with anterior displacement of dorsal dura. Now, Lai et al. Suggested that normal forward dural shift will be 1 to 4.2 millimeters, whereas in Hirayama disease, you will get 6 to 8 millimeters at least. Post-gadolinium flexion MRI will show engorged posterior epidural venous plexus, and in the axial view, you will even find the cobra eye sign. So in the nerve conduction studies, you will find decreased amplitudes and but normal conduction velocity, which is characteristic. And ulnar to median CMAP ratio will decrease. Ulnar nerve is predominantly more involved, and sensory nerve conduction study will be classically normal. F wave latencies will be normal. Various differential diagnoses like amyotrophic lateral sclerosis, cervical spondylotic amyotrophy, and cubital tunnel syndrome, and others can be differentiated based on various other findings as well. The treatment for this has been predominantly based on the conservative management. So cervical collars 24 hours daily has been advised, and it has been seen that 58% of the patients they get better with the conservative management itself. It reduces the venous congestion, strengthens the muscles, and also causes the relief of muscle weakness. And also it has been seen to relieve the cold paresis as well. In the surgical part, many procedures have been described and successfully described as well. Along with that, from a plastic surgeon's point of view, till now only one case report of AI and supercharging has been described in this, and few cases of tendon transfer. So the take-home message is that a young Asian male with pure motor symptoms, with a ulnar claw hand, suspect a Hirayama disease also, because it is something that will be taken care with the conservative management itself. So high index of suspicion is needed, and neck flexion MRI and electrodiagnostic study is the mainstay after clinical suspicion. Patient compliance is an issue in this all these cases. And thank you for inviting. And I will leave up the stage with this slide showing Hewasian criteria for Hirayama disease. Thank you.
Thank you, Dr. Omkar. We would like to invite any questions from the audience.
There are no sensory symptoms at all in this.
So as I showed, classical Hirayama disease by definition says that there are no sensory symptoms, but there have been reports that sometimes atypical findings may have sensory involvement as well, but the explanation for sensory involvement has not been given, because I know where it is coming, that anterior horn cell involvement with but I have searched a lot. They have only reported, actually this disease itself is under research type of disease, like not much of the research has been done. So they have mentioned that even the pyramidal signs or the sensory deficits, they have said that they come in the atypical findings compartment. And if you see, it has been classified into type 3 according to the Hewasian criteria.
Yeah, because you initially told that sensory dryness is there.
Yes, sir.
So if dryness is there, motor deficit is there, then first thing in India, we think of leprosy only.
Yes, sir. Yes, sir.
Because I know this Hirayama disease comes as a good differential diagnosis of anterior horn cell disease.
Yes, sir.
Or motor neuron disease.
Yes, sir.
One of our motor neuron disease patient, when we sent for MRI, the MRI people told that it is a finding classical of that.
Yes, sir.
Yeah, but if sensory features are there, then it is a bit awkward.
Yes, sir. Yes, sir.
Thank you.
Thank you, sir.
So, a wonderful presentation.
Thank you, sir.
Now, since the diagnosis is doubtful, so we have to be very cautious in operating on these patients, because once you operate on these patients, then you have the moral and legal responsibility of him having an improvement with your surgery. So, I want to ask you, are there any predictors of success after surgery in this disease? In which patients you can say that yes, surgery is going to be beneficial?
Yes, sir. So there are 2-3 things in it. The first thing is that for most of all the patients, almost they initially the people who have studied this disease, they have initially opted for a conservative management. So non-compliance of conservative management, no improvement of in the conservative management, plus who are more than 1B. If you see like 1B with non-compliance, or more than 1B category people, they have opted it for surgery. The surgeons have told that 1B patients who are non-compliant, as well as category 2 and category 3, these patients are the people who need surgery.
No, no, no. I'm not asking. My question is
Yes, sir.
very specific. Are there any radiological or clinical criteria by which you can identify those subset of patients who can benefit from surgery?
No, sir. It is radiologically, there are no such criteria per se to say that okay, this patient will benefit from surgery. It is based on whether there are any atypical signs. Based on that, they have classified it as 2 and 3, and they have subjected them to surgery. But as such, there are no pinpointers like, okay, this patient will benefit from surgery, this patient will benefit from conservative management. Even if you see conservative management, the review says that 58%, only 58% have shown good positive results with conservative management. And the most important thing is they have found that with the conservative management, they have to wear that brace to maintain the neck in neutral. And so the social issue comes into picture. And so the non-compliance comes into play when compared with the surgical management. So many of them, there is still a dicey role. Many of them say that it is better to operate. If the patient is non-compliant, it is better to operate. But as such, in the literature, I have not come across any predictors to say that, okay, this patient will undergo positive surgery, sir.
Anyway, lastly, one last question is,
Yes, sir.
how much is the success rate, if at all the patient responds to surgery, according to you, how much is the success rate of surgery?
Sir, they have not mentioned a percentage, but they have said that it is well established that with surgery also they give good results, and the results have been good even with plastic surgery. Like for instance, the AIN supercharging. Only one case has been reported, but they have said that even that patient responded well. And even the spinal procedures, most of them, those who have done even with the posterior as well as the anterior approach, they have said that they have got good results. But as such, the percentages are not available, sir.
Very nice presentation. I
Thank you,
just
sir.
want to add some points.
Yes, sir.
First of all, this disease is self-limiting.
Yes.
It progresses for 3 to 4 years. After that, the progression stops.
Yes.
But the key point is the damage done during those 3-4 years is permanent.
Yes.
So in those 3-4 years is the role of neurosurgical or surgical procedures, when many types of surgical procedures have been tried. So till date, the role of surgery is not proven. So answering Dr. Sumit's question, so once we have to prove that surgery is helpful, only then we'll come to the second question: what is the rate of improvement, or what are the predictors which can predict that the patient will have a better outcome following surgery?
Yes, sir. Thank you, sir. Thanks a lot. Ma'am.
But so far we have been treating it as a Madras variant of Ispnscon. But depending upon the reference from the neurologist, I think depending upon the reference from the neurologist, we end up with the diagnosis of Hirayama disease. And with Nimhans has a huge series of anteriorly fixed Hirayama disease. Most of these are young males, and they are confined to certain regions in India. They are quite common from West Bengal referrals, and then the North Karnataka also has quite a bit of these cases. Then what we have found is when it is early cloying, it gets stabilized. It doesn't revert. It doesn't revert. So instead of putting the patient on neck brace, which will further worsen the condition of the neck muscles, better to do anterior fusion. Usually it is C5-6. We do anterior discectomy, and with or without fusion. You need to basically stabilize them so
Yes,
that the flexion extension does not change the dural impingement. And we have also done post-op scans, and we have shown that the posterior impingement with the dura has come down. So I think that we should address the basic problem in the cervical spine with its impingement rather than the peripheral treatment.
Yes, yes, ma'am. And also, I would like to add that as ma'am mentioned, Nimans, Gauri Devi disease, which was described by Gauri Devi ma'am, yeah, from Nimans again, it has been another differential in this where the proximal involvement is more as compared to the distal, whereas Hirayama shows the distal involvement is more as compared to Gauri Devi ma'am's disease, which involves the proximal, just to add that. And yes, that is a perfect pinpoint that it is always better to treat the root cause rather than jumping around in the periphery. So it has been proven that this main address used to be in the cervical spine itself. Yes.
May I suggest that this paper be ended because too much time is spent.
Okay. Yes.
So
Thank you, sir.
let me invite Dr. Deepak Krishna for his paper on tendon transfers for wrist and fingers in BPI. You get 8 minutes plus 2 only.
Good morning to chairpersons and all the audience. I am Dr. Deepak Krishna. I am here presenting some cases over the tendon transfer for wrist and fingers in brachial plexus injury. So the patient with upper extended brachial plexus palsy may be presented with 5 to 7 or many times, sometimes 5 to 8 palsy. And in these cases, the wrist and finger extension is absent along with the radial abduction of thumb. And why we need to correct? Because of the even presence of the flexor of the fingers, thumb and wrist, the hand grip is not adequate because the wrist is falling down position and flexion position. So for hand grip, the wrist is extension is must, and the span of the hand is also less because to holding the objects, we need to fully opening of the hand. And next question is the why to correct the deformity because the recovery of the hands and took times in extended upper plexus palsy injury. The options are early nerve transfer, just like branch of the FDS or pointer quadratus or PT, or delayed tendon transfer when the spontaneous recovery doesn't happen. And so what is the difference? Because why this is different from the other injuries, other radial nerve injuries? Because in brachial plexus injury, when the lower root 5 to 7 or 8 is involved, the presentation is very variable. Sometimes wrist is not there, extension is not there, sometimes finger is not there, sometimes EPL is functioning, sometimes not functioning. And the availability of the donor muscles in the flexor compartment is also very variable. Sometimes the FCR or FCU is weakened or frontal teres is not good in conditions because these muscles are recovered many times, not in full strength, and all muscles are not functioning. So this is different from the high radial nerve palsy in which the results are good. So for these types of patient, the solution we may follow the standard. Either we have to follow the standard protocol for high radial nerve palsy, standard FCU transfer, FCR, or voice superficial transfer, or we need to customize our method according to the presentation of the patient and availability of the donor's muscles in the forearm. So with these problems, we try to prospectively analyze patient in last 2 years. We have did 10 patients. We are not doing many cases for brachial plexus injury, but In 2 years, we did 10 patients for this upper extended brachial process for tendon transfer. Patient with upper extended brachial process with failure to recover or partial recovered wrist and MCP joint extension after 2 years of injury were included. And after detailed history and examination, hand function patient were categorized into 3 groups. In first group, we included the patient with have normal hand flexors, either from the initial part of the injury, they have good flexion of the hand, or later on they recovered fully. And second group in which the some weakness in the hand flexor with no extension of the wrist. And third is the partially recovered wrist or finger extension with normal or weak flexors. So we analyzed the 10 patient in this study. So the type 2, case 1 is the type 2 type in which the all extensor are deficit except the EPL. And on examination of the donor muscle, FCR, FCU, PT, and palmar longus, all are M0. Only the finger FDS and FDP is functioning. So we categorized into group 2 and did the FDS middle finger for ECRB and FDS of ring finger to EDC by intraosseous route. Because EPL is good, so it doesn't require the PL to EPL. In type 1, all extensors in case 2, wrist and finger extension were absent and all the donors flexor are normal. So we categorized into type 1 and did the standard FCR transfer, PT to ECRB, FCR to EDC, and PL to EPL. So these patients would excellent result in linkage score. Another type 2 patient in which all extensor are involved, but FCR is M0 and PT is M3, FCU M5, and PL is M5. So in this patient, only FCU is functioning, so we didn't take FCR and categorized into type 2 and did FDS of middle finger to ECRB and FDS of ring finger to EDC and PL to EPL. So we need to customize our technique according to the ability of the donor side muscles. And case number 5, in which 2 years male with weak wrist and finger extension. He recovered, but there is a weakness of the wrist and the fingers, and other all flexors are normal. PL is absent. So in this patient, we did FDS of middle finger to ECRB and FCU to EDC and FDS of ring finger to EPL. So he gave some good results. So another type 2 patient, 40-year male with all extensors except the EPL and EIP are functioning. So we did FDS middle finger to ECRB and FDS of ring finger to EDC. Another patient, case number 9, in which the EPL, EIP, and ECRB all are okay, but EDC and EPV are weak, and there is a radial deviation of the wrist also, because the MCU is M1 and others are M5. So in this patient, we do PL to EPV because the EPV was weak and there's a flexion of the MCP joint. FDS of the middle finger to EDC to compensate the deficit of the extensor of the fingers, and FDS of the ring finger to ECU, so that the wrist deviation to radial side will be balanced by this. So tendon were repaired by a pulmonary technique, and both FDS were rotated radially to median nerve. And we did all the standard procedures required in the renal palsy and after tendon transfer. In the case 1, the FDS transfer, you can see in the figure A that the hand so severely deformed that he is not able to open the fingers, and they are very tight even after physiotherapy and delayed presentation. So we did FDS transfer. So we can see this is the presentation of the case 1. The only EPL is functioning. There is no extension of the fingers, and they are so much at the palm level, touching the palm. So we did FDS transfer for wrist and fingers, and this is the post-op result. By seeing the deformity, these results are patient is very happy that at least he is able to open this finger. In case number 2, this is the FCR technique in which the wrist flexor muscles are okay. So we did FCR technique. So this is the deficit. We can see after elevating the wrist extension, the finger drop is more prominent. We did the standard FCR transfer, and this is the post-operative result. This is the group 1 patient. In case number 3, this is also wrist drop and finger drop. And EPL is also not functioning. In this patient, FCR is M0 and PT M3. So we did FDS to wrist and EDC. So this is a pre-op picture. So we did FDS. We took from the forearms, and 4 centimeter tunnel is made at the interosseous membrane, and muscles is going posteriorly. And this is the post-operative result. Initially, the finger flexion is less, but with physiotherapy, it's come back. There's another patient in which partial recovery is there. We did a FDS transfer. So all patients were male and mean age of 27.6 years, and out of 3 cases, out of 5 cases of group 1, results were excellent in 4 and good in 1. Out of 3 cases in group 2, excellent in 1 and good in 2. And out of 2 cases in group 3, excellent or 1 and good in 1. The no feature of median nerve compression deformity in the follow-up period. Discussion in BPI, the potential transfer muscle tendon units are fewer, and they may have achieved multiple functions. And these muscles have been denervated and reinnervated, thus are weaker. So FDS is an important technique in this patient, and transfer of this wrist may be sufficient to antagonize the weaker wrist flexors. So all flexors are tightened. Release of FDC may improve the extension also, and it is very expandable tendons. The tendon transfer for wrist, thumb, finger top must be customized as per the ability of donor side, and FDS transfer is reliable, effective method to ensure wrist and fixed extensor and brachial plexus injury with other where the other wrist flexor are weak and not expandable. Thank you for patient listening.
Any questions from the floor? 2 minutes, maybe 2 questions.
Very good result, Deepak. And did you compare the grip strength of 3 different groups, FDS, FCR, and the FCU?
We come
Both
only
pre-operatively and post-operatively, how it
we
was?
didn't see the grip strength with the dynamometer, but we only evaluate with the Winkage score the degree of extension and flexion, and how the fingers are extending and come back to the palm in fixed flexor position. And patient is doing all routine activity, but we didn't measure the strength in this case.
That would add an extra
We can do.
score in your evaluation.
Yes.
Thank you.
Thank you, suggestion, sir.
Dr. Deepak, in your first case, you mentioned that there was a problem with the passive range of motion also, despite the radio physiotherapy.
Despite the long
So
duration.
did you not consider any release procedure before your tendon transfers in that case?
The flexors are tightened so much, but after FDS release, they become lax. So both the benefit is there. The wrist extension and fingers is also coming, and the flexion is also relaxed in this case. So, and some cases ulnar weakness is also there. So interosseous and are also tightened. So it is many times it is difficult to correct, but it improved by the FDS transfer.
I think, thank you, Dr. Deepak.
Thank you, sir.
We would like to invite the next speaker, Dr. Anuj Tiwari, for his presentation.
Good morning, sir. I would like to start my presentation that I'm discussing traumatic brachial plexus injury experience from a neurosurgical point of view in our Department of Neurosurgery, AIIMS Bhubaneswar. So basically, we all know that traumatic brachial plexus injury occur in polytrauma patients, and most of them are post RTA patients, sir. And they generally affect a young group of male patients and in the prime of their life, leading to a devastating flail limb, leading to functional impairment, physical disability, and a social economic burden and psychological disorders. So basically, we focus on functional recovery as early as possible in these prime group of patients, sir. So I'll be discussing 4 case scenarios which we manage in our department. So first one is a right pan brachial plexus injury, 26-year-old male post RTA presented to us in October 23 post 3 months of trauma. He was a post ganglionic injury. On clinical examination, he had a right upper limb flail upper limb and 0/5 power in all joints. And case of polytrauma with right radius fracture and acromial dislocation. On pre-op clinical video, we can see that the patient is having a right upper flail limb with 0/5 power in all limbs. On pre-op MRI, we can see that there is a pseudomeningocele present over the C7, C8 level. And on nerve conduction study, it showed a post-ganglionic pan-brachial plexopathy. So for this patient, sir, we went ahead with the right spinal accessory now to supraclavicular approach with intercostal to musculocutaneous nerve transfer. As you can see that there is the first case SAN to SSN anastomosis is seen, and the second, in the same setting, we did a fifth intercostal nerve to musculocutaneous anastomosis. In the second case, sir, it is a left pan brachial plexus injury. Patient 55-year-old male post RTA presented to us after 5 months in November 23. And on clinical examination, patient had a left upper flail limb with 0/5 power in all limbs, all joints. On clinical examination, we found on evaluation that patient has a left middle 1/3 clavicular fracture. Hence, we opted for a dorsal approach for this patient and did a stage procedure in this patient. Sir. Clearly, we can see that the left clavicular fracture is seen. Since this was the first time we were approaching dorsal approach, first time it was a dorsal approach, so we went ahead with the cadaveric dissection in our anatomy hall. Delineated the anatomy and the nerves, and then went ahead for the surgery. Did a left spinal axis nerve to suprascapular nerve dorsal approach. With the surface marking, we can see that we marked the middle border of scapula along with the incision over the middle border of scapular spine to the left acromion process. Medially, delineated the spinal axis nerve and laterally delineated the suprascapular nerve. So intraoperatively did a SAN to SSN anastomosis, and in the next stage procedure, we went ahead with the intercostal to musculocutaneous nerve. Third case is a left pan brachial plexus injury patient, sir. 21-year-old male who presented after 6 months of trauma. Patient had 0/5 power in shoulder and with 0 abduction degree, and 0 power in elbow, and had pronation supination 2/5 power by MRC grade and wrist 3/5 power. This is a pre-op clinical video of the patient, sir. We can see that the patient is attempting elbow flexion but could not do it, but wrist 3/5 power is seen with good power. We did a less spinal accessory nerve to suprascapular nerves, supraclavicular approach with oberlin 1 nerve transfer in this patient, sir. Supraclavicular L-shaped incision and anastomosis can be seen. And this one's the oberlin 1 neurotization, in which ulnar nerve is neurotized to the musculocutaneous nerve biceps branch. So on follow-up, sir, we see on 6 months follow-up, we see that there's a marked improvement in the elbow flexion. And on 4 years follow-up, we can see that primary action of elbow flexion is almost recovered with good improvement in shoulder abduction, approximately 20 degrees. Fourth case is a right upper trunk partial brachial plexus injury, sir. 24-year-old male who presented to us post-trauma after 4 months, admitted in this November 2023. And patient on clinical examination had an extension of elbow, 3/5 power on MRC grading, and hence we planned for a triple nerve transfer in this patient, sir. On pre-op clinical video, we can see that patient is having elbow extension, 3/5 power, and pre-op CT myogram was suggestive of no pseudomeningocele on evaluation. And we planned for a triple nerve transfer in this patient. 3 anastomosis done, that is spinal accessory nerve to suprascapular nerve and oberlin 1 and 2, and Somsack nerve transfer was done in this patient, sir. So basically, supraclavicular L-shaped incision was given, and for oberlin middle 1/3 biceps groove incision given, and Somsack position patient supine with the forearm over the thorax. Yeah. This intraclinical video photo, we can see that the median nerve to brachialis branch as well as ulnar nerve to biceps branch anastomosis done with in Somsack procedure and long nerve to long head of triceps anastomosis to the anterior branch of the axillary nerve. So these are the 4 different type of scenarios, sir. In department since 2018, we have done almost 11 cases in our department, consisting of both partial as well as pan-brachial plexus injury involving the partial brachial plexus injury involving the upper trunk, and attempted recovery of both shoulder as well as the elbow joint. Of the 11 cases, 1 case who was a 20-year-old male who presented with approximately at 6 months, had a good improvement in shoulder as well as elbow flexion. And pre-op and post-operatively, we are comparing all patients using the DASH score, that is the disability of arm, shoulder, and hand, with post-operative as well as a visual analog scale, pre-op and post-op. And we saw 2 patients having a good outcome. One, as I showed the pre-op and post-op clinical video, having good elbow flexion, and the second patient basically had an improvement in post-operative neuropathic pain post-operatively. So total, we have done supraclavicular 8 approach for SAN to SSN, SAN to SSN, dorsal approach 1, Somsack nerve transfer 1, oberlin technique 1, 6, oberlin 2, 2, and in intercostal 2 musculoskeletal 4 cases. Thank you.
The paper is open for discussion. 2 questions. We have 2 minutes time.
Two questions. The pan-brachial plexus palsy, you have used both the spinal accessory and intercostal nerve. So what you are going to do for the hand in the future? Which nerve you are going to use? Second question, case 3, you showed that the patient is having good elbow flexion after ulnar fascicles to musculocutaneous nerve transfer.
Yeah.
The number of fascicles that is transmitted along the coaptation side will decrease if you take a single fascicle and connecting to the whole length of the musculocutaneous instead of muscular branch of the biceps. And the elbow flexion should come with the supine position, but the patient is having flexion in the prone position. So probably he is flexing with the help of the brachioradial. This is not with the biceps. So these 2 questions.
Yes, sir. Actually, post surgery hand for hands, sir, we have seen that post brachial plexus neurotization hand recovery is not significant. So usually, with the help of plastic surgery, we go ahead for tendon transfer, sir.
No, so but at least you should keep one nerve left for the future FFMT. That's what my question is.
Okay.
If you are using both the spinal accessory and intercostal, which nerve plastic surgeons will use? The second question, the case 3, that the patient is having good elbow flexion, is using it in the prone position, prone forearm, not with the supine forearm. So probably he is using it by the brachioradialis, not by the biceps.
Yes, sir. In this video, actually, it is there, but on clinical examination, we saw that there's good improvement basically in this case.
Yeah. In case 4, it was a nice presentation. In case 4, you showed that there is a triceps 3/5, and you did the Somsack.
Yes, sir.
So what is the recommendation actually for that? I just want to know.
Sir, actually, 4/5 power, according to the books, it is written, sir. So, but since we attempted on a 3/5 power, and we'll see, sir. We just operated the patient like 3 months ago.
Okay, thank you.
Yeah.
CT myelogram.
Yeah, sir.
Why was CT myelogram?
Sir, actually, 4 years ago, patient had another trauma case and had a bipolar over the hip. So it was not MRI compatible. That is why we had to do a CT myelogram in that patient.
If that's it, thank you, Dr. Anuj.
Yeah.
Now we call upon Dr. Abhijit for his presentation on functional nerve outcome of peripheral nerve schwannoma, experience of management at tertiary care center. Dr. Neeraj, is Dr. Neeraj available for his presentation?
Good morning, respected faculties. Myself, Dr. Abhijit. I am an MC Senior Resident from the Department of Burns and Plastic Surgery. Today, I am going to present a paper regarding the functional outcome of peripheral nerve schwannoma, experience of management at a tertiary care center. So we know schwannomas are one of the common peripheral nerve tumor occurring in an adult, and they are benign, isolated, non-invasive, and encapsulated tumors without any sex predilection and mostly occurring in the fourth decade of their life. Although various presentations are there, most common significant presentation is pain. And MRI is one of the most common or most useful diagnostic imaging modality, which also helps to rule out and relation between adjacent structures. Histopathological evaluation and immunohistochemistry is of paramount importance, not only to diagnose, but also to exclude other differential diagnoses. and main treatment for the same is surgical enucleation. So this study helps to assess the functional outcome after surgical excision of all cases of peripheral schwannoma, and is a retrospective analysis of all surgically treated cases of schwannoma presented to the Department of Burns and Plastic Surgery during the period of September 2021 to September 2023. That is 2-year study period. So all the patients are being assessed, both motor examination and sensory examination is being done. Motor examination is done and it is being classified according to British Medical Research Council scaling. And sensory examination of the upper limb is graded using modified and simplified Hitchens classification, whereas lower limb sensory grading is done using BMRC scale modified by Omer and Dellen. And the preoperative evaluation of the patient consists of anamnesis, physical examination of the tumor, superficial sensory function assessment, which include examination of the touch, pain, and sensory discrimination. And the muscle tone and strength examination is also being done, as well as Hoffman-Tunnel sign is also being elicited. So this was the summary of the result of our patients. So during this study period, we got a total number of 8 patients. And out of 8, 7 patients were male and 1 was a female patient. And the youngest patient was of 12 years and eldest was 63 with a mean age group of 40. And 7 patients presented with solitary tumors and 1 patient had multiple swellings. 1 patient was a recurrent case. So this is a pie chart diagram showing the location of schwannoma. So 3 patients had schwannoma arising at the arm level and 2 patients each had swelling arising at the forearm and leg level. 1 patient each had schwannoma at the thigh and toe level. So this is another diagram which is showing the various nerves which is affected with schwannoma. Out of 8 patients, 3 patients had schwannoma affecting the main radial nerve, and 1 patient had median nerve schwannoma, and 2 patients had schwannoma arising from cutaneous nerves, and 1 patient each had schwannoma arising from saphenous nerve, sural nerve, and digital nerve. And this bar diagram shows the various indications for surgery. Out of all the patients, all the patients had swelling as one of the complaint. And other than that, 5 patients also had significant pain, as well as 2 patients had numbness also. Moving on to each case. This is the first case where the patient presented with schwannoma arising from the left radial nerve. So intraoperatively, we were able to separate the tumor from the radial nerve, and postoperatively, and we were able to access the entire tumor without causing any damage to the nerve. And this is the immediate 2 weeks follow-up video of the same patient.
You may please move on with your presentation.
Sir. This is the second case of radial nerve schwannoma, which is also of almost at the same site. And this patient had a lot of diagnostic dilemma preoperatively, because this case was referred from another department to us. And they did a true cut biopsy for the patient, and the histopathology came as epithelioid hemangioendothelioma, which is one of the malignant form of vascular tumor. So we also thought how to proceed for this case, because MRI was showing schwannoma, whereas preoperative biopsy was showing a malignant vascular tumor. So we thought of proceeding with a review of the slide, which came as few component of schwannoma along with some of the fibroinflammatory as well as blood cells in the smear. So with the due consent for excision of the radial nerve, we have taken the patient to OT. And intraoperatively, we found that this tumor is arising from the radial nerve only and encasing few of the fascicles of the radial nerve. But there was no intraoperative picture to suggest that the tumor is malignant, because all the surrounding structures were intact. There was no local invasion or anything. So we have excised the tumor with excision of the involved fascicle, and the defect was repaired with sural nerve cable grafting. This is another video, postoperative video of the same patient. 10 days as well as after 4 months follow-up. This is the follow-up video of the same patient after 4 months. We can see all the function of the radial nerves are being preserved. This is the third case of radial nerve schwannoma, which is reported by a female patient on the right side, almost at the same side. And this was also intraoperatively, the tumor was found to be arising from the radial nerve without any local infiltration, and the tumor is being excised, preserving the radial nerve intact. This was the fourth case of radial nerve schwannoma arising from median nerve. So it was also a large tumor which is arising from the right median nerve. So we were able to remove the entire tumor without causing any damage to the median nerve. And this is in the inset is the video of after 2 years follow-up, and patient is maintaining all the motor as well as sensory function of the median nerve. This is the next case of schwannoma arising from one of the sural nerve. So in this patient, we found to have the tumor which is engaging one of the fascicle of the sural nerve. So we have excised the tumor, and the defect is being reconstructed with venous graft, vein graft taken from the dorsum of the foot. This is the next case of schwannoma, which is arising from the saphenous nerve, and the tumor was excised, leaving behind the fascicle intact. This is the next case where same patient had schwannoma arising both from the cutaneous nerve as well as from the digital nerve, and both the tumors are being excised without causing any damage to the nerve. This is another schwannoma case arising from the left anterobacular cutaneous nerve. So this is a tabular representation showing the summary of all the treated cases. So in this, we can see that the first radial nerve schwannoma case preoperatively had a sensory evaluation score of S4. In the postoperative period, that patient had S3 plus and S3 plus. This is the same patient where we had diagnostic dilemma with confusion regarding malignant tumor. And the next radial nerve schwannoma initially preoperatively had an S4 function, and postoperatively it is initially S3 plus, but later after 4 months of follow-up, it is now normal. And another sural nerve schwannoma initially preoperatively had a sensory function of S4. Later in the initial period, it was S3 plus in the initial postoperative period, but later it is S4 only. And this patient with the cutaneous and digital nerve schwannoma preoperatively had a sensory function of S3 plus, but after surgery, it came back to S4. And saphenous nerve schwannoma patient also had a preoperative sensory dysfunction of S3 plus, but in the late follow-up period, the patient also recovered to S4. And none of the patient developed any kind of complete motor paralysis after the surgery. This is a tabular representation of the functional outcome of the patient. So postoperatively, one patient only had mild motor weakness. So none of the patient had any kind of permanent motor deficit, and 4 patients had initially some kind of sensory deficit in the immediate postoperative period, and 1 patient developed a late postoperative deficit. Till now, none of the patients reported a recurrence of the swelling, and no patients developed any kind of other complications like seroma, hematoma, or wound infection. So management of peripheral nerve tumor is connected with the risk of some kind of complications usually, and mostly improvement in the nerve function is achieved, and onset of new persistent postoperative deficit is rare. Slow growth pattern allows for the adaptation of nerve function to the pressure effect. However, at a certain point of their growth, most of the tumor will become symptomatic, and surgical excision of the tumor is the definitive management of schwannoma. So on concluding, most common location of schwannoma is being extremities, and most commonly involved nerves reported are median nerve and ulnar nerve. But in our series, we had radial nerve involvement as the main site of involvement of schwannoma, and surgical intervention is recommended in symptomatic patients like those who are presenting with severe pain, sensory disturbance, or even swelling also. And with technical precise, we are able to excise the schwannoma without causing any kind of functional deficit. And the risk of new permanent postoperative neurological deficit in schwannoma is low. Thank you.
Thank you. The paper is open for discussion.
In how many cases?
Very beautiful demonstration. In how many of your cases you couldn't separate the tumor from the vesicle? Did you encounter any such case?
Sir, there was only one radial nerve schwannoma case where the tumor was completely encasing one fascicle. So that tumor was excised along with that involved fascicle. In another case of sural nerve schwannoma also, tumor was encasing one fascicle. So these were the 2 cases where we are forced to remove the tumor along with an involved fascicle. Remaining all cases, we are able to separate the tumor from the entire nerve.
So did you do some nerve stimulation to?
Sir, intraoperatively, that radial nerve schwannoma case we did intraoperatively. So there was no muscle movement. So we expected that will be a sensory component. So we have remove the tumor. So before surgery itself, we told the patient that there is a diagnostic confusion because biopsy is showing vascular tumor, but your MRI is showing schwannoma. So intraoperatively, we will see, accordingly we will proceed. But fortunately, this patient developed very good functional outcome because the involved fascicle was sensory segment only, and that defect was repaired with sural nerve cable grafting. So postoperatively, complete motor recovery has happened, Sensory till now follow-up, it is S3 plus, but patient is very well comfortable, sir.
Yes. Did any one of them have long-term neurologic pain, neuropathic
No,
pain?
sir, no patient developed any kind of sensory disturbance. And in fact, 2 patients who had sensory disturbance like severe hyperesthesia before surgery, now after the surgery, they have recovered from that severe pain on touching. So they are very happy.
Thank you.
Thank you, sir.
Did you use the microscope for the dissection?
No, sir, it is being done under loop, sir.
Maybe microscope would.
Sir,
improve
that
the
one case of
ability to-
radial schwannoma where we had a diagnostic dilemma, that case we used microscope,
that's
sir.
good.
Yes.
And how many patients you had preoperative tissue diagnosis?
Sir, actually, we used to do tissue diagnosis for all the patients except this cutaneous and sural nerve surface. All those patients, we did imaging studies only because one was a child, he was not willing for FNAC, and other were cutaneous swellings like it's from sural nerve. So remaining all this radial nerve, median, everything we proceeded with preoperative tissue diagnosis, sir.
And this patient with multiple schwannomas, did he have this neurofibromatosis?
No, sir. This patient never, like, he had no other features of neurofibromatosis, and all this histopathology report of previous excision, everything came as schwannoma only. He didn't have any other features of neurofibromatosis per se, sir. And no family history also, sir.
Thank you, Dr. Abhijit.
Thank you, sir.
And that brings to conclusion the session on award papers. And thank you, organizers, and thank you, delegates and the presenters.
Thank you so much, faculty, for chairing this session.
We'll be announcing the results for the award session and during the inauguration session. Thank you, everyone.
Next session is on preoperative diagnostic evaluation. I would like to request Dr. N.K. Bodhe, Dr. Satyakam Barua, Dr. Ravi Kiran Nalla, and Dr. Deepti Gupta to kindly come and chair the session on stage.
So are we ready? Okay. So with many thanks to Dr. Shamin, Dr. Anil, the hosting team here, and the Society for Peripheral Nerve Society, along with my co-chairpersons here. A very good morning to you. We'll be starting the second session, which is on preoperative diagnostic evaluation. So my co-persons Ashish Tandon, Satyakam Barua, and I'm sorry, this is change in that. So Ravi Kiran Nalla. So the first session, yeah, Dr. Deepti Gupta. Okay, sorry, ma'am. Actually, this thing is changed. So we'll start with the sessions progressing from anatomy, clinical evaluation, the EP study, MRI, and followed by case-based discussion. So the first session will be taken by Dr. Soumitra Trivedi, Additional Professor of Anatomy at AIIMS Raipur. He'll be dealing with overview of brachial plexus anatomy. So, Dr. Soumitra, please.
A very good morning to all the respected dignitaries, faculty members, and delegates. I'm Dr. Soumitra Trivedi, and I'm going to present just an overview of brachial plexus. All of you are senior doctors, so I'm not going to tell you anything extra. It is just brushing up of anatomy that you already studied earlier. The first thing when we enter the anatomy department, or after a few times of lectures, the first thing that we get actually noticed, or what we remember in the anatomy, or what I remember, like we used to follow that for the clinical anatomy, was the porter's tip hand, or the waiter's tip hand, or the policeman's tip hand, right? These are some of the things which are related with the brachial plexus, which get noticed first of all. And these are diagrams I guess all of you must be remembering, which are related to the Erb's paralysis, or the clump case paralysis, when you're falling from a height or something falls on your shoulder, right? Or when you're falling down, you're holding a branch of a tree. So these are the things that we always they are told in the anatomy that is going to be causing a brachial plexus injury. But the most common cause are the road traffic accidents, or the trauma caused due to the road traffic accidents, which are causing the brachial plexus injuries. But I'm not going to discuss the clinical over here. I'm just going to discussing about the basic anatomy of brachial plexus. So first thing with the to start with the plexus is that to know what is a plexus. So first of all, there's a spinal nerve which is going to be arising by the motor and the sensory root. That is the ventral and the dorsal root. The dorsal one being the sensory and the ventral being the motor. They join to form the spinal nerve, which further divides into anterior ramus and the posterior ramus. And all the plexuses which are getting formed, they are formed by the anterior ramus, never by the dorsal ramus. Right? This nerve is formed in the interventral foramen, which passes out through the various ligaments, especially the superior and the inferior transforaminal and the ligamentum flavor at the posterior side, right? Joined by the interforaminal ligaments, right? It comes down and they form the spinal nerves. Typically, spinal nerves are from T3 to T9. Above that and below that, they are all going to be forming plexus. Basically, 4 plexus where we know that are existing in the body: cervical plexus, brachial plexus, and lumbar and the sacral, commonly referred to as the lumbosacral plexus, which is also involving the first coccygeal nerve. Right. Right now, we are just going to be focusing on the brachial plexus. So, brachial plexus, it is going to be formed by the lower 4 cervical and the first thoracic nerve. Sometimes you find that the components of C4 are going to be more in the formation of brachial plexus. In that case, it is referred to as the prefix. And sometimes the components of C5 are negligible and the components of T2 are more. In that case, it is referred to as the postfixed. Some part of this brachial plexus lying above the clavicle, which is referred to as the supraclavicular part of the clavicle, supraclavicular part of the brachial plexus, and the part which is lying below is the infraclavicular part. Branches which are arising from them, from the supraclavicular part and the infraclavicular part, they are very important. When it is coming down, when it is coming down, it is basically passing between the 2 scalene muscles, scalenus anterior and the scalenus medius. Most of the fibers, they are piercing the scalenus medius muscle also when they are coming down, right? And these muscles, as we know, they are covered by the prevertebral fascia. So when these are coming down, they are dragging around with them the prevertebral fascia, which is forming a covering around the axillary artery as well as the brachial plexus. That is referred to as the axillary sheath, which is covering both these structures. The lower part of the brachial plexus is related with the first rib. It is lying on the first rib, right? And they are forming an intimate relationship with the axillary artery. we actually name the chords of the brachial plexus later on with their relation with the relation with the axillary artery, especially the second and the third part. Right. Now, as they come down, before normally the branches which are going to the muscles of the pectoral girdle or the upper limb, only those we are referring as a branch of the brachial plexus. But there are other branches also which are given by these nerve roots from C5 to T1, right? So some of them branches that we already know. One is the branch to the phrenic nerve. Like phrenic nerve is formed by the branches which are coming from C3, C4, C5. So C5 is also taking a participation in the formation of the phrenic nerve. And phrenic nerve has to be very clearly demarcated from the branch of brachial plexus, because this nerve you are going to be seeing running in front of the scalenus anterior muscle, right? Whereas the branches of brachial plexus, they were rising between the scalenus anterior and the medius muscle. Then there are some muscular branches to the longus colli, which is again a prevertebral muscle. Branches to the scalene muscles, right? Scalenus anterior, scalenus medius, and the scalenus posterior. And obviously the first intercostal nerve. As we mentioned that T1 is taking participation in the formation of brachial plexus. That doesn't mean whole of the T1 is going to the formation of brachial plexus. The one of the smaller branch, it is going to be running in the first intercostal space as the first intercostal nerve, right? And one more nerve which has to be clearly demarcated from the branch of brachial plexus, which is important, as you earlier mentioned in some topics also, that is the spinal accessory nerve. Spinal accessory nerve that is seen running posterior in the posterior triangle of the neck. It appears at the nerve point deep to the sternocleidomastoid, runs downwards and backwards, and it disappears in the deep to the trapezius. So that is one nerve which is going to be later, but that is a cranial nerve. That has got nothing to do with the brachial plexus as such. So the brachial plexus, when it is formed, it is going to be having roots. So 5 roots are there, C5 to T1, right? After the roots, the upper 2 roots, C5 and C6, they unite to form the upper trunk. The middle one continues as the middle trunk, and the lower C8 and T1, they unite to form the lower trunk, which further divides into anterior and posterior divisions. And now anterior division, or we can say ventral division of the upper 2 trunks, they unite to form the lateral cord, right? Posterior divisions of all the trunks, they unite to form the posterior cord, and the anterior division of the lower trunk, it continues as the medial cord. And further, we are going to be saying that these cords are going to giving some collateral branches and some terminal branches. The collateral branches given by the lateral cord is just 1, and rest posterior and the medial cord, they are going to be giving 3 collateral branches, and rest 5 terminal branches are there. So just in short, we have discussed that some supraclavicular nerves are given that we already discussed, right? Okay. And some infraclavicular nerves which are given, those are going to be, so supraclavicular nerves are going to be those which are going to be given before the divisions, and infraclavicular nerves are those which are going to be given after the divisions, because division, if you're going to be seeing, that is going to be lying deep to the clavicle. So from the lateral cord, we actually have 3 branches: lateral pectoral nerve, lateral root of median, and the musculocutaneous nerve. From the posterior cord, we are going to be having 5 branches in total: upper subscapular, lower subscapular. In between them, you are going to be having thoracodorsal, axillary, and the radial. And from the medial cord, you're again going to be giving 5 branches: medial pectoral nerve, medial root of median, medial rotation of the arm and forearm, and the ulnar nerve. I think I've taken too much time. So just branches of the dorsal scapular nerve is going to go backwards. It's going to be running deep to the levator scapulae muscle, and is going to supply the levator scapulae, rhomboides major, and the minor. Long thoracic nerve, it runs over this is the only nerve which is going to be running superficial to the serratus anterior muscle. It is going to be supplying the serratus anterior with the segmental branches, right? It is running behind the middle axillary line. And branches on the trunk are the nerve to subclavius and the suprascapular nerve. Nerve to subclavius is going to be running in front of the subclavian vessel. It is going to be supplying the subclavius muscle from the deeper aspect. And similarly, the suprascapular nerve, it is going to be running in the suprascapular foramen. And further, it is going to be running to the spinoglioid notch. It is going to be supplying the supraspinatus and the infraspinatus. Right? branches from the three cords, medial lateral pectoral nerve. Medial pectoral nerve is going to be piercing the pectoralis minor muscle. It is going to be supplying it, and the pectoralis major, which is overlying it. Lateral pectoral nerve supplies the cavipectoral fascia along with the thoracocriminal artery and the cephalic vein, and it is going to be supplying the pectoralis minor as well as the major. Medial gradation of the arm and the forearm, that is going to be running on the medial side of the axillary artery, and they are going to be supplying the lower part of the arm and the anteromedial side of the forearm. Upper and lower subscapular nerve, right? That is going to be arising from the posterior cord, and is going to be supplying the subscapularis muscle. Upper subscapularis is a smaller division which supplies the upper part of subscapularis. Lower subscapular nerve supplies the lower part of subscapularis as well as the teres major muscle.
Excuse me, sir. In the interest of time.
I'm sorry. I think I've taken too much time to understand that. It's an anatomy lecture. We normally take it for about 45 minutes and 60 minutes. I'm just trying to concise it in 10 minutes. So I'm sorry for that.
You can conclude soon.
So it's just anatomy, nothing else. It's a thoracodorsal nerve, which is going to be supplying latissimus dorsi. Then 5 terminal branches: musculocutaneous, axillary, radial, and the median nerve, which is formed by the median joining of the median and lateral root, and the ulnar nerve. Right? Axillary nerve basically runs in the it runs posteriorly from the posterior cord, and it runs in the quadrangular space, which is formed by the teres major above, teres minor above, teres major above. On the lateral side, it is the surgical neck of the humerus. On the medial side, it is the long end of the triceps, between which it passes backwards, divided into two divisions, anterior and the posterior. The anterior one is the one which is going to be supplying whole of the deltoid, and the posterior division is the branch which is going to be giving a branch to the teres minor also. Right. Then you have the radial nerve, which is going to be running in the radial groove, along with the profunda brachii artery, right? And is going to be giving 3 branches over there before supplying it. One to the long head of the biceps, one to the medial head, and one it is going to be giving the posterior cutaneous branch. Then you have the median nerve, right? Median nerve, which is going to be formed by the median joining of the median root and the lateral root. When both of the roots they join together, they are going to be formed on the lateral side of the axillary artery, third part of the axillary artery, and they are going to be running on the lateral side of brachial artery, which crosses the mid of the at the mid of the arm. They are going to be crossing on the medial side, right? And is going to be supplying most of the muscles of the forearm, except for the medial 1.5 muscle, and is going to be supplying the muscles of the thenar eminence. And similarly, the ulnar nerve, which is going to be running down, and it's going to be supplying the muscles of the medial 1.5 muscles and most of the muscles of the hand.
Dr. Soumitra will
Thank
conclude.
you. Thank you. Sorry for taking that extra time.
So any questions? I have a small question. Whenever we see the diagrams, the brachial plexus is delineated in a single plane. So unless we so once we go
brachial plexus record are available. Their use is very beneficial because it allows systematic recording of all the examination findings, and over serial examination, it becomes very easy for the clinician to compare any change in motor power. We can easily make out atrophy, like the atrophy of the trapezius in this muscle in this patient. Motor power, for grading of motor power, we use the BMRC grade, and it's the most widely used, or rather it's the only grade which we have, but we are using these days is a modification. The original one, M1, in the original scale, M1 was contraction in proximal muscles, while M2 was proximal or distal muscle contraction. But I will tell you that BMRC has been shown to have its own inherent limitations. In a study comparing BMRC grade to normalized torque measurement for elbow flexion and extension in patients with brachial plexus injury, it was found that patients who have been graded by experienced examiners as having BMRC 5 actually had less than 42% of normal strength fulfilled. Another pitfall is that active motion has to be equal to passive motion in order for a patient to qualify for a specific grade. It's not that active motion is present only a small part of the passive motion range. And a grade 4 cannot be assigned unless there is full active range of motion, which is equal to passive range of motion, and there is resistance strength throughout the passive motion. After that, all the muscles in the shoulder, elbow, forearm, wrist, and fingers have to be examined. This chart shows the nerves, their muscles supplied, myotones, we are all aware. I'm not going to discuss the commonly tested muscles. I'll briefly go through the muscles which are commonly overlooked. It is very common, very easy to find to pick a isolated serratus anterior involvement. But when there is global palsy, one may feel the lower part of medial border of scapula, and then the examiner pushes the shoulder back. And if there is posterior movement of scapula, it indicates that serratus anterior is involved. Rhomboids is tested with the patient in this position. The examiner keeps a finger over the rhomboid, and then the patient is told to lift the upper limb off the back. And then the movement, there will be movement of the finger of the examiner in case rhomboids is contracting. Infraspinatus can be examined by adducting the upper arm to the side of the body and placing the forearm against the abdomen. The patient is asked to externally rotate the arm of the abdomen. Subscapularis can be examined by placing the patient's hand on his abdomen, bringing his elbow forward, and having the patient push in against the abdomen. Pectoralis, we all know. Latissimus dorsi can be examined by cough test. Deltoid can be tested. Posterior part of deltoid can be tested by swallowtail test. Flexor carpi radialis and flexor carpi ulnaris have to be tested with the fingers extended and fixed in order to remove the action of finger flexors. For testing flexor distorum profundus, we have to fix the MCP and PIP in extension and test only for distal phalanx joint. For testing flexor distorum superficialis, we have to block flexor distorum profundus by extending all the other fingers apart from the finger which is being tested. I'll skip this in the want of the time. The examination findings which point toward preganglionic injury include the fracture of transverse process or ribs, subclavian artery injury, and presence of Horner syndrome. Findings suggesting of root avulsion injury include constrictive pain in the insensitive upper limb. There might be deficit of scapular muscles, serratus anterior, rhomboidus. Patient might also have Horner syndrome in case T1 root is injured, and there can be vascular injuries. I thank you for your attention, and I would like you to invite for our 26th annual microneurosurgery workshop, which will be hosting next month at AIIMS Delhi.
Thank you, Dr. Kawaljit. That was very nicely and concisely presented. We can take one or two questions if there are.
Thank you.
So we are done with anatomy and clinical evaluation, and then now we start moving towards the investigative part of nerve injuries. We would call upon Dr. Arpit Agarwal, who will be talking about electrophysiology in peripheral nerve injuries.
Repair. मेल से मेल Are you connecting the laptop directly or?
Hello? Hello? Hello?
I think there's some technical glitch here. So by the time that gets thing, I think the next speaker will have to come up. Dr. Richa
I can
Chauhan,
hear you.
or
I can hear
MR
you well
Neurography,
now. Can you hear me?
Assistant Professor in Department of Radiology at AIIMS Raipur itself. As we have already seen from various presentations, MRI plays a very vital role in assessing the neural plexuses as well as the neuronal pathologies, as we have seen in certain cases of schwannoma, as well as delineating the brachial plexus.
So, very good evening to all of you. And I would like to thank the organizers for giving me this opportunity today. And today I will be talking about magnetic resonance neurography. It's a very technical topic if I'll go only with the MRI details and all. So I have tried to keep those things at minimum, the technicalities, and I will try to make the presentation today interesting by showing more cases. And anatomically also, I'll try to show the imaging anatomy of the plexuses and various normal and abnormal nerves I will be showing today. So the talk today will be consisting of the background about the neurography per se, the technique per se, then what are the challenges of the nerve imaging, then brief anatomy of the various plexuses, the signs of neuropathy on MRI, and how various normal and abnormal nerves are seen on MRI. So basically, the magnetic resonance neurography, as the name suggests, it's a tissue-specific imaging for the evaluation of nerves and nerve tracts. So it's not a single technique, but it's a combination of various techniques, and many sequences are done. It's not a single sequence. It's a combination of various sequences which are combined together under the umbrella term of magnetic resonance neurography. So basically, these all sequences, they are optimized to detect the fluid signal, the signal of the water, which can arise from the various components of the nerves. And that those components can be endoneural fluid, it can be exoplasmic fluid, the organelle fluid, the fluid within the mitochondria, etc. And also the fluid that is within the neural sheath, that is within the myelin sheath that is there. So it can be myelin associated water. And because of this, the fluid signal from the nerve, basically we are able to detect the nerve per se on MRI. And this is a schematic diagram where it is shown that the fluid can be from the myelin sheath, from the exoplasmic fluid, it can be from within the organelles, or it can be from the endoneural sheath or endoneural fluid. So basically, the most important fluid compartment, which the abnormality of which the MRI detects, is the endoneural fluid, and it is the most important compartment, and it is the most important fluid structure from where the MRN picks up the abnormal signal, because it's a low proteinaceous fluid and it has a very high T2. So because of which it is bright, very bright, if at all the nerve is abnormal, and it is brightly seen on MRI. And mainly whether it is a compressive process or irritative process, inflammation, infection, or a tumoral process, the most important fluid compartment to be affected is endoneural fluid. And because of that, the MRN sequences are optimized to pick up this abnormal fluid signal. So what is the importance of nerve imaging? We already have electrodiagnostic studies, the electrophysiological studies, but then why to do MR imaging? So the MR imaging is not to replace electrophysiological studies. It is basically complementary to them. There are certain cases where there may be false positive reports on electrophysiological studies, like that of neuropraxia, or it can be the EP studies. They can be difficult to do in the cases of deep-seated nerves, or difficult to access anatomy, or there can be patients with coagulopathy. So in all these cases, the MR neurography can complement the electrophysiological studies. However, there are other imaging modalities also, like ultrasound and CT, on which we can image nerves. But both of these modalities, the ultrasound and the CT scan, they have a very poor contrast resolution. So the MRI is preferred over these modalities. I'll show here by an example. As we can see here, this is the sagittal reconstructed CT scan image, where the entire sciatic nerve is shown right from the origin till the distal end. But this is not the case with all the nerves. Sciatic nerve is a big nerve, so we can very well image like this on a CT. However, the other nerves, the smaller nerves, for example, a superior gluteal nerve or a lateral cutaneous nerve of the thigh, where the nerves are very small, so these nerves cannot be imaged on CT because of the poor contrast resolution of the CT. Similarly, for example, here, this is the median nerve. We can see it here in the forearm on ultrasound very well. But in cases of deep-seated nerves in fatty patients, ultrasound also lacks that contrast resolution, which MRI gives better as compared to other imaging modalities. There are certain pitfalls with MRI also. For example, if the MRI, in MRI, if we are taking a large FOV, large field of view, the signal will be very less. And so a dedicated small FOV will be required for MRN. Then there are not many nerve imaging sequences which are dedicated for neurography. Further, there are many vessels which go parallel to the nerves. The signal of those vessels and the pulsations of those vessels can give artifacts which can affect the nerve imaging. So MRI is also very technically challenging when it comes to the imaging of the nerves. The most important strength of MRN is the greatest soft tissue contrast which it offers, and it is the most important point which actually is giving MRI a plus point over other imaging modalities. There are other potential pitfalls with the MRI, like magic angle artifact, which is at 55-degree angle. It gives a false bright signal from a nerve, which can be seen at many places. For example, in the sciatic nerve at greater sciatic notch, where it courses at an angle. So wherever a nerve is coursing at an angle which is approximately 55 degrees, a false signal can be given from that nerve. And for that, again, the sequences have to be optimized. So coming to the technicalities, the field strength. Since we are imaging a smaller structure, we need higher signal to noise ratio, we need higher contrast resolution, spatial resolution. So we need higher strength of the magnet. So 3 Tesla will always be preferred over 1.5 Tesla MRI. Then the use of higher gradients will increase the sharpness of the image. The RF coils, there are various type of coils, the head and neck coils, the body coils, and the dedicated coils for a particular extremity. So as close the coil to the body or the structure to be imaged, the more nice, the more signal will be generated in the image. Secondly, the positioning. Positioning of the patient within the gantry is very important. So large bore magnets are preferred for nerve imaging because the patient has to be positioned in the isocenter of the magnet. Then there are further various sequences, the optimized sequences for MRN and the other techniques to decrease the imaging time and to increase the spatial resolution, like parallel imaging techniques. So what are the sequences that we use? There are routine T1 and T2 sequences, modified slightly for better imaging of the nerves. The coronal and sagittal T1 weighted sequences, the routine T1 weighted sequences, and the 2D sequence, it is modified with fat suppression for the signal of the nerve to pop out better. So basically a high T2 weighted or heavily T2 weighted sequence with fat suppression and a 3D acquisition is mandatory for MR neurography. Then there can be a diffusion weighted SPIF, PSIF sequence. So it also gives a better image signal, better muscle signal. So this can be added, and contrast is only required if we are suspecting any tumor or any infection. Otherwise, contrast is not required at all in neurographic studies. So the normal nerve signal is T1 weighted signal is intermediate on T1 and hyper intense on T2, and it increases markedly because of the increase in the endoneural fluid, as I discussed earlier. So anatomical consideration, if we see, the brachial plexus can be seen based on these 5 anatomic landmarks. I'll show by the images. This is, we can see at the neural foramen, we can see the roots in the subclavian triangle, or in the interscalene triangle with relation to subclavian artery. We are seeing the trunks here, the upper, middle, and the lower trunk, the divisions at the lateral border of the rib in the relation of the axillary artery. Then medial to the coracoid process, we are seeing the cords here, the medial, lateral, and the posterior cord, and the various branches of the brachial plexus again in relation to the axillary artery at the lateral border of the pectoralis minor muscle. So this is again shown in the example. The roots are shown at these are the 3 trunks which are shown in the interscalene triangle. Then these are the divisions with the relation to the axillary artery at the lateral border of the first rib. Then they are the cords medial to the coracoid process. This is the coracoid process. These are the various cords, and then they are the various branches at the level of the pectoralis minor muscle. So these are the sagittal images where we can see the brachial plexus. It is seen like this. This is a normal T2 weighted FS image, and this is the maximum intensity projection, the MIP image, where we can see that the C5, C6 nerve roots are forming the upper trunk, the C1, C7 is continuing as the middle trunk, and the C8 and the T1 are forming the lower trunk. So this is how the brachial plexus looks on MRI. Similarly, the lumbosacral plexus, I'll show it here in the MRI. This is how it normally looks, and this is how it looks in the maximum intensity projection. So femoral nerve, it arises from the lumbosacral plexus, and it goes to the laterally, and the obturator nerve, I'll take one minute more. The obturator nerve, it goes medially. Similarly, the sciatic nerve, it goes, and it is the biggest nerve, so it can be very prominently seen on MRI. Then what are the signs of neuropathy that we have to see? The size of the nerve, the signal from the nerve, the shape, the fascicular morphology, all these will be changed, and the nerve will be prominently hyperintense on MRI. The muscle signal will be hyperintense, and we differentiate it from myositis, and the surrounding structures will not be altered in cases of neuropathy. So this is an example. This is not myositis, but denervation myopathy of the nerve because of this cyst which is compressing the suprascapular nerve. So similarly, the normal and abnormal nerves, basically based on the size and the signal, we can differentiate. Just few examples. This is an abnormal ulnar nerve. It's thickened and it's more hyperintense here as compared to the radial and the median nerve. Then this is again a thickened median nerve because of a post surgical injury after the carpal tunnel release. Again, a thickened ulnar nerve here. We can see here it's a ulnar neuropathy case. Similarly, ulnar neuropathy case in the distal forearm. The nerve is markedly hyperintense here. A normal sciatic nerve. That's how a normal sciatic nerve looks. A normal femoral nerve, lateral to the femoral artery, here bilaterally. We can see here a normal femoral nerve, the fascicular anatomy on routine T1 weighted images. Penetrating injury, where the sciatic nerve is like this. There is perineural fat inflammation, and the sciatic nerve is also thickened and hyperintense. So likewise, we see various thickening or thinning of the nerves, the abnormal signal from the nerves, and that all can be seen by optimizing sequences, particular innervation changes. Those can be sometimes difficult to be differentiated from myositis, and sometimes there are certain nerves which can be because of the superficial location, they are prone to subtly contraction and they can give false bright signals. So we have to see the clinical picture.
Dr. Deborah?
See the image.
Yes.
Take home message to
Yes.
that it's an
Nice talk is your.
Hi.
The sequence need to
Talk is your.
I think you can, if you want, you can just let the session be over with the case presentations, and then I might be the first presenter of the next session.
Any questions if there are, I'll be glad to answer. Questions from the audience.
I wanted to ask, I wanted to do for telling us there is something called as neurography. I have not heard much.
Can you please repeat the question?
Yeah. So if there is a brachial plexus injury or if there is a trauma patient who has come with a cut wound, we have to specifically tell that do MR venography or that particular.
MR neurography.
Yeah, sorry,
Yeah.
Neurography of that particular area.
Yeah.
Okay. So you will specifically comment about
because
this.
if you write, for example, if a person has a cut in the forearm, you want us to comment upon the nerves, but you have written MRI of the forearm, then we will not be able to specifically
But
tell
we
you
can
which
write there, we need a special comment on the nerve.
Yes, then we will do specific neurography for to better comment on than particular nerve.
And all the technicians are well versed to do this MR neurography.
The residents and faculty are always there. To guide them.
If I can intervene here, this you get in any radiological investigation what you want as you write.
Yeah, definitely.
Okay, if
That's
you
what-
don't write that, you cannot expect that to come. एक MRI कर दिया उसमें सब कुछ मिल जाएगा. नहीं, ऐसा नहीं होता. You have to give.
So I always mention I
Then
want a
I'm just
specific
telling- I'm
comment
just
on
telling,
that.
This is just this thing. So when you have your clinical suspicion at hand, then if the technician is not there, the radiologist always, this MR neurography is not just a dead imaging. It is something like an ultrasound. It has to be done on table, and during those cases, if you are specified, the concerned radiologist will sit with the technician and do it.
Okay.
Because sometimes we have to use more than one coil for the imaging of a particular nerve, especially when it comes to brachial plexus or some smaller nerve if we talk about. So the entire forearm or the entire limb, if we image on MRI, we will not be able to comment on that particular nerve which you asked.
Till now, I used to write only brachial plexus screening.
Yeah.
Should
You
I
can
add
do
any?
brachial plexus neurography like that.
Okay.
Yeah.
Okay. And any 1.5 machine can do that.
3T is better on 1.5, we might not be able to pick up a very tiny or a very minute kind of pathology if it is there. Gross pathologies, or if they are large tumors and like those things, they can be easily picked up. But if we are talking about, for example, Personage-Turner syndrome or something like that, then we have to get better resolution, which comes with a better magnet like 3T.
Okay, thank you.
Welcome.
Very nice presentation. I have a question. Which sequence, in your opinion, is best to pick up lesions, whether it is T2 spin echo or it's DWAPS? Like just an explanation of the previous question. Not everyone is aware of MR neurography. If you can mention the sequence, then
So
it'll
a
be better.
T2-based sequence with fat suppression. So in extremities, just a 2D sequence will suffice, a 2-dimensional sequence, which takes less time. But when we are concerned with plexus imaging, it has to be a 3D T2 weighted sequence, 3D T2 weighted sequence with fat suppression. That is the baseline. That is mandatory for the nerve imaging.
Thank you.
Welcome.
So there's a slight update from our organizing team.
Okay, thank you so much.
Dr. Richa. Sorry. We are fortunate to have Dr. Deborah, the Italian neurosurgeon specializing in peripheral nerve surgeries. She's going to talk to us from United Arab Emirates, I think from Dubai, if I'm not mistaken. She's already online. So we'll be we'll be jumping straight to her talk right now, and she'll be talking on peripheral nerve tumors in neurofibromatosis. Thank you.
Namaskar. Good morning, everyone. And I, first of all, would like to thank everyone for the invitation. I truly apologize for not being able to be there, but unfortunately, in this period, I'm really overwhelmed by things, and I couldn't take the time to come and participate in person at your meeting. So I'm starting sharing my screen, and I do hope that you can see. Can you see my screen?
Yes,
Can
yes,
you
we
see?
can see your screen. Please go ahead.
Okay, perfect. Okay. So as previously mentioned, my talk is on peripheral nerve tumors in neurofibromatosis. Now, neurofibromatosis are an incredibly interesting group of disorders. They are genetic diseases that involve the nervous system, the soft tissues, the skeleton, and many other systems in the body. They are autosomic dominant. Sorry, here there's a so they are autosomic dominant inherited disease, and another typical feature is that they are age-dependent penetrants, which means that the symptoms and the signs of the disorder become more evident as long as the patient gets older. In 50% of cases, neurofibromatosis is inherited by parents, and in the remaining 50%, it's due to a de novo mutation. Neurofibromatosis has been studied and classified at the beginning of the 90s by Riccardi, and he had identified about 8 different clinical manifestations of neurofibromatosis. Then more recently, we also identified a few more forms, the so-called schwannomatosis, the gastrointestinal neurofibromatosis, and the familiar cerebral tumors. So right now, we mostly have about a dozen forms of neurofibromatosis overall. However, statistically, the most frequent types of neurofibromatosis are neurofibromatosis 1, that is also known as von Recklinghausen disease, neurofibromatosis 2, and schwannomatosis. Now, neurofibromatosis 1 and schwannomatosis are of incredible interest for us because they mainly affect the peripheral nervous system, whereas neurofibromatosis 2, although it can still affect the peripheral nervous system, nevertheless, that mainly impacts on the central nervous system. Neurofibromatosis 1 is also very well known because the cutaneous features are very impressive. And what is typical to note is that the clinical manifestations might be extremely variable. We have approximately 500 different kinds of mutations and a wide spectrum of phenotypes. And what is interesting is that there is not a clear correlation between the type of mutation and the phenotype. There is only one exception, which is the so-called microdeletion. And we are going to talk about that later. Now, clinically, as I said, there is no correlation between the type of mutation and the phenotype, and we might have a very wide spectrum of presentation. So, for instance, on the left side, you see the picture of one of the most beautiful men in the world, Robert Redford, that apparently was affected by a very mild form of neurofibromatosis. And then you can see how the pathology disfigured the guy on the right side. Now, as I said, the only exception is represented by the microdeletion. Microdeletion is correlated with a specific phenotype where we found that the patients have a facial dysmorphism. They present generally a low IQ. They have big hands and feet, hypotomic shoulders, and what is mostly interesting for us, they have a very high number of neurofibromas. Generally talking, neurofibromatosis first is associated with very high numbers of peripheral nerve tumors. They can be found in up to 30% of patients. And what is interesting to note is that peripheral nerve tumors in patients with neurofibromatosis actually present peculiarities in comparison with the general population. And we are going to talk about these peculiarities. So the first peculiarity is represented by the ratio between schwannomas and neurofibromas. We know that in the general population, schwannomas are largely prevalent, and the schwannoma-neurofibroma ratio is 9:1. In patients with neurofibromatosis, the ratio between schwannoma and neurofibroma is reversed, and we have 1 schwannoma versus 9 neurofibromas. The other peculiarity is the fact that we not only find all the tumors that are normally detected in the general population, neurofibromas, schwannomas, and of course the malignant forms, but we also find tumors which are only typical of neurofibromatosis and which are the so-called plexiform neurofibromas and schwannomas. Now, plexiform schwannomas are actually quite uncommon, and they are only found in neurofibromatosis 2. Plexiform neurofibromas are indeed the most frequent kind of plexiform tumor that you can find associated with neurofibromatosis, and it's largely prevalent in neurofibromatosis 1. We can find it in up to 40% of patients, and it usually affects the nerves of large caliber and the plexus. As you can see, plexiform neurofibromas can grow enormously and truly disfigure the patient. These are not cases of mine. These are cases which have been reported in the French literature, and there are 2 Chinese patients presenting a 6 kg neurofibroma of the face and a kg neurofibroma of the leg. And these are some of the cases that I treated. So you can see that basically the neurofibromas can be present in every part of the body. This is an intra-extracranial neurofibroma. We can also have plexiform neurofibromas of the cranial nerves, as you can see here, affecting the limbs. And especially I would like to mention that on the lower legs it's particularly frequent to have this kind of situation. This was the case of a 3-year-old little Senegalese that presented with this enormous growth of the brachial plexus neurofibroma, and also she developed a schwannoma giving compression on the spinal cord, developing a quadriparesis. This is another case with an hidden mass in the mediastinum. These are also quite frequent subgluteal growth of the plexiform neurofibromas, which in this case was unfortunately associated also with the deformity of the genitals. So as you can see, these tumors can really enormously grow and they are disfiguring. And we have tried to find a way to stop their growth by medical treatment. And a number of drugs have been trialed, but we have to say that these are still largely experimental therapies. We don't have a clear evidence of reduced tumoral growth in these patients. And besides that, unfortunately, there were also quite significant side effects, which eventually resulted in the discontinuation of the treatment. We also have to consider that basically these are chemotherapeutic drugs, so we don't know exactly what's going to happen on follow-up in patients that have been submitted to this medical treatment when they are very young. The third peculiarity of tumors in neurofibromatosis is that we can have a malignant transformation of previously benign lesions. And this risk is actually quite significant because it's equal to 8–13%. And the interesting thing is also that if you consider the patients that we talked before, the patients that present a microdeletion, the risk of malignant transformation of previously benign forms can even double. Another peculiarity is that malignant forms in patients with neurofibromatosis present an average age of onset of 26, which is thus significantly younger than patients in the general population. Now, when we talk about malignant tumors, some in neurofibromatosis, one issue that is interesting is to note that these patients seem to present a lower survival rate in comparison with the general population after they have been diagnosed a malignant tumor. This is not related to the features of the tumor itself, but seems to be most likely to the fact that there is a significant delay in the diagnosis and treatment in comparison with the general population. Why? Well, we have to consider that in the general population, a malignant peripheral nerve sheath tumor usually manifests as a fast-growing mass along the course of a nerve, and it's correlated with the onset of severe excruciating pain and a rapidly progressive neurological deficit. So obviously, these are signs that raise a red flag, and the patient is motivated to seek for medical advice as soon as possible. In patients with neurofibromatosis, the malignant transformation of previously existing benign tumors may very often go clinically silent. Also, because we have to consider that 1/3 of malignant transformation arise in benign lesions which are in deep location. Moreover, there is something else. Because these tumors were already there, the patient may get used to that. So, for instance, in the case of this girl, when she came to see me, she presented these big lumps on the forearm at the level of the brachial plexus and the leg. And she had these lumps for a long time, and she was not particularly worried. Now, why do we have this silent transformation? The silent transformation is related to the fact that in the pool of the benign lesions, we can have the so-called atypical neurofibromas, which seems to be a subgroup of neurofibromas that present no morphological or radiological differences when we compare them with the pure benign neoplasm. They can be differentiated only with histochemistry and molecular examination. And these lesions have been demonstrated to be predisposed to undergo malignant transformation. So what we usually recommend if you are following up a patient with neurofibromatosis is first of all that you should go for a total body MRI, which is nowadays uniformly considered the first choice investigation to evaluate the total burden of the tumors. Also, it can detect the presence of hidden masses that can be afterwards better studied with a dedicated MRI. And there is something that we have to consider, despite of the fact that we have now new imaging modalities, and the presentation before mine clearly showed the point. Unfortunately, right now, we still cannot be completely sure that we can differentiate MPNST on MRI, because these tumors share basic imaging characteristics with their benign counterparts. So sometimes MRI is not enough to detect if a mass underwent malignant transformation. In these cases, the things that we have to consider is that size is an indicator for possible malignancy. And both in my experience and also as reported in the literature, we have found that if you have a tumor which is bulky with a diameter larger than 6 centimeters in a patient with neurofibromatosis, unfortunately, this is a tumor that very often can undergo malignant transformation. And if you have a doubt, just give indication for a PET with FDG. And if the tumor presents a threshold equal or higher to than 3.5, this is highly suspected for being a malignant lesion. Now, this is usually a very controversial point, the biopsy. A lot of patients are recommended to go for a biopsy. This is actually a really severe mistake because if you have evidence of a tumor that can be malignant, to do a biopsy in these patients is a mistake. Because as we said, very often malignancy is something that starts in previously benign forms. And especially if you have an atypical neurofibroma undergoing malignant transformation, with the biopsy, you can have misleading findings. So we always recommend to go for surgical removal of the tumor. Now, overall, we give indication for surgery in neurofibromatosis when we have a symptomatic tumor, obviously, when we have submitted the patient to radiological screening and we have a suspicion of malignant transformation, when we see a superficial bulky mass, even if it has been clinically silent, and in some cases we might actually give indication for masses which we expect might be responsible of causing future morbidity due to the location of the tumor. So every time that we consult with a patient with neurofibromatosis, we are not supposed to be aggressive, but we have to be careful and customize the indication for surgery based on the suggestions I just mentioned. Now, for surgical removal, we have some key points related to the location of the tumor, the type of the tumor, and thus the possibility of performing a radical excision. And then, of course, we have to consider the post-surgical management in case of malignant lesions. Now, for the location of the tumor, if you have masses which are, for instance, hidden in the pelvis, then surgical approach might be complicated and not performed by a neurosurgeon alone. So you need to work in team with the general surgeon, and you need a multidisciplinary team. Another problem is represented by the type of the tumor. We know that schwannomas can be always radically removed with no deficits. And sometimes this applies also to neurofibromas if they have the so-called uninodular form. However, like in these cases, however, we have to consider that sometimes you cannot really proceed to a radical excision because that would result in providing a deficit to the patient. So you have to contend with a partial excision, like for instance, in this case, where we had a neurofibroma affecting the lower trunk, or sometimes you just have to limit to a decompression, like I did in this case of a neurofibroma plexiform neurofibroma affecting the common peroneal nerve at the fibular head. Now, when you perform the surgical removal of plexiform neurofibromas, there are a few things that you have to consider. These are quite challenging tumors. First of all, because as I said, they can be really large. And in that case, you have to plan the surgical removal in more stages. For instance, I have seen quite a few cases of plexiform neurofibromas affecting the subgluteal course of the sciatic nerve, and then the extragluteal course down to the terminal branches. In those cases, you cannot just perform the removal in one stage, and you have to plan several stages due to the fact that these patients, these tumors, do not present main feeders, so there is not a relevant bleeding, but they constantly ooze. It's a minimal continuous bleeding that anyway at the end of the surgery may result in a quite conspicuous loss of blood, even leading to problems like shock anemia. So you always have to plan the procedure in stages. And another problem is that sometimes the skin overlying the plexiform neurofibroma may be very thin, and you can have problems in the skin healing. Now, when it comes to excision of malignant peripheral nerve sheath tumor, we have to consider that right now there is more evidence in the literature that sometimes the tumor can be removed without resecting the nerve of origin. Some of these tumors may be capsulated, and the nerve of origin may present a preserved function. I showed you an example of a tumor that was affecting the femoral nerve. It was well capsulated, and I could remove it without damaging the nerve. If the nerve is not capsulated and it infiltrates the nerve, then the tumor is responsible of a progressive functional loss. And in those cases, then the resection of the nerve of origin has to be mandatory. And you should try to restore the lost function thanks to nerve transfers or muscle transfers. Graft nerve reconstruction is not an option for many reasons. First of all, because once you have to resect the nerve of origin, you try to resect a piece which is as long as possible, and therefore this would result in the need for a very long graft, decreasing the chances for functional restoration, and also because these patients then have to be submitted to radiotherapy. So this is something that I always try to emphasize in my talks, because unfortunately I see that still many physicians give indication for amputation in patients with MPNST. Amputation should be completely abandoned. It doesn't provide any clear evidence of a longer survival on follow-up, and we also have to consider that it really impacts badly on the quality of life of the patient. Finally, after the patient has been treated for a malignant peripheral nerve sheath tumor, they should undergo radiotherapy. In those locations where it's possible to have an andron therapy, this is definitely recommended. Radiotherapy has shown to significantly prevent local recurrences, and then the patient should also follow chemotherapy. So I would conclude my talk saying that in neurofibromatosis patients, peripheral nerve tumors are one of the main issues that we have to take care of, especially because, as we have seen, we have the risk of malignant transformation. You should particularly be careful in following young patients that on genetic assessment presented a microdeletion. You have to estimate the total bulk of tumors with a total body MRI. If you have suspicions of malignant tumors, a PET scan with FDG is extremely useful. And I definitely recommend the surgical removal of clinically silent bulky lesions in order to prevent malignant transformation because of what we said before of the atypical neuromas. Thanks so much for inviting me. And of course, I'm here available for questions.
Thank you, Dr. Deborah, for that nice presentation. I think we are open for questions.
Good morning, ma'am. I would like to know your thoughts on a new monoclonal antibody which has come up, selumetinib. Do you have any experience on selumetinib? It is especially useful in plexiform neurofibromas, is what is written in literature.
Yeah. Yes, I mentioned that before. There are now a number of trials which are going on, but I have to say, I personally, I don't have any experience on that. These are trials which have been started mostly in Europe and in the USA. I have to say that based on what I have seen in the literature, we cannot really sure that these are going to be resolutive therapies. I have seen a lot of patients when I was in Europe that started a lot of treatments and then they had to be discontinued because the side effects were significant. And I'm talking of side effects which have been really important, like for instance, even hormonal alterations, and even the patient was not really able to tolerate the side effects. And as I said before, we do not have enough evidence of what happens in the long run, because usually the patients that we decide to submit to chemotherapy are patients in their childhood or in their teenage. So they are growing individuals. And you don't really know if this is going to have an impact in the long run. So I'm still quite reluctant to start these patients on this kind of medications.
Can I ask one question? Congratulations, ma'am. You have given an overview of the peripheral nerve tumors. Excellent. Now, in our clinical practice, we do get many families where they come for because of some complaints, and we discover that they have a peripheral nerve tumors. And that is the family positivity. Now, do you think that we should subject to the whole family, means those who are not clinically having now any kind of a tumor on clinical examination, the whole body MRI, indications of whole body MRI in the family, someone has been detected with the neurofibromatosis? Over to you.
Okay, so when I was working in Italy, I was working in collaboration with the genetic department of the University of Padua, and we would have a screening center for patients with neurofibromatosis. What we found out is that in many cases, we had children that were brought to us with neurofibromatosis, and they were apparently the first cases in the family. In reality, then what we found out in quite a good percentage of cases is that these were children of parents, and the parent had very mild clinical form of neurofibromatosis, so they were not even aware of that. So what I would suggest is that if you do have a patient like a child with neurofibromatosis, with young parents, I think it would be important that you study also the parents to identify if that's a de novo mutation or if it's inherited by the parent. And in that case, it's very important that you also give genetic counseling to these people in case they are young and they still think to have more children. Usually I have seen that patients who have a very mild forms with very mild skin features, they don't really harbor tumors as hidden masses. So I don't think it would be recommended that you screen with a total MRI all the patients. If they come to you, for instance, they are 35 or 40. But I would recommend that you do so if you have a child or an adolescent, because as I mentioned before, this is an age-penetrating disorder. So it's very important to be sure that you are not missing something, because this is otherwise when they can get the malignant transformation. So to sum up, I would recommend that you screen the parents of a child that comes to you with neurofibromatosis. Children with neurofibromatosis, an adolescent with neurofibromatosis, regardless of the clinical presentation, should be screened with a total body MRI. If the patient comes to you when they are 35, let's say above 30 years of age, because usually, as we have seen, malignant transformation mostly affects people younger than that age. So if you have a patient that is diagnosed with neurofibromatosis later, when they are 30, 35, or even older, and they have mild clinical manifestations, in those cases, I don't think we should go for an MRI, total body MRI, I mean.
Thank you.
Yeah, it's a quick comment or last
Yeah.
question, I think so.
Wonderful, Deborah. I mean, it's always been a pleasure hearing you on this topic and any other topic related to peripheral nerves. And wonderful pleasure.
Thank you so much. You're always very kind. It's nice at least to see you on Zoom.
Same here. Although it would have been much better if you would have been present here physically. But anyway, of course. So my quick question is, I mean, what factors are deciding factors for you when you're doing surgery for these tumors in NF1 patients to do the nerve transfer during the original surgery, during the first surgery?
Okay. So first of all, as I said, if I have a clinical suspicion of MPNST, I always do a PET before I go for surgery. Then during surgery, we can see if the tumor is capsulated. As I said, then I will just remove it like in the benign forms. If the tumor has infiltrated the nerve, then clearly it's a malignant form, and I will resect. So basically, I decide if I can do the nerve transfer, or sometimes if I have to do a muscle transfer. So I had cases of malignant tumors of the common peroneal nerve. And for instance, in those cases, we thought that a good option might be the muscle transfer of the tibialis posterior. So the patient would immediately recover a gait without steppage. And then there were cases, for instance, I remember a few cases where there was a tumor that was englobing the musculocutaneous nerve, and therefore the removal implied that there would be a loss of the biceps, and those were cases where we did an Oberlin procedure.
Okay, thank you.
Thank you very much. Thank you, Dr. Deborah. It was really enlightening, and thank you for sharing your experiences with us. We are already running significantly late, so we'll quickly move back to the previous session where Dr. Arpit Agarwal, he was about to present electrophysiology. There was some technical glitch. He's back on, and we request him to present on electrophysiology and peripheral nerve surgeries. And we'll please stick to our time. Sorry.
I'll stick to my time. Thank you for giving me this opportunity for presenting electrophysiology in peripheral nerve surgeries. So we have seen anatomy, we have seen the MRI, the clinical examination. Now we'll see things and things that can be felt. So my talk will be a very basic one, as discussed with the organizer and with the neurosurgery residents also. My principal sources are Shapiro's, the Bible of Electrophysiology, and John Kimura's. So this will be the outline. So nerve conduction studies at EMG, the electrophysiology, are essentially an extension of clinical examination. First rule, no electrophysiology should be performed without a proper clinical examination and history. Second rule, which is not written in the slide, No EMG should be performed without nerve conduction studies. Just I have seen residents just writing EMG, so that is not expected. We have to do the NCS first, then only we can perform EMG. How does EPS help? EPS helps in localization of the lesion, determination of pathophysiology in some cases, especially the radiation-induced brachial plexopathies, establishing the severity of lesion, and identification whether there is ongoing reinnervation or not. So these are the various localizations. We'll only focus on the neuropathic ones. CNS can also be done with more advanced EPS studies like evoked potential, somatosensory evoked potential, but the focus will be on the neuropathic localization. So it can be localized from the anterior horn cell up till the peripheral nerves. So neuronopathy means the involvement of the cell body that presents as sensory ataxia. Again, it is not a peripheral nerve injury, so I'll not focus on that. It can be a radiculopathy, a plexopathy, a mononeuropathy, or multiple mononeuropathies, or polyneuropathy. So the focus will be on these. So nerve injury classification is very old, still ongoing, still valid by Seddon and Sunderland. Seddon classified it into neuropraxia, that is transient ischemia, transient malfunction of the nerve that is easily recoverable. Axonotomesis, there is loss of axon loss, but the and endoneurium is disrupted, but epineurium is intact. And neurotomesis, that is the complete cut-to-cut loss of the nerves. So there are electrophysiological correlates to that. Neuropraxia can present as a conduction block with or without a conduction slowing. Axon loss causes fibrillations. Well, I'll come to that. Then Sunderland classified this. The grade 1 Sunderland is neuropraxia. Grade 2 to 4 is axonotomesis. And grade 5 is neurotomesis. So this is the classical diagram of Wallerian degeneration. I think the audience is very much aware of that. So I'll just skip to it. This is the pathophysiological consequence of a peripheral nerve injury. The first one is normal. Second is Wallerian degeneration, the distal degeneration which occurs after nerve damage, with segmental demyelination and axonal degeneration also. So I'll come to this slide later. So these are the basic potentials which we see in EMG. The first two, I don't have a pointer. I can point with this. It's not visible. These are the fibrillation potentials. Fibrillation potential is like a rain on a tin rooftop. So EMG is more about listening to the potentials produced rather than seeing the graphs, but both are equally important. So second one is positive sharp wave. Third one is fasciculation. All these represent the denervation potentials. So first and foremost question, when should the NCS and EMG should be done? The patient has an accident, a brachial plexus injury or nerve injury 1 day back. Second, you are ordering NCS. No, that should not be done. The CMAP response, because of the pathophysiology of Wallerian degeneration, declines by day 3 to 5 and absent by day 7 to 9. The sensory response is again a bit 2 to 3 days later. So at least 2 weeks gap should be there in ordering a NCS after the injury. Similarly, in motor nerves, abnormal spontaneous activity like fibrillation and PSWs appear 1 to 4 weeks after the injury. Ideally, it should be planned 3 months after the injury. If there are no reinnervation, only denervation is going on, then surgery could be planned. The intensity of fibrillation activity approximates to the severity of axonal damage. So this is the same thing. So again, the same thing, brief history and directed physical examination is very, very important by the clinical neurophysiologist. I'll just give you a a small example. A patient presents with foot drop. Resident has ordered a EPS study, but after examining the patient, the reflexes are brisk. So the whole differential diagnosis change, and again the whole NCS and EMG study will change accordingly. So I think it is the same thing. Cardinal rules of NCS and EMG, very, very important. Their extension. Small findings in electrodiagnosis studies. Suppose we take a median or CV to be normal as 40. If it comes out to be 35 or 38, it should not be overinterpreted. And when in doubt, we should always consider technical factors. As suppose in elderly, the sural nerves may not be recordable after age of 65 years. Sural nerve is difficult to get. There may be technical glitches. There may be supramaximal stimulation. When in doubt, always re-examine the patient. Brachial plexopathy, from the beginning of anatomy, I know that everybody loves brachial plexus injury. I'll just give a small point in electrophysiology. We should focus on, in the NCS of brachial plexopathy, we should focus on seeing the sensory potentials, snaps. And LABC, that is lateral antebrachial cutaneous, and MABC, medial antebrachial cutaneous nerves in sensory stimulation should always be done. That is often missed from the NCS studies. Suppose if both the snaps of LABC and MABC is absent, straight away it is a pan-brachial plexopathy. So the all the trunks of the brachial plexus are involved. In EMG, maximum number of muscles, especially the weak muscles, should be examined. At least one muscle from every peripheral nerve should be examined, and at least one muscle from every root should be examined. So a brief overview of intraoperative neurophysiological procedures. One, it prevents the surgeon from causing further damage to the peripheral nerves, and medico-legally also it is helpful. So these are the these are brief overview of intraoperative neurophysiological procedures. Free running and stimulated EMGs can be, the needle can be placed in the muscle of which dissection or surgery is going on. Nerve action potentials can be done for the ongoing surgeries of a peripheral nerve. Evoke potentials can be done for especially if there is a cervical spine surgery is going on to see if there is any damage. Grossly, as a, you can say, thumb or rule or gross rule, 50% reduction in any of these potentials should warn the surgeon. He should stop the surgery and relook for any nerve damage. Similarly, it can be done for cranial nerves in skull-based surgeries. So safety, NCS and EMG is safe. Coagulation disorders, we should be cautious. And in patients with low dose aspirin, EMG is safe. So there are some limitations. I'll just take one more minute. Age less than 5 years, the CVs are slow. Where patients who are very tall, the CVs will be slow in the lower limbs, but normal in the upper limbs. Snaps amplitude goes down in the elderly, and it may even be absent. If the skin temperature is below, there will be reduction in the conduction velocities. So ADX studies are essential and extension of clinical examination. It is not an alternative to clinical examination. That is my conclusion. Thank you.
Thank you, Dr. Arpit. Are there any questions for Dr. Arpit?
Any questions, please?
Congratulations, this excellent presentation. Now, my question is, some of your examples where the diagnosis clinical was changed because of the ENMG, and ENMG's diagnosis was changed because of clinical. That is the one. Second, in our clinical practice, everywhere EMG is not available. So in what cases only the nerve conduction study would be enough in the peripheral nerve involvements? Not the EMG is not easily available. In what cases you think that, yes, nerve conduction velocity is good enough for the diagnosis? Over to you.
Sir, I will start with the second one. A patient presented to me with foot drop. I examined, the reflexes were all brisk. When I examined again, there were tongue fasciculations. So now a diagnosis of foot drop due to maybe a peroneal or sciatic nerve injury has changed to motor neuron disease. So the diagnosis will change as well as the treating doctor will change now. One thing.
Good.
Second thing, suppose in a brachial plexus injury, as I told, both LABC and MABC are absent. It is good enough to label as pen-brachial plexopathy, and EMG may be avoided if it is not available. In mononeuropathies, if suppose there is ulnar neuropathy, there is complete absence of all the amplitudes in one nerve and preserved in the opposite side, then that is also good enough. But EMG also localizes the site. So site will not be available from NCS. The nerve injured will be available, but the site of injury will not be clear.
Good, thank you.
Thank you.
May I ask you a question, sir? Just in case of brachial plexus here, in case of brachial plexus injuries in partial, for example, if we need to check if there are any signs of reinnervation and decide about the surgical procedures.
Yes, sir.
How exactly do you look into that issues? Like what exactly do we need to see in the EMG, especially?
So that is a very good question. For denervation, we see the fibrillations and PSWs. For reinnervation, we see the MUAPs, the motor action potentials. So it depends upon the duration of injury and the amount of reinnervation that is happening. If there is complete reinnervation, there will be only a increase in duration of MUAPs, may be polyphasic, but otherwise MUAPs will be large amplitude near normal. In case there is a severe injury or there is not enough reinnervation, small MUAPs will be visible. That will be low amplitude and polyphasic. In very severe injuries, we see in RTAs when there is complete transaction of the brachial plexus, MUAPs may just be absent.
So is there any sure sign, like, because clinically they have zero power in the shoulder abduction and all, but still EMG gives some signs of reinnervation. Is that possible like that? And should we, like, it's a gray zone, the patient will say there is something reinnervation, but clinically is absolutely no power, nothing.
Yes, actually, it correlates to clinical examination quite a lot. If there is no activation, you cannot see for MUAPs anyways. So some power should be there for measuring the MUAPs. And for denervation, if you denervation, it can be quantified also, because measuring the number of fibrillations and number of PSWs, and sometimes the denervation is so severe that even they are absent. So yes, it can be quantified, but it will not be very exact.
Thank you.
Thank you. Sorry, any other questions? Thank you.
Done. So I think our final presentation for the second session is case-based discussion in peripheral neurography by Dr. Nihar Kathrani.
Yeah, good morning to everyone. And first of all, I would like to thank organizers for providing me this opportunity to present this talk in the conference. So I will not take much time. I have kept the presentation quite minimal, but few points I would like to emphasize about MR neurography is the technical aspects, and here most of the audience is clinicians. So I have kept according to it, and what to expect in MR neurography and what are the limitations. So this is just MR neurography is just similar to what a woman looks in a man. It's a long list. It is, we cannot get all the points. We cannot understand everything about it, but MR neurography is exactly same. So I may not take it much further because my wife is present here. So first of all, I would like to say that what to expect in MR neurography. So high gradient performance is the key. So I have a strong opinion that 3 Tesla MRI is the way to go for MR neurography, because like even if you are imaging brachial plexus, it is quite easy to image roots and trunks, but going there further, it is almost impossible to get good images with 1.5 Tesla scanners, and it doesn't end there actually. We need, other than the MR hardware, we need dedicated coils for that, and which is not available at all the centers. We need dedicated coils to image brachial plexus and peripheral nerves, and preferably respiratory gating should be there. I will show in next subsequent slide that how image quality improves. So I would not go in much technical details, but I will directly show, and we need actually good post-processing softwares also. So this is, I'm showing respiratory triggered versus non-triggered MR images. So here we can see that there is neuroma here involving the one of the divisions of upper trunk, and here if it is a non-respiratory gated images, the images are blurred actually. So when the brachial plexus goes further to the level of divisions and cord, we actually need two things. One is good fat suppression, and other is as it is near to chest wall, we don't want respiratory artifacts to affect it. So I will show some good images, which are like one of the dedicated center from US is there. So this is like, everyone knows about this entity. So I'll just show images like commonly involved nerves. So this is suprascapular nerve involved in this. So it is actually looking like someone has drawn this nerve. So here we are actually seeing hourglass constructions of suprascapular nerve, which is commonly involved. Now there is infraspinatus atrophy also we are seeing here. So this is actually very, very difficult to image. Actually, it is easy to interpret, but to acquire such sort of images are quite difficult. And this is again a long thoracic now having hourglass construction. So this is actually difficult to image. And if I may take liberty to show one of the cases of brachial plexus. My screen is not seen here. I will skip to that part. Actually, I actually wanted to show one MR of brachial plexus and how better we can image the axillary region. So I will directly go towards the case-based example. So this was the case of brachial plexus injury. Here on the right side, we can see there is thickening of cords and trunks. The opposite side, left side, is looking normal. We can see the pseudomeningocele, and same is shown on axial section. So this was the case of trauma. This was the case of neurofibromatosis, already very well discussed in previous session. So this patient actually he presented with flexor spasm in all four limbs, bladder urgency, frequency, and he had all other features of neurofibromatosis. So here we can see the Naushid tumor here. It is everywhere, but the remarkable feature was it was so severe in extent that it was actually compressing the upper cervical cord like anything, and suggesting a severe presentation. And the lower cord also, they are showing multiple Naushid tumors. So this was the case of Pankos tumor. So this was 49-year-old male smoker, presented with upper limb symptoms, sensory symptoms, presiding motor symptoms, and there were more of C8T1, and so explained by the MR brachial plexus study. So here we can see the specific affiliation of lower trunks and cord here. And this was the case of MPNST. So this was 13-year-old girl presented with sensory symptoms followed by motor symptoms, and imaging. This is histologically proven. So imaging showed peripheral Naushid tumors. Actually, it was not looking like benign. It has multiple septa and within it. So it was suspected of malignant peripheral Naushid tumor. But anyways, it is not always possible to demarcate between the benign and malignant entities. I will show some other cases of tumors in which there was leukemia or lymphoma, and then it had involvement of peripheral nerves. So this was a 16-year-old male, and he presented with peripheral nerve features, hyperesthesia of both feet, and then he started to having motor symptoms. So actually, we were not sure that whether it was because of the chemotherapy he's having such problem, or it was actually affection by tumor. So CSF analysis was high cells, low glucose, atypical cells were present, and I'll show the picture of MR neurography. So we are here seeing asymmetric involvement of the brachial plexus, and here we can see the roots and trunks are thickened. And I would like to again emphasize here, you can see axilla, it is extremely well suppressed. We can actually see the brachial plexus crisp and clear here, and there is no fat. There is some blurring. It may be there because of the respiration, but it is still much betterly seen, and they are also thickened. Right side more involved in the left side. Here also we can see nicely brachial plexus through in its entire extent. And lumbar plexus also was similarly involved in this particular case. This is very interesting case. This was CNS lymphoma with peripheral nerve involvement. So this was histologically proven case of DLBCL, and which is the commonest tumor to affect the central nervous system. So this was 58-year-old female presented with difficulty swallowing and weakness of all limbs. I will directly show the imaging part of it. So I will first show the peripheral nerve imaging. So here we are seeing quite thickened now bilaterally, and it is extending all the way to the cords, asymmetric involvement. And this is the PET images which is showing increased uptake along the nerve root, and here we can see the thickened nerve root exiting from the neural foramen. And similarly, we see in the lumbar plexus also there is similar involvement here. We can see the upper ones are okay. Yeah, the upper ones are normal. The lower ones are thickened and enlarged nerve roots in this particular case. And this is the CNS picture. The biopsy was taken from thalamus, and which is the imaging is quite characteristic of lymphoma, the way it is enhancing and the involvement. This is a case of multiple myeloma. So in multiple myeloma, there can be peripheral nerve involvement because of three reasons. One is the direct affection by tumor, or it can be some neural compression fracture, or it can be because of amyloidosis, which is amyloidotic affection of the nerve. So this was the case. Okay, I'll just take 1 minute to show quickly rest of the cases. So there is again thickening here. We can see asymmetric. This was the case when there is involvement of the nerve because of the compression fracture because of multiple myeloma. This was an interesting case here. There was epidural shunt. So post embolization, they developed neuropathy. Here we can see the thickening of the nerve. This is endometriosis, and here we can see the compression of sciatic nerve, which is quite rare to find. This is hematoma. Here again, it is hematoma causing compression of sciatic nerve. And this is abscess, injection site related abscess, showing involvement of sciatic nerve again. This is Mycobacterium leprae infection. So there is large case series published from NIMHANS in this particular entity. So we used to get a lot of cases of leprae with thickened nerve roots. This is CIDP with cranial nerve involvement. So it is cranial nerve involvement is seen in 20-30%. So here we can see the very well involvement of mandibular division passing through foramen ovale.
Dr. Nihar, can you please conclude?
Yeah, just one or two last case. And this is for AIDP, thickened nerves, and radiation nerve injury. So I would conclude that it is technically difficult to get, but once it is acquired with, it is quite easy to interpret, and it gives excellent morphological details. I would acknowledge a few of the images in the slides were from NIMHANS. So acknowledgement to my professor. Thank you.
Do you have any questions from the audience?
So I'll give you a case scenario. If patient is coming with a radicular pain to a neurosurgeon, we do a MRI lumbar spine. There is no compression seen. So in such cases, can we ask you guys to look into the pelvis and have, like you showed one case, there was some endometriosis compressing the sciatic nerve. So do we have to repeat the study, or you can see the scans there itself?
No, actually we need to repeat the study because these scans are dedicatedly acquired considering the visualization of nerves. So
MRI pelvis has to be done.
No, MRI lumbar plexus.
Okay.
So in lumbar plexus, we do basic sequences to cover pelvis also, but the rest of the sequences are dedicated to see lumbar plexus only. So even if like you are suspecting sciatic nerve or femoral nerve, then we would particularly try to image that area.
Okay. Thank you.
Okay. Thank you.
Dr. Nihar. I would like to thank all the speakers and for this very informative session on the preoperative diagnostic evaluation, and like to conclude this session. Thank you.
Thank you, respected faculty, for chairing this session. Our next session is symposium for Professor A.K. Mahapatra on adult brachial plexus injuries. I'd like to invite Dr. Durga Karki, Dr. Kuntal Kanti Das, and Dr. Devajati Guin on stage for chairing this session. Also, our first presenter, Dr. Dattaraj Savarkar, please come to stage.
Madam, can
Good morning, everyone. Now we will start with our session 4. This is a Professor A.K. Mahapatra Symposium on adult brachial plexus injury. So first I will invite Dr. Dattaraj Savarkar. He will give an introduction of Professor A.K. Mahapatra. Dr. Dattaraj.
So thank you very much. And it's my privilege to talk about a great man, Professor A.K. Mahapatra, sir. And he's a great academician. He was our head of Department of Neurosurgery and has many things on his name. But one of the most important thing, he was a founding president for our Ispnscon society. And under his umbrella, like we are here. So he born in a great place, Puri, and he continues his spiritual journey over the years. And his qualification, he passed his MBBS from Burhanpur. Subsequently, did his MS and MCH from AIIMS Neurosurgery in AIIMS New Delhi, and had done DNB. And he is a fellow of National Academy of Sciences, was awarded in 2004. He has various qualifications on his name. He is a great man. I mean, it will be difficult for me to enumerate in this small time. But he carried out more than 24 of the research project in Delhi. And there are many multi-central international trials and around 120 chapters and 6 books on the head injury. Many papers on traumatic blindness, more than 15,000 patients he has treated with and reported in the literature. Many articles, including on nosocomial infection, cerebral glioma, and many of the studies done over the years, including the gene therapy into the gliomas. His clinical interest was in pediatric neurosurgery, head injury, skull-base surgery, and the peripheral nerve surgery. So he was behind us for the development of this society over the years. He has many publications in his name, around 12 books, 120 chapters, 505 papers in the journals, and many abstracts. He was meritorious, and he has many awards on his name. This is the list of his awards here. And he was editor of child nervous system, and then subsequently again he is on editorial board of our Journal of Peripheral Nerve Surgery as well. He got many awards. He is a teacher for us. He got BC Roy National Award in 2007. Subsequently, he also got UP Ratan Award in 2008. He was awarded with the Bharat Nirman Award in Bhubaneswar in 2011, and in 2012 he was also given a Vigyan Ratna Award. Beside that, he was selected as the best doctor in the Odisha and Lucknow in 2007 and 2013. We call him Mr. President. He served as a president for the many of the societies, including, like as I earlier mentioned, he was the founder president for Ispnscon Society. He was president for Neurotrauma Society, Skull-Base Society of India, Indian Pediatric Neuro Society, and various society like NSSI and DNA, which is Delhi Neurological Association. These are some of the photographs, and he, like we all know him as a great man in the pediatric neurosurgery. He was a founding member of Ispnscon as well. But one of the most important thing, like he was involved into one of the separation of craniophagus. We can see like a lot of members, including Harry here, who was a part of that multidisciplinary team. And it was had a successful outcome, and it was under his able leadership we could do that. He has many appointments. He served as a director of HGPGI and also founding director for the Bhubaneswar AIIMS, and he brought it to a good level during his tenure. I mean, we could keep enumerating his achievements over the years. This is one of the things that I was mentioning. And now he was recently was selected post-retirement as a Vice Chancellor of Shiksha Anusandhan Dim University in the Bhubaneswar. This is what this how he himself carried himself in the AIIMS. He was the Don. I mean, this was his picture once upon a time in Delhi with the ma'am, the food he likes, and the drinks only to lemon soda. I mean, nice pictures with the ma'am, and he always believed in the Go Green initiative and the spirituality. So over the years, I mean, whenever you meet him, you'll find these two things in him: very good spirituality, and he kept guiding us on that path. So you better listen to him. If he's not there here, you have to listen to his symposium. Be tuned. Thank you very much. I open the session.
Thank you, Dr. Datta, for such a eloquent introduction of Dr. Mahapatra. So we shall be beginning now, and the first speaker of this session would be Dr. Hari Venkat Ramani. He will be speaking on global palsy reconstruction, the Ganga Hospital Protocol. Dr. Hari, please. I request all the speakers to kindly stick to time because we are running very late. Thank you.
Yes, sir. As he mentioned, I was part of the team and I had great interaction with Dr. Mahapatra. So we had a patient we operated on yesterday who had a global palsy. So what do our patients want? They have injury because of this, and the first aim they have is to go back on bike because that is the livelihood for most of our patients. So that's what they want. And to achieve this, we need a stable shoulder, stable elbow, good elbow flexion, a fused wrist, and something in the finger. And these are what we are left with: spinal accessory, phrenic, intercostal, and opposite C7. Dr. Bhatia will be speaking in his oration on the opposite C7. So we opt to do primary reconstruction when the time is below 6 months. Beyond 6 months, as the time progresses, functioning muscle transfer remains the only option. DOI has popularized this protocol, but it is a very difficult protocol because it has many components, double free flap, and most of our patients don't withstand, or even because of cost factor and the technical challenges. So it's a package, you cannot pick and choose. So our philosophy has been, we do what works because Indian customer patient is a value customer. So every procedure we do should have some outcome, then only they are ready for the next stage. So that's what we are able to do. And in our team with Praveen here, we can do from FFMT to arthrodesis, the entire spectrum. So this has been our protocol. First stage, we do a spinal accessory to MCN because as we know, spinal accessory is very powerful donor. Then the second stage, when they get grade 3 power, we do wrist fusion and CMC fusion and trapezius transfer to deltoid. The third stage we do for fingers, that is either an FFMT or now we do a biceps to FDB transfer. And in the fourth stage, we just added is an action rotation osteotomy because none of them have action rotation because of the global palsy. So in the order of priority, elbow, shoulder, finger. Sensation is not something which we really aim for because they don't get real good sensation, which is worth for any day-to-day purpose. How do we get elbow flexion? Spinal accessory intercostal. We rarely use phrenic. We have used in few cases when there is the upper two ones are not possible to harvest. So this is a good study which came recently, which says if you see compare the results of intercostal versus spinal accessory tends to get more grade 4 power. Intercostal gets grade 3 very quickly, but then to get a sustained grade 4 power, this study proves that, and this has been our experience also, that spinal accessory is a great donor for elbow flexion. So that's what is our preference. This is what we do. And we reserve the intercostals for a future FFMT for finger flexion. So that's been our protocol. How do we do it? We showed it yesterday. So spinal accessory we identify, and then we use an MABC or a sural nerve graft. We have reduced the graft length to around 15 centimeters. So if you really take the musculocutaneous from its origin, then you will get it exactly around 15 centimeters. So this is a study we did, which is just going to be published. We have done 337. If you see, more than 80% had M3 or above, and many had M4. So this is a great advantage of the spinal accessory. Though the long nerve graft is there, but it always works. So there's always a criticism whether long nerve graft work, and it has been our experience that it works. So once we get elbow flexion, we address the shoulder, that is trapezius transfer. We have not done many wrist shoulder fusions. Our bias is to doing trapezius transfer. We can still do it because we have preserved the upper trapezius by leaving the branches intact. And what we get a result like this. If you see the result in a global palsy following trapezius transfer, it is quite similar to what we'll get with a spinal accessory to suprascapular, around 30 to 40 degrees of abduction, but a very stable shoulder. Then we come to the finger, which is the most difficult part, as we saw in many of the presentations since morning. finger is a real challenge. Before we do finger flexion, we fuse the wrist. So once we get this stage, now we have a good shoulder stability. We have elbow flexion, stable wrist, then we address the finger flexion. So how far our patients have gone, if you see here, we have done so many nerve transfers, but not all of them have gone to have the entire spectrum of the procedures. But then, yes, once they get good outcome in the initial stages, they go ahead and do the. So we have done 17 FFMTs. And to be useful for an FFMT, it has to be M4 power. M3 is not useful. So you need to have M4 power. So our role of FFMT is, if you see them late, now late is around 8 months, 6 to 8 months, we directly go for FFMT for elbow flexion. These are advantages of Gracilis. The advantage of Gracilis, a lot of times the criticism is it is not powerful enough. But if you see the parallel, the strap muscle versus a bulky muscle like a rectus or a pectoralis major, what we need is a range of movement. So the pinnate muscle give strength, but the gracilis gives the range of movement. And in elbow, we need range of movement. So we need for isotonic contraction, not isometric contraction. So we need the hand to come to mouth. And that's why gracilis is an excellent donor for elbow flexion. And it gives the consistent results. Now coming to finger flexion, this is what we have incorporated. We applied for patent also. So this is a very simple technique. You have a magnetic glove, and this just goes across any object you want. People can use it for drinking with a glass. Various sleeves are available. This is following an intercostal to MCN. And now we come to a stage where we have done a spinal accessory to elbow flexion. We get elbow flexion, trapezius transfer with wrist fusion, and then we do an FFMT for finger flexion. And what does this achieve? So this achieves a hook grip and his ability to bring the elbow and the hand to mouth. So many times the question is asked whether this much flexion is useful for the patient or not. So this is what it will achieve. The forearm is being held because it goes in internal rotation. But then he can grasp an object. He can pick up the bag. They can pull, they can open a door. So that's the amount of finger flexion which has got with an FFMT. And they can even they can lift an object. And it keeps getting powerful. So this is a 5-year follow-up of the same patient. If you see the 5-year follow-up, they cannot open the fingers, so they use the other hand to use for the grasp. But if you see the powerful elbow flexion with the nerve transfer and finger flexion with an FFMT. So this is the power we can get. Now with Dr. Praveen with us, and this is what we have moved on to. If there is a very strong biceps, we extend the biceps with fasciolata graft for the finger flexion. And this is how it has been done. It goes under the flexor pronator mass, so they don't lose any elbow flexion. And this is how the tension is adjusted. This is the biceps to FDP transfer. And this is the amount of flexion they get. Again, we have modified the same glove as an extension glove. So the glove mechanically opens the fingers. So this is the same patient, a 2-year follow-up. He's able to drive a 2-wheeler. He's scared to drive a bike. And this is the power they can get to lift a heavy bucket full of water with biceps to FDP transfer. If you have done an FFMT for elbow flexion, we can still use the same technique. So this is a very strong elbow flexion he's got. And we have fused the wrist. And this is, we extend the FFMT, that is the same biceps tendon for finger flexion. So you can get a very powerful finger flexion. They cannot open it still. We are working on techniques to get a finger extension, which is a most difficult part. So this is again an example of elbow flexion with FFMT, fusion of wrist, and FFMT, the biceps tendon extended with fasciolata graft. Finally, external rotation osteotomy. This video is not working. Yes. So if you see, after external rotation osteotomy, they get, initially it was hitting the tummy. Now with external rotation osteotomy of the elbow, they can get good elbow flexion without having to remove their hand. And this is a power they can get with biceps to FDP transfer, same patient. So what the patients are happy, or what we are happy about, is that elbow flexion is very consistent. They are relieved of their paralytic look, ability to drive the 2-wheeler and use the hand as a supportive hand to lift a bag, to lift a bucket, and even to drive a 2-wheeler. So future will be incorporating all the techniques in your armamentarium and having a good team. So we have a new team member also, Dr. Vignesh. So it's a team approach. We are able to cater from the nerve transfers to all aspects of secondary procedure. Thank you very much.
Any questions from the audience? Dr. Hari, it's
Yes.
a nice, wonderful presentation.
Yes.
I have a question. Like what should be the power of this elbow
Biceps.
flexion so that we can do a
Yeah, so minimum grade 4 power. Grade 4 is, we have not lost the power at all in any patient so far because it is anyway going below the paralyzed flexor pronator mass. So the biceps is retained, the power is retained.
M4 will be M3 while it reaches the finger.
So if it is
everything.
below M3, then we prefer an FFMT for finger flexion. We don't use the biceps. FFMT will both augment the elbow flexion and also the finger flexion. Yes, sir.
Sir, if you have any good nerve root proximally,
Yes.
then also you prefer to do the same thing?
No. If we have nerve roots, we direct it to the median nerve for the hand.
Thank you. Vascularized ulnar nerve?
No, we have not done any vascular. No.
Thank you.
Sir, many of the DOIS fellow, they connect the for the elbow flexion along with the finger extension with the same FFM.
So we did couple of cases of finger FFMT with wrist extension, but our patient don't like it because they all want a supinated elbow flexion. So psychologically they like this. If you get this, they cannot see their hand. As Bhatia sir says, if you don't see your movement, then you cannot actually do physiotherapy also for that. So you need to have a nice supinated elbow to get a good outcome.
Thank you.
Sir, when you give spinal accessory to MCN, you give it to whole MCN
Whole
or
MCN.
to only bicep
No, whole
brachialis?
MCN.
Whole MCN.
Whole MCN. We use MABC graft. So we have compared both MABC and sural now. The results are same. MABC is a little thicker. So we take a MABC, reverse it, and then use it to the fingers.
Okay.
So single incision.
Sir, in the new protocol, is there any role for exploration, sir? In what cases?
No, all cases explosion. All
Okay.
cases we are exploring.
Then you have not used roots, sir?
So these are the cases where there is no root available.
Okay, sir. If
No.
the roots are available,
Yeah,
then...
that's what I told you. We use it for median now.
Okay, sir. Through a graft.
Through a graft.
Okay, sir.
Thank you.
Again, a non-vascularized graft.
Yes.
Okay, sir. Thank you.
Thank you so much. It was a really wonderful talk. I know there would be many more questions, but for the want of time, would like to move on to the next talk.
Good morning.
I'd like to invite Dr. Praveen Bharadwaj. He'll be talking on strategies for improving wrist and finger extension in patients with extended upper brachial plexus injury.
Okay, thank you, Gwen. I'll be talking about the role of tendon transfers in extended upper plexus palsy. This is again a small gray area in brachial plexus surgery, and there are many controversies in this because it is not a perfect upper plexus where the nerve transfer has solved all the problems, and the injury is a little more extensive than that. There is a continuing debate about whether the nerve transfer is better or a tendon transfer is better. But in this talk, I'll be stressing more on various tendon transfer options in these patients. We know that nerve transfers now are getting more defined in a pure radial nerve palsy, but still in a extended upper plexus palsy, it is not having that much great role and it is being defined. Now, when we come to tendon transfer, all the principles have come from the radial nerve palsy treatment. So it appears like just like a radial nerve palsy with the wrist, thumb, and finger drop. So at first look, it appears to be a simple thing because once we do tendon transfer in radial nerve palsy, we know that we can consistently get good result. But we should not forget that many of the radial palsy donors are not functioning in an extended plexus palsy patients. And they account for about 20 to 25% of the overall brachial plexus cases. We would note that C7 supplies the wrist and finger extensors and also supplies many of the donors which are being used for tendon transfers, like the pronator teres, the flexor carpi radialis. This has a good C7 content. So in a patient with extended plexus palsy, the pronator teres won't be working. The FCR won't be working. And if the FCR is not working, we are not supposed to take the FCU and palmaris longus, which form the main tendon transfers in radial nerve palsies. If one does take FCU and palmaris longus, we can have this volar instability at the wrist, because of which the finger extension does come, but it is only when the wrist is stabilized. Otherwise, the wrist will go in extensions and finger will not open up. So one easy way to take care of this lack of donors is to fuse the wrist. So once the wrist is fused, now the FCU and palmaris longus are available for doing a tendon transfer. That is the small general thought. The wrist fusion, yes, it improves the appearance of the hand and gives a very good grip strength. However, one loses the tenodesis effect, what you get when you do a tendon transfers in these patients. So the FCU, which is capable of lifting the fingers up because of its 3 excursion, cannot match to the original excursion of 5. So you would have only about 60 to 70% of opening up of the finger. So if the wrist is fused, our finger extension can never be complete with FCU. And also a fused wrist, many times the patient does not feel very comfortable with that, especially if you have done it on the right hand, they are not able to use the hand for accelerator when they are driving a bike, because these patients cannot compensate with the shoulder and elbow as well, because their triceps also is poor. And we have had a patient who was very upset that he is not able to drive the bike. So that is the reason we were trying to search various combinations to avoid the wrist fusion. And in our overall series of 78 cases where we did various combinations, we have come to this small algorithm in which we have divided them into 4 classes, and that's how we decide now these days. So if the patient has got a good FCU, FDS, and palmaris longus working, then these patients can be taken for FCU to EDC transfer. The palmaris longus is left on the volar side to act like a volar restraint, and that is enough to maintain the stability. The FDS middle finger goes to ECRB and ring finger goes to the EPL, and this is the kind of outcome we can get in such patient. Can see good independent extension of the wrist and fingers, and also quite a good extension of the thumb independently is possible. However, sometimes the FDS may not be strong enough, both FDS, so you can use the FCU itself to the EDC and EPL. This also can result in reasonable amount of independence for the thumb and finger extension, and you can get a good result like this. So this patient was very much able to do an independent thumb movements in this form. Now the palsy becomes little more extensive, where the FCU and palmaris longus are strong, but the FDS and FDPs are weak. So you don't want to take that FDS because finger flexion is finally more important than getting the wrist extension. So in such patients, we did just an FCU to EDC and EPL transfer. So only one tendon for all the things. So this transfer in radial nerve palsy is become a common trend now, and they say that the result is very good. But when we have done it for brachial plexus patients, they are able to open up their fingers, but the wrist is not so much stable. So when they are grasping anything, the wrist tend to sag down, but overall they are feeling that it is quite useful for them. Now the last combination is when the FCU also is not strong, but here the FDS and FDP are good. So you can take one FDS goes to the finger extensors, and other FDS goes for the wrist extension. And this is the type of result we can get. So the wrist is stable, the fingers are opening well. The patient does not have an independent wrist extension though, but they are able to open up the fingers for a grasping purpose, and they are quite happy. So this is the algorithm which can be used for patients with extended upper plexus palsy. And almost 2/3 of the patients, we will be able to get away with tendon transfers without having to fuse the wrist. Thank you so much. Any questions?
Any questions? Anyone?
Okay.
When you use toner for wrist extension and finger extension, in these cases, first you do transfer for wrist extension and tensioning for wrist extension.
Yeah, actually, ideally it is good to do the transfer first for the finger and then for the wrist, especially when you are using the FDS for both purpose. Because if you attach to the wrist first, the checking for the tenodesis effect becomes little difficult. So when we are doing FDS for finger and wrist extension, we will attach the finger first so that we can flex the wrist and see that the finger is opening up nicely, and then put it for the wrist.
Okay. Means when we use FCU for finger extension,
yeah, So FCU for finger extension, the tension parameters are very much defined. So in that case, we are not worried about whether the wrist and finger tension is too much. You can put the wrist first and then put for the fingers by holding the fingers in this position. But since the FDS tension parameters are not so much defined, first we can do for the fingers, because moving the wrist makes it easy to check whether the tension is correct.
So you mean first for fingers and then for wrist?
Correct.
Okay, thank you.
What is your post-operative protocol for splintage and physiotherapy and all?
Yes, sir. So all these patients will have a splintage in the form of cast for 1 month. And at 1 month, the physiotherapy is started. The first 2 weeks, the wrist is supported and only the fingers are moved. And at 6 weeks, the wrist movement is also started. At 8 weeks, that is 2 months from the operation, patient is left to use the hand completely, only to avoid heavy work for another 1 month. At 3 months, they can do anything.
What suture material do you use for repair?
Yes, sir. So the wrist extension side, it will be the 30 proline, and for extensor digitorum transfers, 40 proline.
Thank you so much, Dr.
Yes,
Dr. Praveen, for such a comprehensive algorithm. Vipin?
Now I will invite Dr. Satya Sarup Tripathi. He will speak on nerve transfer for functional restoration of upper limb functions in adult brachial plexus injury. Dr. Satya Sarup.
I'm going to present now transfers for functional restoration of upper limb function in adult brachial plexus injury. The aim of the reconstruction, to a man with nothing, a little can be a lot. The aim of the surgery depends on what is lost, what is needed, and what is possible. It is individual for each patient. What is possible is shoulder abduction, external rotation, shoulder adduction, elbow flexion extension, wrist extension, protective median sensation, and pain reduction. Aim of the reconstruction is always shoulder, stable shoulder with active with supraspinatus and deltoid, elbow flexion active with biceps, stable elbow with triceps, protective sensation and finger flexion with median nerve. Earlier, the nerve repair in the brachial plexus injury and waiting endlessly for the result to happen, the surgeons, they used to get frustrated. Then came the nerve transfer phase, where the transfer of a normal or near nerve fascicle to a more important sensory motor branch that has sustained irreparable proximal injury. Indications are irreparable preganglion injury, selected postganglion injury, and reinnervation for the free functional muscle transfers. Attributes are, it is closer to the end organ. There is more rapid and reliable recovery. Repair is done outside injured or scarred zone. There is avoidance of nerve graft and there is easy relearning. So intraplexus peripheral nerve donors are ipsilateral roots, ulnar nerve like ovalin 1, median nerve ovalin 2, nerve to long triceps with some sac transfer. The interplexal nerve grafting. Ovalin transfers described by Ovalin 1994. Ulnar nerve fascicle to biceps motor branch. 2 described McKinnon 2003. Median nerve fascicle to brachialis motor branch. So indications are like for the elbow flexion in C5, C6 injury, C5, 6, 7 injury with reserved median ulnar function, and the ideal duration is less than 6 to 9 months post-injury. So they are reliable, early recovery, technically easier, limited skin incision, and they are less invasive. The examples, and the branch to biceps is 12 cm distal to acromion, and the brachialis is 17 cm distal to acromion, and this is the anatomy, this is the position, skin incision, and the fascia covering the biceps inside and muscle is retracted laterally. And the branch to biceps identified, transected proximal from musculocutaneous, the distal part rotated medially towards the dissector ulnar nerve, and then 1 or 2 fascicles with adequate size. They are matched with the FCU seeing the contraction located anteriorly and medially within the ulnar nerve, and they are repaired done with 10-0 nylon with fibrillin glue added. Similar is the Ovalin 2 transfer. this dissection and transfer, seeing the functional FCR or FDS muscle stimulation, they are again cooperated with 10-0. This is the example doing both the transfers. And post-op care and rehabilitation, flexed arm is strapped to the chest for 3 weeks, gradually increasing passive exercises started at shoulder and elbow joints. Paralyzed muscle, they are subjected to electrical stimulation till M3 power is achieved, and earliest contractions they are seen by 2 to 4 months follow-up. And there is absolutely hardly any complication. Permanent deficits they are. Outcomes, they are reliable and early recovery within 2 to 4 months expected. Bicep strength more than grade 3 in 90% cases. And double nerve transfer is better outcome than a single transfer. Samsac transfer, there is 2003 Samsac transferred motor branch of longer triceps to anterior branch of the axillary nerve. And this is the anterior branch of axillary nerve. It restores the anterior, middle, and posterior parts of the deltoid. Posterior branch of deltoid is usually avoided. Donor nerve usually nerve to longer of triceps. It is a constant branching point proximally to the recipient, largest diameter offering to the best size match. A longer branch, most dispensable branch. Indications like C5, C6 upper injury, strong triceps, C5, C7 if tricep strength is good, and injury less than 6 to 9 months post injury, but contraindication if the triceps is less than M4. So this is the for anatomy. And dissection is the lift the posterior deltoid fibers, identify the quadrangular triangular space, and dissect anterior branch as proximal as possible, tag the anterior branch with vessel loop, and develop the plane between long and lateral head of triceps for gentle finger dissection. Electrical stimulus to confirm the strong contraction of the triceps. Then the long head of triceps nerve is caught as distally as possible. Anterior branch of axillary nerve caught as proximal as possible. Then they are sutured to tension nylon. So this is the post-op care, shoulder immobilized for 3 weeks. Gentle passive mobilization performed to prevent joint stiffness, no specific motor re-education necessary. Usually deltoid contraction noticeable post-transfer after 6 months. So outcomes, they are better in patient with C5, C6, and the isolated axillary nerve patients, Samsac transfer, deltoid power M4 achieved. So this is the patient example, upper brachial plexus injury, and this is the transfer done. Earlier, I used to do the posterior approach, and this is the sorry, the video is not working. Patient is doing normal agricultural activities. Extraplexal donors like spinal nerve, then intercostal training, cervical plexus, opposite C7. Ascent to SSN, we mostly know. And critical points, they are mostly commonly for upper plexus injuries, panplexus injuries, ideal for injuries less than 6 to 9 months old. The pearl is they spare the most proximal branch of SN and sufficient distal dissection for direct transfer of SN to SSN. Technical points use a transfer skin and transfer only the middle and distal fibers of the spinal nerve. So this is the transfer, and this is the panbrachial plexus injury, the transfer of the SN to musculocutaneous. Intercostal nerve to biceps branch of musculocutaneous. So the critical points: exposed 3rd to 6th intercostal through the inframed of the incision, proximal dissection of the motor nerve to the biceps, direct neurography of the intercostal without tension, repair with arm maximally external rotated and abducted 90 degrees. So this is the exposure, and this is the coaptation, and this is the recovery you can get. So modified, this is the anterior approach. Recently, this incision begins in the armpit and continues medial upper arm. Nerve branches to long medial and lateral left triceps identified, and the tendon of latissimus dorsi identified. Deep dissection made towards the medial border of latissimus dorsi, carduncular space palpated. The anterior branch deltoid muscle isolated, long head of triceps distally dissected and repaired. So this is the patient pre-op with upper brachial plexus injury. This is the exposure in the same incision which you give for the upperly, and then extended till axilla, and this is relatively easier. And this is the post-operative recovery you can see. And can you please see video? Patient is tying his own turban. Basically, videos are not. Anyway, I told you to check. Anyway, the patient is tying his own turban in his own hands. So this is another case of upper brachial plexus injury. And post the transfer, patient is doing his normal agricultural activities. Another patient, upper black plexus injury, post-transfer, patient is having normal activities, and you can see the normal gym activity. You don't have to tell any extra additional physiotherapy. He has to just move the arms, and you can get the post-operative results like that. So this is another example of upper plexus injury, post-nerve transfer. This is again paralysis suprascapular, some sac transfer, and only 1 and 2, and this is the post-operative result you can get. This is another upper plexus injury, and this is the post recovery. Patient is having absolute normal range of movements. Another patient, upper plexus injury, post-transfer. These are the results. So this is another interesting case. This patient, post-transfer biceps function, and we did that is for the wrist extension, that is a branch to coronary quadratus is we have given to that is ECRV, and we can see the wrist extension in upper plexus injury. This is another patient with phrenic to musculocutaneous and spondylosis to musculocutaneous. Phrenic to musculocutaneous, spondylosis to suprascapular. And this is a nerve where we don't have to educate the patient. Patient involuntarily and without any specific physiotherapy, he achieves good post-operative recovery. And this is the amount of recovery you can get with this transfer in panbrachial plexus injury. In panbrachial plexus injury, another is the contralateral C7 transfer, where we give maximum importance to the hand function recovery. So this is the patient, and this is the these are the incisions marked on table, and this is the exposure where we isolate this C81, then the spinal accessory to suprascapular, then phrenic to posterior division of lower trunk, and MABC to the musculocutaneous, and this is the amount of recovery. You can appreciate that patient is doing the opposite wrist movement to achieve this hand function of the opposite side. This is another patient where upper transfer, the upper brachial plexus injury, and post transfer patient is doing, my videos are not working, but he's doing all these natural activities like lifting bags, thrashing crops, crop cutting, plowing, milking of the cow. We don't have to educate the patient to do any particular physiotherapy. With normal agricultural activities, he used to get back all the functions. So to conclude, timely intervention, choosing the proper donors, and post-operative activities, which are very important. That is, no particular physiotherapy. Patient has to carry out his normal day-to-day activities to get back all the results. They are keys to successful outcome. I thank you for giving me patient hearing.
Thank you, Dr. Tripathi. Any questions from the audience? Thank you, Dr. Tripathi, for a wonderful presentation.
Thank you.
For delivering the next talk, I would like to invite my friend Dr. Amol Raheja, who's an additional professor of neurosurgery at AIIMS New Delhi, and he shall be presenting his talk on shoulder reanimation strategies for partial and panbrachial plexus injuries.
Thank you, Dr. Pantal. At the outset, I would like to thank the organizers, my dear friend Dr. Anil, for this opportunity. So I'll be presenting the shoulder reanimation strategy. Can we have the slides on the main screen? So I'll be presenting the shoulder reanimation strategies for the partial and panbrachial plexus injuries, which over the years I've learned from Dr. Sumit Sinha and Dr. Deepak Agarwal and in our department. So initially, the first thing is to understand the basic surgical anatomy for all the lateral and medial cord and the posterior cord before we dwell into a surgical procedure. So looking at the strategies for the C5-6 injury, if it's an early post-ganglionic injury, then you can do a C5 to lateral cord or upper trunk transfer along with a C6 to posterior cord. And if it's an early, if it's a late post-ganglionic or a pre-ganglionic injury, and especially in an old patient, you have a spinal accessory to suprascapular and medial pectoral or a triceps or a thoracodorsal to axillary nerve for shoulder reanimation. The SOMSEX procedure has already been briefly described. I'll be presenting a brief video to elaborate on the surgical steps for this SOMSEX procedure. So typically, I prefer using a prone position with a small hockey stick incision. Again, you can see both the divisions of the anterior and the posterior division of the axillary, and also the branch to the teres minor that is being shown here. So if the donor is a good donor, that is, if you use a long head or a medial head of triceps for a donor branch, you can actually use the whole trunk, because as has been shown by the literature, that if we can reanastomose both the teres minor and the deltoid, the power improvement in the long run is better. However, you need to weigh in about the quality of the donor that you have. Now, here you can see the long head, the lateral head, and the medial head of the triceps nerve are being delineated. Using the stimulation, they are being isolated. I prefer to use a long part of the medial head of the triceps branch for anastomosis, do anastomosis in a standard fashion, and then use glue to complete the procedure. For the spinal accessory to suprascapular nerve anastomosis, I prefer a dorsal approach, which I learned from Dr. Sumit over the years. And in this, again, you have to divide sharply the ligament over the suprascapular notch, below which the suprascapular nerve is present, which has to be slinged above using a right angle retractor. And adequate length has to be harvested so that there is a tension-free repair. Any anastomosis, if it's under tension, it's not going to work in the long run. It's a basic principle. And also key is to divide the muscle of the omohyoid to have an adequate length. This is a modification that I use. And once you have the adequate length, you can you can see that, and also the advantage of the dorsal approach is that you can see for any neuromas formation in the post-ganglionic injury, because many times the injuries are mixed pre and post-ganglionic, and especially in patients having a very severe road traffic accident or high velocity injuries. So you have to perform a tension-free repair. I tend to anastomose at least using 3 to 4 stitches for the nerve anastomosis, because many times you see that in front the anastomosis and the coaptation is appropriate, but when you look at the back side, usually there can be some amount of pouting of the nerves, and that can lead to loss of the neurons. So once the anastomosis is complete, you put a glue on top of it. Now, this is the position that I've already shown, and this is one of the example of the patients having improvement after the triple transfer, like Dr. Tripathi was telling. And similarly, another patient having a triple transfer with a C5-6 injury, you can see the gradual improvement over the year, over 18 months has been complete and has restored complete function. Now, looking at the C5-6-7 injury, over and beyond what you do for C5 and C6 injuries in an early post-ganglion, you can actually use a C7 route to anastomose it directly to the posterior cord or the middle trunk using a MABC or a sural nerve interposition graft. And if it's and for the shoulder stabilization, the procedure remains more or less stable. However, you have to add some additional nerve transfers for the elbow extension. Just a brief video of how to perform a medial pectoral to anterior division of axillary transfer, just showing the basic steps which can be helpful to the young faculty and the residents out there, if there are any, so that the surgical technique is important, the basics remain the same. And initially I was holding the medial pectoral nerve, which can be isolated, and this is the axillary nerve. The anterior division of the axillary is being harvested, and attention repair is being done. Again, you have to freshen out the margins so that the anastomosis is done in a seamless manner. And then you can see that since it's a small donor nerve of the medial pectoral, it's better to use only anterior division of the axillary rather than using the whole trunk. So for each case has to be individualized. There is no one size which fits them all. So it's always a variety of combination of surgical technique that you have to use in these patients for an optimal outcome. Now, this is again some example of the double transfer of the SN, and this double lobulin is done. Patients having some recovery. The elbow extension procedure was not done in these cases. However, recently started doing that in my practice. Now, the strategies for the C8T1 injuries revolve around more distal transfers for the AIN and the PIN, for the median and the radial nerve respectively, and even a contralateral C7 transfer can be done. Now, for the global palsy, Dr. Hari very carefully mentioned, very nicely mentioned that first stage is, of course, the nerve transfers, including the extraplexal nerve transfers, and then you can proceed with the second stage functional free muscle transfer in our setup. So for shoulder stabilization, you start with spinal accessory to suprascapular nerve, and then contralateral C7 to lateral posterior cord, and you can use intercostals for elbow flexion as well as elbow extension, depending upon your preference. Now, in few cases where there is a post-ganglionic injury and there is a route which is present, which is a viable route. I used it in a couple of cases, and C5 route was used for using interposition graft of sural nerve graft and MABC. We had about 45 centimeters length in total, and we used that for various anastomosis as mentioned here for a complete recovery, for attempting to complete recovery. This was a complete exposure given in that patient. Just a brief video of how we perform the motor intercostal nerve to anterior division of the axillary nerve anastomosis. Again, this is done for a pan-brachial plexus injury patient. A careful dissection of the two divisions of the axillary is important in this patient because the intercostal nerves are very, very small. So you don't want to use, divert all of the nerves towards posterior division as well, because which has some amount of sensory nerves as well. So you divide an adequate length of the axillary nerve as can be shown here. And sharp division using a scissors is important. Now here you can see using Dr. Bhandari's splint and weld technique of anastomose. In the center part can be seen as the intercostal to 3 intercostals used for musculocutaneous, and then the sensory neurotization also done for the lateral root of median nerve, and which helps to restore the sensation, and which is important in pan-BPI patients because they often come with insensate limbs and has a lot of burns and other traumas which they cannot perceive. So again, using splint and weld technique, these are the 2 intercostal nerves are being harvested and being anastomosed to the anterior division of the axillary nerve. This was done just a few weeks back, actually. So I don't have any follow-up for this patient as such. I'll be showing some other follow-up videos after that. So again, the anastomosis has to be done in a careful manner, a meticulous anastomosis using a tenos suture, just like you perform microvascular anastomosis. The attention to the attention to detail is paramount, and you don't restrict yourself by just putting 1 or 2 stitches. This I've learned from actually while visiting Ganga hospital in a few years back in an Ispnscon conference, that you have to suture it well so that even during the rehab procedure, during the active and the passive limb movements, there is adequate tensile strength to hold the sutures together with each other. Just putting a glue might not be sufficient in many of those cases. So these are some of the cases just with the pan-BPI patients and kids and adults where we had reasonably decent outcome. And then we refer to our colleagues, Dr. Hari, Dr. Raj Manas in a plastic surgery department who take over the mantle of doing a second stage surgery in these patients 3 months later. And for that, free functioning gracilis transfer, tendon transfer surgeries, etc., are advisable and being done by them. So the take-home message is a detailed understanding of the surgical anatomy is paramount. So as a resident, as a young fellow, young faculty, you need to literally do the cadaveric studies, look at your basic Snell's anatomy or Gray's anatomy books, and then understand the surgical anatomy from all the aspects, from front, from back, and then look at the treatment strategies. It needs to be individualized. No 2 patients are same. Strategize your treatment individually based on each patient's requirement and try to give your best. It may take many settings, it may take many hours, but I think it's totally worth it. And then meticulous surgical exposure and coaptation is again paramount before, of course, the rehabilitation part kicks in. You need to have a consistent follow-up with them and a good rehab team for having an optimal outcome. Thank you.
Thank you, Dr. Amol. That was a really nice presentation. This paper is open for discussion. Any questions? So if there are no questions, I'd like to ask you one. The issue of placing multiple sutures is controversial, if I am correct.
Right.
It has the theoretical concern of giving rise to more fibrosis there, eventually impairing the very idea of why you actually put it in the beginning. So how much is enough according to you? How many sutures should we put?
I think visual impression as a surgeon, once you feel that the nerves are well coapted, whether it's 6 or 4 or even 8 sometimes for big nerves, I can do that. But the idea is, and you have to do an epineural anastomosis under high magnification so you don't damage any fascicle. If you do take the fascicle bundle along with it, then you're going to damage with each bite. And in some nerves, you have to do out in technique rather than out in and out technique because some of the fibril nerves, like for Oberlin type 1 and type 2, because this was not elbow flexion, so I didn't show the videos for that. So my talk was mainly for shoulder approximation. So that's why I think it's not just the numbers, the way the technique is more important. And if you're meticulous enough, you don't leave too much of a redundant nerve material, then the fibrosis chance is less. And I think my improvement rates, of course, it's a limited experience because we go just a few times a year there, but in the trauma center, but it's been reasonably okay.
Thank you so much. Thank you.
Thank you.
I'd like to call the last speaker of this session, Dr. Deepak Agarwal. He'll be talking on nerve transfers in cervical spine cord injuries.
So good afternoon to everyone and to the chairpersons. This is an interesting topic which I had kept, transfers in spinal cord injury. And we all know Christopher Reeves, who's a very famous personality who became tetraplegic. And despite everything, he died within 2 years of his injury. So what we need to know is in cervical spine injuries, 2/3 will involve the C5 vertebra, which translates to C6-7 spinal cord. And any injury in the spinal cord will lead to 3 discrete segments. One is the supralesional segment, which is the segment above the damaged level. One is obviously the damaged segment itself, which is called the lesional segment, and then we have the infralesional segment. Why we are wanting to have recovery in these patients is because they want it. Almost 80% will want improvement in the hand function. That is the top priority for spinal cord injury patients. And most of them will believe that by giving them some function in the hand, they are going to have a better quality of life. So as we have discussed many times since morning, obviously you need a muscle power of at least MRC grade 4 to take a part of the nerve from that muscle. And ideally it should be in proximity to the donor nerve to avoid any delay. Various studies have shown that all this nerve transfers should be done within 1 year to the damaged segment. Otherwise, as we know, denervation can occur, but I will expand on this a little later. This is, if you look at this figure, you can see that C7, if it's the damaged nerve out here, we can take the C5 and put it across to either the damaged segment or to the segments below the damaged segments. And when should we be doing it? Ideally, we should wait for at least 6 months for some spontaneous recovery to occur, because if it doesn't occur within 6 months, it is unlikely to occur. However, and this is the most important part which I want to put across, the infralesional segment, the whole spinal cord below the level of the injury, the roots are intact of those levels, the muscles are intact. So there is no Wallerian degeneration occurring, nothing happening out there. The spinal reflexes are intact. So even from a supralesional segment to an infralesional segment, if you do any anastomosis, any neurotization, it may work even decades after the actual injury. This is the key take-home point which I want to put across. And when we talk about what is most important for these patients, obviously the first priority for us is elbow extension, followed by pinch, followed by grasp. And obviously for elbow extension, in these patients, usually shoulder function is preserved and elbow function is also preserved. So if these two criteria are met, then only we can think about having elbow extension also. And the teres motor branch can be used to the axillary nerve to re-innervate. The pinch is usually done by the brachialis to anterior interosseous, as Amol has also said. And this is just the anatomical figure showing how it is done on a cadaver. For the pinch, we'll need a ECRB to the FCL anastomosis. And this shows the anastomosis. For the thumb and finger extension, we use the supinator motor branch of the posterior interosseous nerve. And the reason is both these branches have almost the same number of myelinated axons amongst them. Now, for these cervical spine injury patients, can we innervate the diaphragm also so as to remove, if they are ventilator dependent, the ventilator requirements? Yes, we can do that, provided this injury is totally not encompassing from C3 to C5, because that's where the innervation comes from. And there will be Wallerian degeneration in those segments. But if any segment is preserved, this can be thought of. And in fact, we have put in phrenic nerve stimulators in couple of patients over the last decade. Of the 2 patients, 1 patient could be weaned off the ventilator, and discharged home just on the phrenic nerve stimulator. And we have a follow-up of that patient over 10 years. And that patient is doing well in terms of being ventilator free. For paraplegics also, we have many options, especially for, bed sores, which is very, very common. And although plastic surgeons think of musculoskeletal flaps and other flaps, if we can restore sensory function, then I think it will be better, and the chances of the flap giving way will be less. Bladder re-innovation is again a very important on the wish list of these patients in terms of bladder function. And there is another talk today about bladder re-innovation, which I'll take. And there have been studies which have shown that you can recreate the reflex arc of the bladder, again using the same principles we have discussed in this talk, so that bladder function can be attained. Even in conus medullary injuries, intercostal to the intradural S2, S3 nerve root anastomosis has shown to re-innovate the bladder function. To conclude, nerve transfers are a viable option for restoration of critical upper limb function in spinal cord injury patients. And this technique remains in infancy, but it is important for all of us to know that these techniques exist so that we can at least think about them, even in tetraplegic patients. And these, we have so many spinal cord injury patients coming in. Attempting all these techniques will also increase the skill level, besides providing a very important function to these patients. So I invite everyone for our neuromodulation and pain workshop, which is by the Ispnscon Society, and will be held from 3rd to 5th May. And we have the brochures outside. So thank you so much.
Thank you, Dr. Deepak, for a great presentation. Any questions from the audience?
Congratulations, Dr. Deepak. It's an innovative thought. I'm only wondering, is it an complete spinal cord injury in that you are talking about the intercostal nerves transferred to the sacral nerves?
Intercostal nerve transfer is for paraplegics, sir.
Okay, right.
So I first talked about complete spinal. This is for complete spinal cord injury. The first part was on high cervical spine injury.
Right.
And the second part of the talk was for lower, for the paraplegics who had upper limb function intact and thoracic function also intact.
Now, what about the partial cord paralysis? In that, how is the functions? Because most of them have a lot of spasticity.
Yes, sir.
And how does it come in the way when nerve transfers are being done?
Yes.
Without spasticity relief.
For partial spinal cord injuries, obviously we have to wait to actually assess the recovery of whatever segments were damaged. And once we have waited for that period, let's say 6 months to 2 years, the way of treatment remains the same as I discussed. So that means for upper cervical, we can do all these procedures. If there's partial injury, what I mean to say is, if we thought initially C5 root was gone and it came back after 6 months to 7 months, we may be able to use C5 for reinnovation.
In paraplegics, what is your experience with the genitourinary dysfunctions?
So we have done some studies on it, and that is another talk in today's next session. So I will show you what we have done to reinnovate the bladder in that.
Thank you. Good.
Thank you, everyone. Now we will conclude our session. Thank you all the speakers and my co-chairpersons. Thank you very much.
Thank you, respected faculty, for chairing this session. We'll be skipping the tea break and moving on to our next session, which is a presidential oration. I'd like to invite Dr. Hari Venkatramani sir and Dr. Deepak Agarwal sir as chairpersons, and Dr. M.S. Gopalkrishnan to introduce our orator, Honorary President of Indian Society of Peripheral Nerve Surgery, Professor Dr. B. Indira Devi.
So, good afternoon, everyone. It's a privilege indeed for me to introduce Professor Indira Devi, President of the Association. Indira Devi had a sister. She is born in Guntur, Andhra Pradesh, to Shivaramakrishnan and Annapurna. And she did her MBBS in Andhra Medical College, inspired by her grandfather who told her to become a doctor. Then she did in PGI Chandigarh, both her MS General Surgery and MCH Neurosurgery. That's her graduation picture. And she had a closely knit group of friends, both at the PGI Chandigarh. Atul and Rajesh went on to do neurosurgery, and you can see her pathology colleagues, Ruma and Radhika. She joined NIMHANS in 1993 as an assistant professor, where she honed her skills and extended her repertoire of surgeries. And for the next 30 years, she built up the subspecialty of peripheral neurosurgery. She considers Professor Kak and Professor B.S. Das as her mentors and teachers. And there you can see Professor Das passed away recently. And this is our gang, who are also my teachers. You can see Hegde, Praharaj, Indira, Aaron Mohandeep. Some of my our residents are here. And over the years, lots of residents have gone through that pipeline, which is NIMHANS. And we are also there. And she has taught over 100 residents and almost single-handedly pursued surgeries of the peripheral nerve and craniovertebral junction. Craniovertebral junction, of course, PSCM also was operating. And after B.S. Das left in 1996. So that's, I also had the privilege of doing a thesis with her. I'm a student, and Kapal Tunnel and Alna. She has been the chairperson of neurosurgery curriculum with the MCI from 2010 to 2015. And for example, she converted this the MCH curriculum into a single thesis topic, which is a good thing. Too many thesis topics are also not good. Introduced basic science exams so that at the first year and only 3 papers at the exit exam. And she was the controller of exams and dean of faculty neurosciences from 2019 to 2022, where she made significant changes to the PhD neurosciences program. But everything nice had to end. And so she retired 30 years later after being head of department for 2 times. When we talk about her, we have to also look at women in neurosurgery. You can imagine how difficult it was and for a woman to become a neurosurgeon 30 years back. Now there are lots of women coming into neurosurgery. Even now, there is only 3% of the neurosurgeons are women. So there is a lot of challenges she would have faced, and I'm not sure whether she will talk about it or not. And they have Women in Neurosurgery has got an association, and she has written in that Neurology India paper about her opinions about women in neurosurgery and the association. She said that the issue with the discrimination and solutions created is it obviously has a tendency to produce even larger divide. Yes, and you could also read about her biography of international women leaders in neurosurgery, and she is one of the leaders and with a lot of leadership qualities. And Dhananjay has written about her in Neurosurgery Focus. She has lots of energy. In fact, during her residency, people used to ask her to take calls because she'll always be available and she'll be the favorite person, so that you can dump the calls on her. But she liked all that. She's resourceful, she's kind and firm at the same time, and she's no-nonsense, very assertive, sometimes too assertive, and highly perceptive. And she's a friend. And she likes a lot of surgeries, almost all surgeries, but she has her favorites like craniovertebral junction surgeries, vestibular schwannomas, brachial plexus and entrapment neuropathies, spinal intramedullary tumors, which she has published some. She has been involved in lots of research, including regeneration of the pre-treated allografts in rats, which loses their antigenic property, and you can use it as a nerve graft. Amniotic membrane wrapping, which she said was not very useful. She has done recent studies on fMRI to show the plasticity when you do brachial plexus grafting, and about the gender differences and differences in aneurysmal rupture. And recently, she has published, she has been one of the lead investigators in the major trial that had ended and is published in 2023 about decompressive craniectomy versus craniotomy, a big thing in neurosurgery, showing that there is no superiority of decompressive craniectomy, but only side effects and the problem of a second surgery. This is a practice-changing landmark trial. And currently, she is about to spearhead a new multi-center trial to see if hinge craniotomy, which opens up for when there is intracranial pressure, is better than decompressive craniectomy in association with the National Institute of Health and Care Research in UK. So she is there. We would welcome Professor Indira Devi, exceptional by choice and exceptional by design. Please.
Always say payback time. As I finish my tenure of president of Ispns, I wish to put on record my gratitude to my teachers, my colleagues, my residents, and God overhead. First of all, for all that I had gone through, it has been a wonderful journey. I enjoyed every moment of it. And being a female in neurosurgery is another story. Today we are going to talk about peripheral nerve surgery. So let's start at the very beginning. Injury to the peripheral nerve, it puts into effect a cascade of events, both antegrade and retrograde, and not to forget the transneuronal degeneration and the death of neurons if it is a large nerve with loss of large amounts of exoplasm. So each of these aspects will affect whatever you do, whether the regeneration is spontaneous or surgically manipulated. So we talked about this from the from the surgical reluctance for rewiring. We called it the road less traveled. We said that there are several considerations when to operate, and then the surgical intervention may be indicated only when there is little evidence of progressive spontaneous recovery of motor and sensory function by 3 months following the injury. Of this we are talking about when we know that it is not an avulsion injury. And the early surgical exploration, of course, is indicated when there are open injuries. Otherwise, for traction injuries, you need to wait and watch and pray, both by the patient and by the surgeon. And we feel that the cortical plasticity is a key factor in determining the prognosis of the sensory motor abilities following the nerve injury and repair. So brain imaging studies, they will provide the evidence following linking the functional outcome of with the brain plasticity. In brachial plexus injury due to traction and traction in road traffic accidents, multiple levels of critical injury to the nerves has to be kept in mind. It is not as simple as this is the level of injury and that therefore I address that level. So still your outcomes may not be up to the mark, because you would have left the multiple levels of injury which you have not yet picked up, or you have not paid attention to. So the preoperative investigations, the electrophysiological investigations, and then the autonomic dysfunction which happens along with the injury to the cervical roots may give some amount of insight into what exactly is happening, and whether we can predict that this patient may have pain, dysesthetic pain at a later stage, or he is likely to recover. And of course, the fMRI and DTI studies will tell us what is happening at the central cortical level. So basically, both these are end organ investigations. Whether you're talking about in ENMG and QSOT, that is the motor and the sensory functions and sensory target organs you are investigating. And then the fMRI and DTI studies will tell you about the central processes. Those are also so-called end organs or primary organs. So we had been discussing with our neurologists and regarding when to do the ENMG, because many times you would do it immediately after the injury, which will not tell you always the true story or the extent of injury to the nerve. What happens in this is that one has to keep in mind not only the neuropraxia, but also a term known as extended neuropraxia. So the best time to schedule an ENMG would be beyond 6 weeks, which would be beyond the extended neuropraxia time. The and in the study in which we did the autonomic dysfunction, which we had studied with the pseudomotor axon test, was we could find that the sweating was decreased on the side of the complete brachial plexus, and in many of these patients may go on to have dysesthetic pain. So what do these fMRI studies tell us? The problem with the fMRI studies is that You have to know when exactly to do, and it is not a one-time study. You need to do it multiple times. That is, it is a longitudinal study. You, whenever you do the test, fMRI and DTI studies, you do at the beginning of the introduction to the patient. That is, that soon after the injury or 4 to 6 weeks later, whenever he comes to you, that is the first time to do. Put the patient on range of motion exercises, and then while you are waiting for it, and then after that, schedule the surgery. After the surgery, once the patient starts recovering, that is between any time between 3 to 6 months to 1.5 years. You keep repeating this, then you will find what are all the changes occurring in the central nervous system following the brachial plexus injury. So we said that because some of the studies would show that there is a loss of volume in the corpus callosum, and then in the same similar set of patients, somebody else would publish that the volume may not vary so much. But no one is talking about the time at which the fMRI studies or volumetry has been done. So we said that there should be some type of a consensus. So the consensus would be that at about 6 weeks, you do the first one, you do it at 6 months following surgery, then you again do it after 1.5 years to 3 years. So the first one of the first pictures, first papers we had. So don't go on. One of the first ones we had published was on the cortical reorganization following neurotization at diffuse tensor imaging. The very interesting findings we got in this was once the intercosto-musculocutaneous nerve reinnervation happens, the initial regain of function is through the donor synkinetic action. That is, the patient takes a deep breath and initiates the flexion of the elbow. And at that time, if you did the fMRI and DTI studies in these patients, it would show that the activation is happening at the intercostal area of the brain, of the motor cortex. But as the time passes, that is, when you repeat the scan, repeat the fMRI after 1.5 years, the activation shifts back to the intercostal from the intercostal area to the area of biceps, elbow flexion. So though the neurotized donor, neurotizing donor is the intercostal nerve, the reorganization has occurred so that it is shifted back to the elbow area. That is quite an important aspect of this. This paper was under the concepts, innovations, and techniques. It had come under that heading in neurosurgery. So we were talking about the preservation of the peripheral end organs and the central one, and then we also tried to learn when exactly would be the actual timing, because there are so many patients who would turn up at various times in the following their injury. Some of them would be beyond 2 years and 3 years also, and many of them are so desperate, please do something, etc. And if you so you need to decide what exactly you want to do, and after discussing with the patient, if you feel okay, since it is not going to cause any harm, let us do the intercostal musculocutaneous neurotization. If it works, let it work. And to your surprise, you might find that about 20 to 30% of the patients, even beyond 3 years, 2 years, may improve. So we looked into this aspect as well, and and then this is one work on cold preserved allografts in rats. We had used both Winster rats and then Sprague-Dawley rats, and then crossed over the nerve taken from the Winster, and we had transplanted into anastomosed across the gap in the nerve in Sprague-Dawley. And then, so we had divided into the various groups. One of them would undergo immediate anastomosis. That means without treating it, pre-treating it, and then the other group would have a delayed repair with pre-treated grafts. These were stored in normal saline for 21 days at minus 4 degrees centigrade. So in those with pre-treated allografts, even with across Sprague-Dawley and Winster, what we have found is the regeneration across the graft is acceptable, and then the step length ratio had improved quite well, thereby showing that the storage of these grafts at minus 4 degrees in normal saline would decrease the allogenicity of these grafts. In this work, which is again in an MCH thesis, we had tried to see whether the glue was useful or not. And in one of the groups in which only glue was used without any suture, what we have found is that there was separation of the ends with and then there was, I mean, it could not regenerate across the gap. Whereas where we had done a hybrid technique, that is placed one suture, and then the rest of the sutures were exempted by putting the glue, then there was a better regeneration across the gap. So basically, the glue itself may not be binding totally. So it needs some kind of a anchoring. And as we all know, the epineural sutures would not create as much inflammation and obstruction to the anastomosis. We also know that the nerve is 90% connective tissue and only 10% is neural tissue. The neural tissue, of course, are the fascicles. So any amount of whether you place the sutures or don't place the sutures, once you cut the nerve, there is likely to be quite a bit of inflammation and quite a bit of fibrosis. So the additional fibrosis which we fear may happen can be prevented by placing the sutures as only in the epineurium. So how do we assess the outcomes? We try to reassess the outcomes not just by improved, not improved, or patients who had MRC grading of 1 and 2 or even 3 minus after surgery. They were all labeled in our assessment as neurologically improved. Only the functional functional outcome was graded as useful when it is 3+ or above. And this was discussed in our paper published in 2007. And it was one of the comments is that it is one of the most honestly reported outcomes following the peripheral nerve repair, and it also formed discussion for one of the sessions in the WFNS interim meeting at 2007. And then the other way you can measure your outcome is by the MRI imaging techniques, like I have said earlier. The cortical reorganization and the area of activity of the motor cortex and the sensory cortex can be easily be picked up, and then by the fMRI and DTH studies. And also the corpus callosum volumetry is one of the quite exciting things we discovered for ourselves. That is the whole of the corpus callosum is divided into the parts. It is called parcellation, and then it is 1, 2, 3, 4, and 5. So these are according to the areas connected to various parts of the brain. The 1, 2, 3 are connected to the prefrontal, frontal, and motor cortex. And of course, the area of 5 would be to the association, posterior association. And this, and then we also had worked on the birth brachial plexus and then compared them with the adult brachial plexus, because what was our hypothesis was that in birth brachial plexus, the injury is occurring to the limb at a time when the myelination is not complete. So what happens to the motor cortex, and what happens to the sensory cortex, and what happens to the white matter transmitting area, that is the huge corpus callosum? What happens to this? Will these changes in the various areas of corpus callosum, that is according to parcellation, will be the same, or will it be different in children versus adults? And then we also looked into the mechanism of dysesthetic pain, and then we suggested that one of the mechanisms of the dysesthetic pain may be because of the bombardment from the of the antidromic impulses from the dreads area, from where the roots have been avulsed due to the injury. And then so we thought that if that is so, the dreadsotomy should address this by preventing the bombardment. If we address the empty dread space, that is from where the roots have been avulsed. And then so we try to quantify this by looking at the clinical outcomes prior to clinical assessment, prior to the surgery and post surgery. And simultaneously we did fMRI and DTH studies, and then what we found is the cingulate gyrus and the motor cortex motor cortex representing the upper limb, which has been injured. That means opposite to the side of the injury. That it does not have the representation from the motor cortex at that time. So what has happened? But the antidromic impulses from the sensory side are still available for activation of the sensory cortex. So not only the sensory cortex gets overactivated, but we see that the spillage, activation also occurs on the motor cortex. So what we proposed was that that is the reason the patient is able to feel the pain, whereas he cannot feel the touch. So by doing rhizotomy, what we are doing is preventing these antidromic impulses to impinge upon the not only on the sensory cortex and also the cingulate gyrus and the whole of the limbic system, but it also is preventing it from activating the so-called empty motor cortex representing the limb. So that's what exactly we found in our fMRI studies. So this is the paper I was talking about. This is brachial plexus injuries outcome following uretization with the intercostal nerve, and this has shown that here what we have done is we had used only one intercostal nerve. What our hypothesis has been that it does not matter whether the donor nerve is of the same size, number, so on and so forth with the recipient nerve. It is the connection with the neuron which is important, and that is what we have demonstrated here. Here, about 62% had observed had achieved useful recovery. In 2019 January, we had a special supplement on peripheral nerve injuries, and then I was a section editor, and then along with many of my friends, starting with Raj Medha, Dhanjay Bhatt, Deborah, and Mariano Sokolowski, Salik, and Ketan Desai, Anil Kumar, and Gopal Krishnan. And in that, Professor Mehta was also one of the contributors for that issue. And then he and Dr. Sumit Sinha had talked about the contribution of aims for the peripheral nerve surgery. And I would like to tell something more about my birth brachial plexus and traumatic brachial plexus injuries in children. And this we had compared with head injuries. Means does the brain react in a different way? Well, if it is brachial plexus injury versus head injury. Head injury in which there are actually no deficits, but it is a diffuse injury. And this is part of our DST project, and in which we had concluded that the volumetric loss in corpus callosum following the birth brachial plexus is slightly different from the brachial plexus injuries which occur in children much later. That means when the child is in between 5 to 15 years or 18 years of age. What is the difference here in whereas in the birth brachial plexus, what happens is that the areas of 1, 2, and 3 of corpus callosum are show volumetric loss, in traumatic traumatic brachial plexus injuries in children beyond the myelination age. That means between the end of second year. Then means completed walking and talking and doing all sorts of small tasks and all. Then the volume loss is from the mid segment and the posterior segment. This paper is set to be published. Then our experience with peripheral nerve injuries in children, what it showed was that majority initially were of injection pulses. And so what is and these were mostly into the gluteal region, upper and outer quadrant. So therefore the common peroneal nerve was mostly involved. As we all know that the sciatic nerve shows clear bundling right at the sciatic notch into the what's a hamstring area, and then the what's a medial okay, and but the lateral most is the common peroneal, so it always gets injured. So now the following are multiple papers on this, in which we've said that the injection injuries can be prevented, and so that we don't need to treat them at a later stage. What we said is that in children with very less subcutaneous fat and muscle, what we need to do is to give the IM injection into anterior thigh, anterior part of the thigh, to prevent the injection pulses. And then we also said that it should not be given into the arm, so that we can prevent the injury into the radial nerve. And then if there is a if an injection injury occurs, it is the duty of the doctor who is prescribing the injection to be aware of it and to address it immediately, instead of washing it off and then pushing it under the doormat. What needs to be done is the child or patient, even grown-ups can have, especially without any subcutaneous fat. And these patients need to be referred to a treating surgeon who needs to explore it immediately. If these things are happening immediately after the injection, they need to be addressed immediately. Otherwise, if the problems are happening at a later stage, that is due to perineural fibrosis. Whereas here it is due to the injection into the nerve, and what it needs is exploration and washing and thorough washing and internal neurolysis. And then I would like to talk about the bilateral carpal tunnel syndrome, which we are generally seeing in children with storage disorders. And usually this problem is not addressed in children, because whatever deformities we see in these children, we feel that and then both the pain and the deformities, we tend to say that this is due to the storage disorder. But many of these children have better functional use of the hand, both because of the pain and etc. I mean, relief of pain, etc. When we do the release of the carpal tunnel, not only the carpal tunnel, but even the cubital tunnel sometimes needs to be released in these storage disorder children. In this entrapment neuropathy studies, which Dr. Gopal Krishnan has done, in that what we have found is in some of the cases which were due to Hansen's disease, during the treatment or before the treatment, there is anesthesia along the ulnar nerve supply, but after the treatment, the patient may have painful ulnar nerve neuritis, and in both the cases, release of the cubital tunnel usually relieves the symptomatology. That is, of course, the anesthesia doesn't get relieved before the treatment, but at least you will have the diagnosis, and some of the deficits can be averted. That is, the claw hand is much less common if you do the cubital tunnel release at an early stage. We have talked about this animal models. We have used it for nerve injury, but we usually prefer the Sprague Dolly rats because they are quite tame, whereas the Windsor rats are quite restive. They can bite you anytime, and then they'll try to run away. This plexiform neurofibromatosis is a difficult decision. How much to remove, what to remove, so on and so forth. Many of these MPNSTs, they may be, if especially they involve the brachial plexus, they are one of the most difficult ones to treat, in the sense, usually the patient does not survive beyond probably 6 months to 1 year. But again, depending upon the type of sarcoma you manage to diagnose in this, that will either further shorten or maybe marginally lengthen the outcome. And I would like to bring to your attention that only a few neurosurgeons are practicing peripheral nerve surgery or getting trained in it, with occasional exceptions. And this reluctance is a matter of is not a surprise, but it is a matter of much concern. And then they tend to worry about the invasion of the neurosurgery by the ENT surgeons, and taking over the skull base, orthopedic surgeons dominating the spine, and even the traumatic brain injury and the traumatic spine is being taken over by the trauma surgeons. But however, they either seem to be indifferent or resigned to the fact that about the challenges and opportunities in peripheral nerve surgery. And I have told rest of the things I have already covered. And I wish to thank my teachers, both Professor Das and my primary teacher, that is Professor V.K. Kak at PGI, for all the training they have given, and attitude and enthusiasm they had encouraged, and kept following up my career. Thank you all. And I thank the society, and I thank Dr. Anil Sharma for taking up this, hosting this conference. And thank you all for your patient listening. Thank you.
I would like to request our chairpersons to felicitate our Honorary President of Indian Society of Peripheral Nerve Surgery, Professor Dr. B. Indra Devi. Next session is Professor A.K. Banerjee oration. I'd like to invite Padma Shri Dr. V.S. Mehta, Dr. B. Indra Devi, Dr. Anil Kumar Sharma as chairpersons on the stage. I'd like to invite Dr. Deepak Agarwal for introduction. I would also like to invite Dr. Sumit Sinha on stage for introduction of the orator. Dr. Professor Anil Bhatia, kindly come on stage for orator. Who is
I welcome all the chairpersons on the dais. And
very important.
today's oration, faculty colleagues, chairmen, and ladies and gentlemen, is named after Professor A.K. Banerjee, also known as AKB to most of us. Dr. A.K. Banerjee did his schooling from Allahabad and did most of his medical training, including MBBS and MS, from KGMC Lucknow. And at that time, KGMC was considered the top medical school in India. He went on to do there was no MCH at the time, it was known as MS Neurosurgery from CMC Vellore. And he was appointed as lecturer in CMC immediately after he finished, where he continued for a year and then moved on to AIMS, which had recently been set up, and then continued in AIMS New Delhi for the next 30 years. And it did not stop there, because he rose to the topmost, I would say, echelons, became the chief of Neurosciences Center, and then became emeritus professor, which he remains till today, and we hope for a very long time. The important thing to know is that age is just a number for Professor Banerjee. He continued to be very active. When I joined as a resident in the year 2000, Professor Banerjee had already retired and he was working as emeritus. Yet he was very active for the academic rounds and used to interact, knew every faculty and most of the residents, and still knows most of us. So that is the amazing personality Professor AKB was and is. He actually did his fellowship in London and set up departments of neurosurgery in other countries, including Iraq and Libya. He has delivered himself many orations, including Dr. B. Ramamurthy oration at NSI, Dr. L.H. Lobo oration in Ludhiana, and Dr. T.K. Ghosh oration in Ranchi. He has obviously been the president of many society, including NSI in 1991, ISPN, Skull-Based Surgery Society, and the Neurotrauma Society. Besides this, he has been the founder member or the actual founder of NSI, besides other societies. He's also been the founder president of the Indian Society of Cerebral Vascular Surgery. At AIMS, he initiated microneurosurgery. Prior to that, we were not using microscope. So he is the true initiator of microscope in neurosurgery at AIMS, New Delhi. He started transfemoral surgery, brachial plexus surgery. He was a big proponent and actually spread it, motivated. Brachial plexus surgery is which you need to motivate your colleagues and resident. It is passed down in hierarchy to the junior most, and he made sure that it was there till the highest levels. People, even Professor Mehta used to, when I joined as resident, Professor Mehta used to do brachial plexus surgery, despite being head of the department. And he also started aneurysm surgery and the experimental neurosurgery laboratory, which was known as Animal Lab at that time, under neurosurgery. And obviously, as you can see, he has been an innovator, a conceiver. He conceptualized a lot of things. He conceived the idea of a neurosciences center, and conception without practice is hallucination. So he was not high. He actually made it happen. He made the neurosurgery department, the neurosciences center. He actually created the neuroanesthesia and the neurology center or the departments at AIMS. Besides the Gamma Knife Center, in which he was instrumental, he started the DM courses and the animal labs, as I said. What he considers the crowning jewel is that he could actually have the WFNS, the World Congress, held in India, in Delhi, in 1989, which was a very big thing. More than 1,000 delegates attended. And that he considers that he could manage to get the world's attention back on India. And then he set up the WFNS Trust, through which he has assisted hundreds of neurosurgeons in attending conferences and getting fellowships. So I, along with all of us, bow down to a great teacher, mentor, educator, innovator, who really showed us the way in what we can achieve if we would like to achieve anything. And I welcome our orator, Professor Bhatia, on which Dr. Sumit will be introducing. Thank you so much.
Yeah, first.
Hello, good afternoon, everyone. Well, it's been a wonderful pleasure and privilege to introduce this year's Professor A.K. Banerjee orator. And needless to mention, this is a very prestigious oration. As the name goes, Professor A.K. Banerjee, and it's been since the inception of Indian Society of Peripheral Nerve Surgery. They've been delivered by very, very famous personalities across the world, including, and naming a few, is Dr. Mariano Sokolovsky, Dr. Alex, Dr. Deborah, and many others. And carrying the legacy forward, we have today none other than Professor Anil Bhatia to deliver this oration. And let me have the pleasure and privilege to introduce this magnanimous personality. He works as a consultant brachial plexus surgeon presently at Dinanath Mangeshkar Hospital, Pune, and has been there for more than 2 decades now. He's basically an orthopedic surgeon, primarily trained in orthopedic surgery, but then I have known him as a brachial plexus and peripheral nerve surgeon from times immemorial. I have known him. I met this man first, perhaps more than a decade and a half back. He might not be also remembering, but it was a meeting abroad. My friend Lucas organized a meeting at Serbia for the WFNS. It was a peripheral nerve meeting, and then I happened to hear his lecture, and also in Narakas also. And then I was mesmerized by the quantum of work that this gentleman was doing at that time when I was learning the intricacies of brachial plexus surgery here in India. So his primary areas of expertise is, I already said, brachial plexus injuries and obstetric palsies. He's known more so for these specialties. And he has held several positions of administrative post for various societies. He's a faculty of Brachial Plexus International School. He's the secretary of Brachial Plexus Surgery Group of India in 2007 to 9, after which he became the president of the same society. And he's a member of the Club Narakas since January 1994. He's a teacher par excellence, and you will love to hear his talks, including today's oration. I'm very sure about it. He has been invited as a faculty for various courses across country and across the globe from last so many years. And his talks are thought-provoking, his ideas are challenging, and he is a great surgeon and a teacher. Professor Anil Bhatia carries the distinction of having numerous publications in various international and national journals, with a chapter in Alexander Shin's book, which is a treatise in hand surgery. He's worked with Professor Raimondi and Professor Oberlein in 1992 and 94, and here are some of the glimpses of his rendezvous with these great personalities. Professor George Clifton, Professor Raimondi, Dr. Oberlein, Professor Klein, and ladies and gentlemen, I present to you Dr. Anil Bhatia for his distinctive oration for today's annual meeting of Indian Society of Peripheral Nerve Surgery. Dr. Anil Bhatia, please. Right. Sorry? हाँ? अच्छा, चल तो रहा है। नहीं, ऐसे ही है। Okay. मुझे कोई दिक्कत। Thank you very much, Sumit, for the very kind invitation. As it happens, this is my first ever oration. So it really is a landmark event in my career. I'm very happy to see Professor V.S. Mehta again after the WCNS which Sumit had organized in 2016. I got introduced to Professor Indra Devi. So my trip is made. Now I'll just get on to the job of boring you for the next half an hour. I will beg your indulgence for the first case, because this is not a total palsy. This is an extended partial palsy in whom, after exploration, one does this, after confirming avulsions, one does the standard set of nerve transfers in my practice: a double fascicular nerve transfer for elbow flexion, innervation of the rotator cuff, innervation of the ECRB for independent wrist extension. And this is my addition. I prefer to re-innervate the serratus anterior, because that will never recover in a C5, C6, C7 avulsions.
which gives this sort of function at 2 years. So what we are doing is approximating nerve ends. Sorry? I didn't get you, I'm sorry. Slideshow here. क्या करूं? ऊपर से करूं? नहीं, ऊपर है, ऊपर है। स्क्रीन मिररिंग चाहिए ना?
स्क्रीन मिररिंग हटाना है। Okay. Second one. Remove this external display.
Main display.
यहाँ पे नजर नहीं आ रहा? Oh dear, I must see my slides. Escape करना नहीं हो रहा. Anyway, while they are trying to work this out, the purpose of this talk is not to emphasize how good a surgeon I am or how magnificent my results are. The point I really wish to make is that brachial plexus injuries are challenging situations, and leave it ना, क्या दिक्कत है? लोगों को समझ में आ जाएगा. Oh dear. Still the same, don't worry. So brachial plexus injuries are challenging injuries. And when we are talking about total palsies, what I wish to motivate the younger surgeons is that what the patient will get back will depend upon the adventurousness of the surgeon. And you should know every single technique available in a given situation before you even open your first plexus. And if your results do not match what some of us present at the conferences, it would be your bound duty to visit those centers, learn how those results are achieved, and then embark on reconstruction, because the patient has given his body to you. What you do at that particular moment is what is going to decide how well he's going to regain function. So that is the purpose of this presentation. So anyway, this is, as I said, we do nerve approximations and we get this sort of function. I don't know, there's no sound here. So we all know that it is not magic. All this study of nerve repairs has been done more than 50 years ago. So what we have to do is utilize whatever is available to get maximum function. And how that works in a total palsy is what this talk is all about. Now, just to go back, as I said, I do not like talking about partial palsies because almost half my patients are total palsies. And where there is a complete disconnection of the brain and spinal cord from the upper limb, which would present something like this. in the presence of honor sign. Now, when I got back from Europe in December 94, I was under the influence of the French school, who were in their turn following what Kotani had published on the spinal accessory to musculocutaneous nerve transfer. And at that time, since I did not have any experience in nerve reconstruction of my own, I was just an observer for 3 years. I pursued that as that process of a spinal accessory to musculocutaneous nerve transfer using a nerve graft as the only procedure in a case of all root avulsion of the brachial plexus. So this is one of my early cases, something I'm ashamed of. 18-year follow-up, the patient never came back for any secondary surgery. He just accidentally rang me up years later, and I called him and recorded the video. So yes, the spinal accessory to musculocutaneous nerve transfer works. We know that. In the beginning of my practice, I had done a lot of them. In 1999, I started doing intercostals. So added the intercostal to musculocutaneous. Now, I'm taking you over a journey of my evolution as a brachial plexus surgeon for total palsies. So, as I said earlier, we are applying known techniques with increasing confidence in their success rate, so that to replicate that success in the next patient. So, we know that innervating the rotator cuff using the spinal accessory nerve does produce abduction. We know that direct coaptation of the phrenic nerve to the posterior division of the lower trunk from this landmark publication by Wong gives more than grade 3 triceps in a consistent manner. This is the most consistent performer for restoration of triceps in a total palsy. I have already published on my outcomes of intercostals to musculocutaneous in the beginning of COVID, where approximation of 3 intercostal nerves to the musculocutaneous nerve in the axilla can restore grade 3 elbow flexion in 90% of patients less than 30 years old. The contralateral C7 transfer by direct repair by the pre-spinal root, direct approximation to the mobilized lower trunk was published by Wong in May 2013. And again, it really consistently works for younger patients, gives restoration of wrist and finger flexion from the opposite C7. The reason I record my videos like this is to show that the the wrist flexion and finger flexion has come from the opposite side. It's not that the patient needs to press the opposite pectoralis major in order to activate it. So when I proceeded from intercostals and ipsilateral root stumps in 1999, for distal functions, I was still using the ipsilateral root stumps bridged by nerve grafts, and I was using the nerve transfers for shoulder and elbow, which would look something like this. And just to show an example, this girl was operated at 10 months from the accident. The shoulder and elbow function came from the spinal accessory and intercostals, and the finger flexion, very feeble finger flexion, probably because I operated her quite late, came from the C5. And I did secondary surgery, which helped her to position the limb better. I prefer to have the forearm in the neutral position and not in supination, hurry. This looks more aesthetically appealing when the patient places the hand on the table. And of course, wrist fusion helped to augment the finger flexion. But when we have an avulsion of all 5 roots, we have got no, for distal function, we have no option but to opt for the contralateral C7. Now, for a very long time, I was using a hemi C7 with long nerve grafts for restoration of hand function. But this was the best I could get. The shoulder and elbow has come from the spinal accessory and intercostals, whereas finger flexion was activated by the hemi C7 transfer, Even at 5 years post-surgery, he needed to contract the opposite upper limb in order to produce even the most feeble flexion in the recipient hand. And that persisted even at 9 years follow-up. So in effect, in my practice, the hemi C7 transfer with nerve grafts was completely useless. In fact, in January 2013, I had decided I would never do a contralateral C7 again. And then came Wong's publication. So I shifted to the full C7. This guy, 19 years old, his shoulder abduction came from the spinal accessories to suprascapular nerve transfer. Elbow flexion came from the contralateral C7. And wrist and finger flexion, very feeble, came from the nerve grafting from the opposite C7. But he was very determined. So at 46 months, his abduction and external rotation had improved. His elbow flexion was much stronger. And following a wrist fusion and an FCU to APB transfer, his finger flexion brought him from to palm 0. And at 7 years, this is how useful it is to him. Now, I will just pause at this moment to define what I consider as prehension. Prehension is not merely the ability to pick up and drop objects. Prehension is the ability to place your arm in space voluntarily without use of the opposite upper limb and then manipulate objects. And therefore, if you use up nerve transfers to do a free muscle transfer for distal function, you don't have anything left for your shoulder and elbow. So I'm totally against the double free muscle transfer for in total palsies. It is something that has not worked in other departments, and I'm not worked in my hands either. Now, the next step was to accept what Wong had said. Now, in October 2013, I visited Wong and satisfied myself on two things. One, that dividing the full C7 did not cause any significant deficit on the donor limb. Second, direct approximation was possible and did give consistent results. Having satisfied that, I came back and I embarked on my endeavor to copy what Wong had shown. Now, if you read the old Campbell's orthopedics, I'm an orthopedic surgeon, so I follow the orthopedic textbooks. If you want to approximate nerve endings, we have to mobilize the nerve ends, we have to reroute the nerves, sacrifice certain non-essential branches, position the joints so that the nerves can be approximated, and if necessary, shorten the skeleton. Now, all this is embodied in this article of May 2013. But what it really involves is mobilization of the lower trunk. This is full C7 is pivoted at the bony margin of the intervertebral foramen and brought across the neck in the pre-spinal root. For direct approximation to the mobilized lower trunk. The loose end of the medial cutaneous nerve, the forearm, plus a nerve graft, we use the growing axons along those nerves to get elbow flexion in addition. And we do a phrenic nerve to posterior division of lower trunk and a spinal accessory to suprascapular. Therefore, this is a comprehensive strategy to give control of the shoulder, elbow, and hand. But what it really involves is jumping into this part of the brachial plexus, which for years we chose not to. We found that, oh, the nerves are broken and lying there in the medial part of the posterior triangle, and we don't want to go there. But in order to mobilize the lower trunk, you have to. So you have to undo all those broken ends like this in this manner, mobilize the lower trunk, sacrifice the pectoral branches, the medial cutaneous nerve of arm and forearm, in order to get proximal migration of the stump of the ADLT. I must also emphasize that you must separate the posterior division of the lower trunk. Otherwise, you won't get proximal migration. Also, innervation of the entire lower trunk by one source is a crime. I have done it thrice. I burnt my fingers, and you must provide an alternative source for the posterior division of the lower trunk and a separate source for the anterior division of the lower trunk. When all these maneuvers are not enough, we might need to shorten the skeleton in order to complete or relieve tension at the repair. It is only after all these maneuvers that we can get a direct approximation behind the esophagus. But the results are gratifying. This lady with avulsion of all 5 roots regained abduction and external rotation from the spinal accessory. The contralateral C7 has provided the elbow flexion. Wrist and finger flexion came from the opposite side. Again, as I said, I recorded this way so that you know that it is the contralateral C7 which produced it. And while she was flexing the wrist and fingers, the opposite upper limb was not engaged. She didn't really need to engage the opposite upper limb in order to do the recipient function. Now, as it happens, she never came to me for secondary surgery. Phrenic nerve to posterior division of lower trunk gave very strong triceps. And all this was continued at six years follow-up too. But she never came back for secondary surgery. In fact, when I had recorded this video, she had come here for to Pune for the secondary surgery. But then she was called back by Mamata Banerjee's government. So she is a government employee and she had to perform election duties. So the superiority of the direct repair over nerve grafting for the contralateral C7 was something, one of my early studies in this technique, and I published the superior outcomes by the direct repair. Currently, if I cannot get a direct approximation, I don't open the opposite C7 at all. So to recapitulate what I've been saying so far, you must systematically explore the entire brachial plexus. You must list all the available donors, innovate the rotator cuff if possible, or plan for a subsequent shoulder fusion. If you cannot innovate the rotator cuff, the best surgery for the shoulder is the shoulder fusion. The nerve transfers for elbow flexion and extension, you can use all these nerve donors. If you're using the ipsilateral root stump for elbow flexion, then you can use the contralateral C7 for finger flexion. Or if there are 2 roots available on the same side, then you could use one of them for direct approximation to the lower trunk. Now, the parameters affecting my strategy are mainly age and delay since the accident. I have arbitrarily drawn a line at 35 years. A patient older than 35, I can only anticipate proximal functions, and therefore that is what I focus on, which would give this sort of outcome from the spinal accessory to suprascapular and intercostal to musculocutaneous C5 nerve grafting to the posterior division to the posterior cord, which after a derotation osteotomy and a wrist fusion helps him to place it better. But if the patient is less than 35 years of age, we have to add the hand. Now, this boy, on the 15th of August, 2021, during COVID, I received a phone call from Bangalore about this kid who had fallen from the 2nd floor. And the cardiothoracic surgeons had explored. They found the subclavian artery rupture and they had clipped it. And this was what they found in the nerves. So I went next day to Bangalore and I reconstructed, because had I left it for natural healing first and then gone back, it would have been impossible to do what I eventually did. So I explored the entire plexus. I did a spinal accessory to suprascapular. The suprascapular nerve was found beyond the notch, and it had to be, but since there was a clavicle fracture, I could reach there very easily. I used intercostals to the musculocutaneous. The C5 was bridged to the pectoral branches and the posterior division of the lower trunk. And the contralateral C7, since he was only 5 years old, I did nerve grafting to the medial cord. The clavicle was fixed. I had gone to Bangalore in August, and this is the outcome for abduction external rotation, elbow flexion from the intercostals, and triceps coming from the C5 nerve grafting, and the contralateral C7 is producing wrist and finger flexion. He's too young to undergo secondary surgery. Therefore, this is going to be an ongoing project for the next few years. Now, 10 years older, this patient was 19 years old. Again, one route available. That was used for the musculocutaneous, spinal extended suprascapular, contralateral C7 for finger flexion, and phrenic for the posterior division of the lower trunk, which at 2 years had given enough stability in the shoulder and abduction, elbow flexion coming from the C5. The patient had triceps from the phrenic nerve transfer. Wrist and finger flexion came from the opposite C7. I did a derotation osteotomy of the humerus and a wrist fusion, which allowed him to flex and extend the fingers. And he's able to hold objects. No, come on. What happened? बैटरी खत्म हो गई चार्जिंग पे है इसका फुल चार्ज है नहीं बैटरी get my the battery would last. Can you put it? Can I get my bag there? नहीं होगा कहाँ किया आपने कंप्यूटर को कनेक्ट कीजिए ऐसे कैसे होगा कंप्यूटर को कनेक्ट कीजिए Sorry for this delay. I thought my laptop had enough juice in the battery to last out the presentation. Come on. Why is it not running? No, the password, it is right. Why is it not working? Sorry? No, it doesn't work. Cannot work. It always works with this password. There, but it's in a Mac. It will never work in your computer. Recognizing my fingerprint also, I cannot understand it. Come on. Huh? No, it will not. When it is, sorry? No, it is there in my external hard disk. That is not a problem. But then they don't have a Mac. Hari, do you have a Mac? Fine. Yeah, I have the connection. Now I know why it is not working. You have disconnected my this. ये disconnect नहीं करना है. इसी से तो चलता है ये. नहीं. It has to work. Okay. Okay. ये one numerical है. It's not. It doesn't matter. We will play it with this. It's just the last few slides, so it doesn't matter. Pure. Huh? No, how can it come? Anyway, I have opened it. Unfortunately, you'll have to sit through far more slides because I had deleted quite a few of them. Anyway, sometimes you can't get the triceps because the posterior division of lower trunk is damaged, and apart from the avulsions of all 5 roots. So the contralateral C7 can provide elbow flexion very easily in a young patient. The wrist and finger flexion comes from the opposite C7. There's palm to palm 0, which we don't get with a nerve grafting. And while he is flexing the elbow, wrist, and fingers, the opposite upper limb is not engaged. So therefore, the contralateral C7 transfer does achieve some degree of independence in the recipient upper limb, which will allow the patient to handle objects, keeping the affected upper limb still in space and using the finger flexion to carry that weight. As you can see, he's working with the opposite upper limb while he's packing the bag, and therefore, obviously, he doesn't need to do any concomitant gesture on the opposite upper limb in order to activate finger flexion in the recipient upper limb. Another case of the same nature, I had suppressed this slide in my final presentation, but it's the same thing. So finally, we come to prehension. Again, this guy came during COVID. He was one of the first cases I operated during COVID. Avulsion of all 5 roots, elbow flexion coming from the contralateral C7, wrist and finger flexion coming from the contralateral C7, the phrenic nerve providing the triceps, and while he is flexing their elbow, wrist, and fingers, the opposite upper limb is free. Following secondary surgery, he can actually manipulate objects in space without the participation of the unaffected upper limb. Another case of the same nature, again operated during COVID. But not all cases have this beautiful, successful outcome. This guy had done nerve grafting from the C5 to the musculocutaneous, contralateral C7 for finger flexion, phrenic to PDLT. The phrenic to PDLT transfer has this one big disadvantage, that at every breath it is getting activated, and therefore the triceps becomes very strong, and sometimes interferes with the progression of the most important function, that is elbow flexion against gravity. So this patient had a partial finger flexion and a partial elbow flexion and a partial shoulder, very poor result. So I noticed that his triceps was getting activated, which was hindering elbow flexion. So the first thing I did was I transferred the triceps to the biceps, which allowed him to flex the elbow more freely. Subsequently, I did a derotation osteotomy of the humerus, which positioned his upper limb better, and he could flex in the sagittal plane rather than the coronal plane, and he was able to manipulate objects. Now, the same concept of direct approximation of the ipsilateral root stump can be applied to the for the ipsilateral root stumps as well. This was a study we had published together with Wong, and this is a case whom I had operated in 2018. He had a total palsy. The untreated fracture of the upper end of the humerus stopped me from trying to attempt re-innervate the rotator cuff. So I used the ipsilateral root stumps C5 and C6 for direct approximation to the anterior division of the lower trunk. The phrenic was transferred to the posterior division of the lower trunk, and the spinal accessory was bridged with a nerve graft to the musculocutaneous nerve below the coracoid process, not distally as Hari showed, but below the coracoid process, which is what the original publication of Panupan was. And at 27 months, he had regained elbow flexion, regained elbow extension from the phrenic nerve transfer, and wrist and finger flexion was very strong from the direct repair, which following shoulder fusion and wrist and radioulnar fusion, since I could not re-innervate the rotator cuff, eventually he was slated for a shoulder fusion once the distal functions had been regained. Now, all these procedures I disagree with Professor Indra Devi about this. She did mention that when root avulsions are seen, you can explore earlier as well. And this is something that the neurosurgery department in Leiden has been working on in super early exploration. And taking a cue from my friend Willem Pondag, this patient with a Horner sign and a total palsy with MRI proven avulsions at all 5 levels was explored at 7 days. It is very easy to dissect because the plexus is just broken and lying there. So working out the broken ends is very easy. It takes only 10 minutes. And the clavicle was plated, and I did the regular set of nerve transfers, which following secondary surgery allowed him to place the upper limb in space very well. And he could manipulate objects. So to recapitulate my philosophy, you must systematically explore the entire brachial plexus in every single case. You must do it even in the partial palsies, because where nerve transfers are quite enough, like a C5, C6, if you do not inculcate the habit of exploring the roots medial to the phrenic nerve, when you really need to find proximal root stumps in total palsies, you will not be equipped to do it. So you must explore the plexus fully, apply known techniques in the right way. Now, to teach this cutting-edge surgery, I had partnered with my colleagues from across the globe for instituting, I think, the first ever diploma in brachial plexus surgery. I did it with Alex and Tarek El Gamal and Jorge Clifton. This was the first batch in 2018. 2019, they terminated in Barcelona in January 2020, and then COVID intervened. So this is the message I would like to leave you with. Thank you very much.
I would like to request the chairpersons to kindly felicitate Professor Dr. Anil Bhatia. As we are lagging a little behind schedule, we'll be breaking for a 30-minute lunch now.
During lunch session, we will have poster presentation in the left side of the gallery. And I request Dr. Prashant, Dr. Raghavendra, Dr. Shweta.
The session will resume at 2:35 because we are lagging behind and already we are delayed.
All poster presentation participants, please reach in the left side of the gallery of auditorium. And Dr.
बेसिकली क्या है, ये मेरा पुराना लैपटॉप है, मैं यूज नहीं करता नया लैपटॉप हरी
खोलो ना एक असेसमेंट वाला
लोगों को मुश्किल पड़ रही है ना? हाँ नहीं, वो तो लास्ट, वो तो उन्हीं का प्रॉब्लम था। यही चेक करोगे मेरा ये? अच्छा एक चीज बताओ, सेल फोन से मैं भी लैपटॉप से आज चेक कर ले रहा हूँ, मेरा कल है प्रेजेंटेशन, लेकिन गड़बड़ नहीं हो जाए। क्योंकि बहुत टाइम वेस्ट हो गया। ये बहुत टाइम वेस्ट कर रहे हैं। हाँ चाहिए थोड़ा सा भाई, आज के टाइम ऐसा नहीं होता है। ये नहीं, वो सब ठीक है, ये घुसेगा।
यही लैपटॉप चलेगा ना भाई मेरे? पता चला तो मेरे लैपटॉप चेंज कर दिया था बाद।
हम लोग अपना लैपटॉप पा रहे हैं, लेकिन भी ऐसे चेकिंग करते हैं तो मेरे भाई क्या होता है कि
अभी भी नहीं आ रही है मेरे ही की। हाँ बस ठीक है, इसमें देख 220 से बोला कुछ है, ये डाल दो।
आप कॉपी कर लीजिए, आपकी इसमें वीडियो है इसमें?
हाँ मैं इसीलिए मैं चेक करना चाह रहा
इसी जगह पे है, वो वीडियोस के नहीं है।
नहीं सर,
इस फाइल में नहीं है तो अभी नहीं आएगा।
अभी वो फाइल वाला कंसेप्ट खत्म हो गया है।
अच्छा
हाँ,
अच्छा
खत्म हो गया।
अच्छा, इसी के अंदर पेस्ट हो जाता है
हाँ,
वो?
कैसे
पेस्ट करेगा वो, चेक कर लेते हैं। नहीं वो पहले
फाइल लिंक
साथ में ट्रांसफर
मेरा भी नहीं चला था, फिर मैंने एम्बेड किया था।
आजकल ऐसा नहीं है, आजकल ये भाई अभी देख लेते हैं, पता चल जाएगा। बिकॉज मैंने मैक में बनाया ना, मैक में एम्बेड हो जाता है।
नहीं
Ah.
तो एक तो यही तरीका हो गया हमको, है ना, हमारे लैपटॉप में जो वीडियो अभी मैंने चेक कर दिया, आ गया है, वरना आपको पेन ड्राइव पे देना होता है ना।
Vaishnavi, 16 years female.
Good afternoon, everyone. We are starting with the next session, that is innovations and controversies in peripheral nerve surgery. I would like to invite faculties Dr. A.K. Purohit, Dr. Sanjay Sharma, Dr. Sumit Bansal, and Dr. Nischay Naik to chair the event. I would also like to invite Dr. Deepak Agarwal to speak about bladder reinnervation using neurotization.
Yeah. Connect करो. Good afternoon to all, and I welcome you all back after the lunch session, whoever's here. So, what I'll be talking about is bladder reinnervation in spinal cord injury, and I will continue from my previous talk in which I was talking about neurotizations in spinal cord injury. So actually, in patients with spinal cord injury and paraplegia, this is the two things this whole talk is going to revolve around. The patients do not want to walk. That is not the first priority. The priority is dignity of living, and that dignity of living is bladder control, bladder and bowel control. So that is the number one, I would say, on the wish list. And it may be difficult for us to understand, but any patient with paraplegia, this is what they want. Bladder innervation is not so simple. It's a complicated thing. Parasympathetic fibers coming from S2 to S4, sympathetic fibers coming from all the way from D12 to L2. And there is a lot of splanchnic, somatic efferent fibers coming in. Plus with the external detrusor muscle fibers, it is at best complicated, and it's sometimes very, very complicated. So we have various, over the years, people have tried various strategies to repair or reinnervate the bladder. And I will quickly go over the various, I would say, strategies so that we have an overview. And then I'll come to what we are doing or we are trying as a project. So one is the homotopic root repair, in which if there is an injury, the same root is repaired to itself. So it's not a neurotization where we are doing between the roots. The same root, if we find injured, it's like you just cut it and you repair it if you think there's a damaged segment in between. And this can be both intradural as well as extradural. And this figure shows that beautifully. You can just repair it here or you can repair it outside. Multiple studies are there on this type of technique. And if you see the application, this is basically in cauda equina injuries. All of them have tried it, and gratifying results are there. So what I would suggest is any patient with the paraplegia with a spinal, with a cauda equina injury, exploration is the key. So because we write them off as nothing's going to happen if you don't find a compression, but exploration, assessing, and then doing either neurolysis, neurotization, or simple root repair can be sometimes very gratifying. Then we have heterotopic root repair. And in this, we cut the S2, S3 roots and connect it to the L6, L7 or L5 roots. And this provides a kind of a reflex arc, which is also interesting. It is also done in cauda equina injuries, and people have seen there is recovery of micturition reflex. So it is limited. It has all been done in humans as well as animals, but more likely inside a research setting. Then we have extradural to intradural transfers, which are all basically combination of what I just talked about, the root repairs. You can do it both intradural or extradural, and there are a lot of studies again on these kind of repairs. We can transfer peripheral nerves to the pelvic nerves, and we can use either the hypogastric or the obturator nerves to the pelvic splanchnic nerves, and we can also use the genitofemoral nerve to the anterior vesical branch of the pelvic nerve. Why I'm saying all this, that we should be aware of the techniques available, what people have tried to renovate the bladder with good results. There is also a technique of direct detrusor muscle renovation by somatic nerve transfer. And in this, bilateral pelvic nerve neurectomy is done, and or sacral rhizotomy is done. And after doing this, 10 days later, the obturator nerve or femoral nerve is sectioned and the distal ends implanted directly into the detrusor muscle, as close to the utero-vesical junction as possible. And then finally, this is the one we have tried actually among all these techniques, is artificial skin CNS bladder reflex pathway. So it is known as a ZIO technique, he was the person who he's in US, who described it long time back. And in patients with paraplegia, what he did was he took L4 and L5 roots, one of these, and connected them to the S1 or the S2 root. And these are the ventral roots on both sides. So we are taking the ventral from L4 or L5 and the ventral from S1 or S2. So this is done an interdural procedure, and we connect it and we can do it on both sides or we can do it on one side. I usually have done it only on one side. So we create this reflex arc, because as I said in my last talk, the spinal cord is completely intact below the level of the injury, with all the spinal reflexes and everything, vascularity, everything intact. So it's a mini working brain which has been decapitated. So it's there, it's working. And if we can get that reflex working again, it might just work out. So it gives back the tone to the bladder. And there are two ways. If you actually use the S2 root, what authors have described is that by stimulating the Achilles tendon, you cause micturition. So it sounds good. We haven't replicated that. So a lot of studies. And if you look at the author, this is Yayo himself. He's published 4 studies. And then Lin came in and he published. He did it with S1, S2. And S2 reason I told you instead of S1, he used S2 because the Achilles was easier to, I would say, stimulate. S1 root is, you don't need anything. The beauty of this technique is, obviously you can use neuromonitoring, but S1 root, as we all know, is the largest root and you can easily identify it and you can go up and again identify. It doesn't make a difference if you take L5 or L4. If you miss 1 or 2, it doesn't make a difference. Just connect it out and see the results. So we have done around 3 patients. One was a D8 fracture, and we did this L5 to S2. Second patient was again D12 fracture. Again, the same procedure we did. And third patient, again a D12 fracture in which we did the neutralization. So we have follow-up in progress. We'll hopefully update you next time. But I would say right now, all we do is tell our patients to do CIC, or sometimes even not that, send them home on catheter. I think we need to keep ourselves, and there is so much more in peripheral nerve surgery. There is so much we can do, even at the research level. So I'm sure even if it works or even if it doesn't work, it is definitely a ray of hope for our patients, and it's completely free. It doesn't require expensive hardware. So to conclude, bladder function is more important than the ability to walk, as I mentioned, and creation of an artificial somatic CNS autonomic pathway has shown mixed results in previous studies. And it is obviously very cost effective, and research needs to be done on this. So thank you so much. All the figures I have taken from, there was this article by Gomez Amaya. Thank you.
Can I ask question?
Yes, sir.
Dr.
Yes,
Deepak,
sir. Yes.
congratulations. Good innovative ideas. Now, again, the same question when we take the sacral nerves. Now, you have said about urinary functions. What about genital function? When S2 get stimulated, S3 get stimulated, what happens to the genital functions?
Sir, that we have not looked into, but yes, I get your point. The two most important on the wish list is genital function and bladder and bowel function on these patients. And definitely we should be looking into how to improve upon it, but we have not looked into. So we can.
No, but automatically when the bladder function improving, is something happening on the genital region?
We haven't explored that, sir. So I will not be able to answer.
We are already running 2 hours late, so I appreciate if the questions are going to be directly discussed with our editor after the session. So may I call on our next speaker?
Good afternoon, respected chairpersons, my seniors. I must say, I don't have any hesitation. I'm extremely glad to meet Dr. Indra after, I think, 15 years, 1.5 decades. And thanks, ma'am, for bestowing me with your teachings. So I'll just give a slightly different perspective to what Professor Deepak elucidated about the bladder issue. So what is sacral nerve stimulation? Sacral nerve stimulation is a straightforward procedure whereby we put some wires and stimulate some selected nerves in the sacral region so as to improve the bladder, sphincter, and the defecation problems. Today's topic, I'll be concentrating only on its role on a very tenacious and socially and emotionally distressing spectrum of problem known as neurogenic bladder. So neurogenic bladder basically is any bladder dysfunction which emanates from any disease of the central nervous system. So there are various types of neurogenic bladder, as we all know, depending on the level of involvement. If it is, suprapontine, you have uninhibited bladder. If it's between the pontine center and the conus, you have the automatic bladder or reflex bladder. If it is at the conus, you have the autonomous bladder. If there is involvement of the motor roots, you have the motor paralytic bladder. If there is involvement of the sensory roots, you have the sensory paralytic bladder. But these are all very, sort of a complicated thing for decision making. So to simplify things, you can basically divide urinary problems due to, say, stroke or spinal cord injury or multiple sclerosis in two broad categories. One is overactive bladder, where the detrusor is hyperacting. So you will have symptoms of urinary urgency, urge incontinence, or a combination. The second is an underactive bladder, where obviously you will have urinary retention. So sacral nerve stimulation has been found to work in reducing the symptoms in both these categories of patients, both overactive as well as underactive. The mechanisms are multifactorial. There are various hypotheses. but it tends to influence both the afferent and efferent signaling. For example, suppose there is an overactive bladder. So what it does, it tends to block the sensations carried by the C and the A delta fibers so that the detrusor muscles gets relaxed and there is a decrease in urgency frequency. Similarly, if there is an underactive bladder, what it is supposed, I mean, it is hypothesized to do, there is nothing proven, is that it blocks the somatic efferent fibers coming from the pudendal nerve as part of the guardian reflex, and there is a relaxation of the bladder and relaxation of the external sphincter, and the retention is improved. So both ways it works. Paradoxically, it works both in incontinence as well as retention. Of course, for long-term effects, it does have an effect on supraspinal structures, especially in the dorsolateral prefrontal cortex as well as the paracentral lobule, as proved by functional MRI studies, which ma'am has conducted a lot during a stay at NIMHANS, that it leads to have a neuroplasticity to re-coordinate the bladder reflexes supraspinally. Now, what is the scope? A person comes to us with overactive bladder or underactive bladder. The first step is conservative treatment. Say there is an overactive bladder. That means there is a parasympathetic over excess. You give anticholinergics along with Kegel's exercises and behavioral therapy. If there is an underactive bladder, urinary retention, you have to obviously give an alpha blocker so that the retention is relieved, and teach CIC along with various behavioral modifications. But the fact of the matter is that only around 50 to 80% of such patients respond to these conservative treatment. There is a large cohort up to 30 to 50% which don't respond. And also, those patients who are responding initially, by 24 months, it has been found that around 90% of such patients become non-compliant to these conservative therapy. So what do we have? One perspective Dr. Deepak presented. The other perspective is, can we do something less invasive? So here comes the role of very simple neuromodulation surgery, which I occasionally do as part of my functional neurosurgery practice, known as sacral nerve stimulator. And it has become so popular since its FDA approval in 1997 that it's not uncommon to have this in all the countries where they have access to neuromodulation. There are two steps to do this. First, we have to conduct a trial whereby we put a foramen needle through the right S3 foramen. The S3 route is selected because it has been found that it gives the maximum innervation to the urinary bladder sphincter as well as the perineum. The surface landmark is you trace the sacroiliac joint to the greater sciatic notch on both sides, as you can see here, and then join both the points. 2 centimeters to either side of the midline, you can have the S3 foramen. This, of course, is corroborated with fluoroscopy. So S3, I already told why we select. So this is actually what we do in the trial. I don't know whether this video runs or not. Yeah, it runs, thank God. So what we do, we insert that needle at a 60-degree angle under fluoroscopic guidance, and we see for 2 responses. One is the bellows response, whereby we have to see the deepening and flattening of the gluteal curve. And second is the plantar flexion of the great toes and other toes. All these responses should come within less than 2 milliampere with a frequency of 14 to 21 hertz and pulse rate of 210 microseconds. As you can see in one of my patients, I'm stimulating the foramen needle and you can see the bellows response coming and going. Here again. So this denotes that you are hitting the S3 foramen. Our target is the S3 nerve root. The second you have to see is the plantar flexion of the great toe and somewhat of the other toes. So once you have these 2 things done, you are sure you are at the right area. You introduce an introductory sheet under a directional guide, take out the foramen needle and put the final electrode. Again, repeat the same thing. Confirm the bellows respond with the final electrode. That's done. We confirm fluoroscopic confirmation, we are at the right place. The point to note is that distal most, rather the proximal most electrode has to straddle the foramen, S3 foramen, because that's where the maximum impact on the right S3 will be. Once that is done, you connect it to the external pulse generator and conduct a trial for 3 to 7 days. So what do you look for during those 3 to 7 days? Clinical, radiological. Clinically, you have to see at least 50% reduction in the symptoms. For example, in the episodes of urinary incontinence or the episodes where the patient needs to use a CIC, the patient has to maintain a voiding diary. Radiologically, usually ultrasound is used in most centers, where for overactive bladder, you have to see the first bladder filling sensation volume. And for an underactive bladder where you have retention, obviously you have to see residual volume. Anything less than 50 is good. In elderly, up to 100 is okay. 100 to 200 is a gray area. In milliliter, I'm talking about residual volume. Anything more than 200 ml is pathological. The benefit of the test period, it provides us an opportunity to assess the viability of this therapy. That's the main thing. And there are certain predictive factors, out of which the most important, which has come up at least in literature, is age. They say a cutoff of 55, the patients are less than 55, the response to this neuromodulation is better. But in our series, we have not found any such predilection. So the trial period is successful. You have a 50% reduction in symptoms. Stage 2, you connect the wires with the pacemaker and make a subcutaneous pocket near the iliac crest and complete the surgery. Adverse events, as for any brain pace neuromodulation surgery, you can have pain, local pain, migration, infection, and whatnot. So over last 12 years, we have just done around 19 cases. Most of our patients have been underactive bladder patients, that is with urinary retention. And most of them have been patients of spinal cord injury with a mean follow-up of 67 of 13 months. The average time to optimal response in our series was 3.3 days. Mean symptom improvement was 64.16%. And the residual volume had improved by 63%, first bladder sensation by 26%, no adverse events. In our series, we found that the maximum response was found in patients who had retention. Ironically, as Dr. Purohit asked a question some time back about the genital function, we also found a 43% improvement in erectile dysfunction in our patients. The cause is not known. And our series actually commensurates with two major meta-analyses which have been done on this therapy, that most patients with retention respond the most. And these are all gratifying success stories. Our paper is under review and should be published later this year. So conclusion, sacral nerve neuromodulation, efficacious therapy for properly selected refractory neurogenic bladder patients, but we need larger series with greater follow-up, especially in the Indian population. Thank you.
Next speaker, please.
Thank you. Arranging, I will just introduce. Jatin is doing something unique in our country, which is now being followed, which we started 1988. Spasticity surgery. And I really appreciate that he has initiated it in Jabalpur. Congratulations.
Thank you, sir. It's very humbling to present in front of you. You are really a father of spasticity surgery in India. Thank you, respected chairpersons, Ispns, and Dr. Anil Sharma for kind invitation. So I'll be moving from reconstructive procedure to stimulatory procedures to destructive procedures. But these procedures are very safe and efficacious, particularly in improving spasticity, which is very common in different neurological conditions. Thank you. So, so a patient needs of spasticity. He needs basically relief of spasticity, improvement in power, reduction of pain, which is commonly associated with spasticity. Of course, the procedure should be safe. It should be durable enough, and should be cost effective, especially for a country like us. So, a generalized spasticity needs a procedure like dorsal rhizotomy or tracheotomy, or an intrathecal baclofen pump. So we all know that intrathecal baclofen pumps are costly, and it requires periodically the drugs also, which is also sometimes difficult to attain. While a focal spasticity can be relieved either with Botox, which is again costly in repeated terms, and the procedure of choice can be neurotomy in these. But of course, in generalized spasticity also, for example, a patient of cerebral palsy or a stroke patients, you have some, the patient may have few joints which are affected most, and you can give the option of selective neurotomies for these patients. So before embarking on the surgery, we need to properly take history and examine the patient. We need to differentiate whether it is spasticity or whether it's contracture, rigidity, or dystonia. We need to examine his charts, his videos in spontaneous postures, motions, and in different angles. So the procedure was introduced by Stoffel, and it includes sectioning of the terminal 50 to 80% of the targeted nerves. So for a lower limb, for hip spasticity, we can offer obturator. For knee spasticity, we can offer sciatic neurotomies. Foot and toes, tibial neurotomies. Extensor hallucis, we can offer anterior tibial neurotomy. For upper limbs, for the shoulder, we can offer pectoralis major and teres major neurotomies. For elbow joints, musculocutaneous, and for wrist and fingers, median ulnar neurotomies. I'll be showing few of the cases. So this is a patient who had who was a post MCS stroke patient. So he had talipes equina varus deformity as well as an upper limb deformity. So he underwent initially the this tibial neurotomies, hyperselective tibial neurotomy. So you can perceive there is a flattening of the foot, flattening of claw toes, as well as if you look closely, there is reappearance of extension of the toes. So that is a very gratifying result. So again, post-op and pre-op comparison. So the procedure is simple. The compared to the other brachial plexus injury patients, all those things, the anatomy is preserved here. So this is a left lower limb, left popliteal fossa, cranial, medial, caudal, and lateral. So after incising the skin and fascia, we need to preserve the saphenous vein, sural nerve. We need to preserve all the sensory nerves. Otherwise, there will be problems with paresthesias, neuromas, etc. So you need to go between the two heads of gastrocnemius. So this is tibial nerve trunk, and we are separating the two branches to the two gastrocnemius, lateral and medial. So important, do not go above the main trunk of tibial nerve. Otherwise, you may injure the common peroneal nerve, which can lead to foot drop. So again, separating the sensory from the motor nerves. Again, the neuromonitoring is very helpful for this. So these are branches, posterior tibial. Again, this you are stimulating to branch to the soleus. So this is branch to the posterior tibial, showing inversion of the foot. Branch to the soleus. This is gastrocnemius. This is sensory. And this is medial gastrocnemius. So you go terminally up to the muscle, and after stimulation, cut 2/3 of them. So cut at least 2 to 3 millimeter to avoid a regeneration. And you may also coagulate the cut ends. You can compare the stimulation distally and proximally to the to your dissection cutting. Similarly, do for lateral gastrocnemius. Cut 2 of the 3 nerves. Similarly, go for the distal tibial trunk. Cut, this is nerve to the soleus. So divide it. After stimulating, ruling out the sensory fascicles, just cut the motor fascicles. Going distally. This neuromonitoring is very helpful. That is, compulsory for this procedure. And we are opening now the main distal tibial trunk for the toes, great toes and other toes. So again, for the want of time, I will move ahead. So these are some pictures. I kept it, suppose video doesn't work, but thankfully the video worked. So the incision for the musculocutaneous is in the mid-arm. It can extend proximally also if we don't find the nerve to the biceps. So the target is incision of nerve to the biceps and brachialis. So you can see the branch to the biceps here. So again, dissect it terminally and divide 2/3 of them. Similarly for the nerve to brachialis, median nerve incision will be in the cubital fossa. So we need to dissect between the pronator teres and flexor carpi radialis, incise the lacertus fibrosus, and dissect the nerve distally. You can find nerve to pronator teres, palmaris longus, FDP, FDS, and FPL. So again, divide 2/3 of all these branches. The ulnar nerve can be found in the cubital tunnel. So here the main trunk has to be opened. We cannot find up to the distal muscles. So this is pre-op and post-op. This is pre-op. The thumb was very much in wrist. But here in the post-op phase, you can see there's some reappearance of flexion of the fingers. This is only because we are rebalancing the flexors and extensor group of muscles. So that's why there is a reappearance of some functions also, apart from the relief of spasticity. So some, again, pictures, preoperative and postoperative phase. Again, preoperative and postoperative pictures. This is a controversial case, although old D12 burst fracture with spastic paraparesis. So patient was in, she didn't agree for the spinal procedure. It was already 2 years down the line. So you can see preoperative extreme spastic patient. It was painful also. So she underwent bilateral tibial neurotomies as well as bilateral achialis tenotomies because the achialis tendon was in contracture. So the result was nice. So there are long-term studies also of more than 5 years showing more than 50% relief of spasticity after 5 years also. And Purohit sir has also published a good number of studies. So recently we have published a video in the Neurology India. It has come in this issue only. The complications of this procedure are not much, only few, like sensory disturbances if we harm the sensory nerves. Recurrence can be one of the complications in the long term if we lyse less number of these nerves, and very rarely paralysis. So to summarize, this procedure is an excellent option for relieving focal as well as focal spasticity in generalized spasticity patients. This procedure is underutilized and should be stressed, especially in our country. The aim is to suppress the excess tone and achieve rebalancing of flexors and extensors. Intraoperative monitoring is vital. We need to differentiate spasticity from contractures, rigidity, and dystonia. And this procedure helps in rehabilitation as well as rehabilitation is critical after the procedure. Thank you, sir.
Thank you. That was nice presentation. Dr. Raja Tiwari, robotic microsurgery in brachial plexus.
Very good afternoon to everyone and the chairman. It is a quote which says it is better to solve one problem in 5 different ways than to solve 5 problems in one way. And with this, I would like to introduce the technique of robotic assisted nerve transfers for brachial plexus injuries. So as in its current setup, the robotic systems are basically optimizing our routine surgical steps, and they do not take the control of the robot by automatically doing the surgeries. So the robot which was introduced, the first in the world, was the Da Vinci surgical system. And this was the robot which was initially used for doing nerve transfers, which was introduced by Dr. Levernes some 10 years back. But subsequent to it, several other robots are also introduced in today's times, and which have cut down the cost significantly. So the Da Vinci robotic system is basically has 3 parts: the surgeon's console on which the surgeon sits, the robotic arms, and the viewport. And many other specialties have taken up robotic surgeries like plastic surgery. Many other procedures are being done, which include the robotic DF flap harvest, sympathetic nerve reconstruction, and the transolar robotic surgeries. So why robotic surgery for brachial plexus? So like I said, because the robotic surgery has certain advantages. They provide long instruments through which we can access the desired locations with minimal access incisions. It has a very efficient electrocautery for minimum blood loss. It can provide us with good magnification, a 3D vision, and 10 to 40 times zooms. And also it has a 360-degree freedom of movement along with tremor dampening, which assists in us in good exploration of the nerves. So of course, learning robotic surgery is a steep step. So we have to practice on the simulators first. Then you get a basic training certificate. Then we have to practice on human tissues. Basically, we use placentas to conduct anastomosis on blood vessels before embarking on any human studies. And we also do cadaver studies to decide upon the port locations for the various robotic arms. And during the course of our training, we also calculate our scores, and we find that within a period of 6 years, if you are practicing twice a week, then we develop good surgical skill by the end of 6 weeks. So we also have to do a dry run in the operating room itself to decide upon the position of the robotic system, the position of the surgeon, the console, the surgeon assistant, and the viewport, the robotic console, and the assistants, other surgical technicians and anesthetists. Also, because as plastic surgeons, we are not trained into robotic surgery. So we have to assess other departments which are routinely doing robotic procedures. And two of the most useful techniques that I have found during my training are the robotic thyroidectomy and the retropelvic nephrectomy, which helps us in learning the steps of robotic maneuvering. Also, we have to have a knowledge about the various robotic instruments. So the upper instruments, which are the Maryland bipolar monopolar curved scissors, these are already provided by or already being used by other surgeons. But the two important instruments, which are the black diamond microforceps, are unique for microsurgical work because these are very fine and allow us to do microsurgical repair using these. So in our cases, we started with doing the partial brachial plexus injury cases first. And we have included the cases who had a preganglionic or postganglionic C5, C6 segmental injury. In postganglionic cases, we waited for around 3 months for some spontaneous signs of spontaneous recovery. And if there were none, then we proceeded on with the exploration. Sorry. If the BMI was more than 30, then it was a relative contraindication because the increased bulk of the tissues does not allow the robotic exploration to proceed. What have been achieved so far? We have conducted 5 nerve transfers, including 3 SAN to SSN and 2 oberlin transfers. And along with this, we have done 2 supraclavicular explorations and 1 infraclavicular exploration. And our follow-up ranges from 3 to 10 months. So in the supraclavicular exploration and SAN to SSN transfer, the first figure shows the location of the port. And the second is the instrument which we use to create the surgical field. It is called a percutaneous balloon dilator. And with this, you can see it is inserted subcutaneously and inflated to create a surgical field. And once this field is created in the infraclavicular location, then we move on to the supraclavicular part. And this is a video demonstrating the technique of supraclavicular exploration. So as you can see, the landmark is the clavicle. Then we put our finger on the supraclavicular location to identify the various landmarks. We start by dividing the subcutaneous tissues. And then we identify the landmarks, which are the lateral border of the sternomastoid muscle, medially, and the anterior border of the trapezius more laterally. So we keep on moving into the surgical field. The next structure that we have to identify is the omohyoid. And we can either divide or push the omohyoid muscle aside to explore the structures underneath the omohyoid muscle. So this is the omohyoid muscle, which is carefully held by the grasper. And then we divide it from the surrounding tissues and then cut it under cautery. Next, we have to explore the scalenus anticus muscle. So we divide the fat pad on the medial side of the supraclavicular area. Once this fat pad is divided, we can easily see the scalenus anticus muscle. And behind the scalenus anticus is the usual location of the brachial plexus. So depending upon the findings, we can find either a scar tissue or we can get access to a nerve rootlet. So in this case, there was some fibrous tissue which was coming from the distal part of the brachial plexus, going all the way up to the location of the C5 nerve rootlet. However, the phrenic nerve was not stimulable. And on careful exploration, we were able to separate it from the surrounding tissues and then divide it. Next, we tried to identify, and there was no stimulation distally. So we use a percutaneous needle inserted through the skin and then tried to see the stimulations in the hand. Next, we identified the suprascapular nerve, which arises from the Erb's point. Once this is identified, we have focused our attention onto the anterior surface of the trapezius muscle. And likewise, we carefully separate the fat pad. And then the spinal accessory nerve also comes into our view, which is around 2 centimeters from the anterior border of the trapezius muscle. So the good part is that it is, although it is in depth, but because the field is inflated by gas, we can get a good view of both the nerves. And then we can trace it more distally to get a good length for nerve cooptation. We are not required to divide either the supraclavicular nerves or any other structures because we can work with these arms more laterally. So this we are dividing the suprascapular nerve, and then a good nerve cooptation can be performed using the robotic arms. As you can see, there's some extra fibrous tissue which is attached. So using the same instruments, good epineurial repair can be performed. On the left side, you can see the black diamond microforceps. So you can see that the tip of the instrument is very small, very fine, and it assists in good suturing through the robot. The suture that we are using is a 90 nylon. So you can see that the even finer sutures can be easily used with the robot with the use of these instruments. So we usually apply 2 to 3 sutures. And then we also use some fibrin glue to strengthen our repair, which is inserted through a percutaneous skin insertion site. Next, we have also done the Oberlin transfer. So accordingly, you can see that you can form a heart-shaped structure with the hands, and these are the location of our ports. And similarly, we create the field with using the percutaneous balloon dilator. And this is the technique. So once we are inside the subcutaneous tissue, we divide the deep fascia and try to locate the anterior border of the biceps muscle. Once this is lifted up, then we can get access to the musculocutaneous nerve. And you can easily see that there are the 3 branches of the musculocutaneous nerve are now being exposed. These are the nerve to the biceps more superiorly, and nerve to the brachialis and the lateral cutaneous nerve. Similarly, the median nerve in our case was explored, and the superficial medial fascicle of the median nerve was separated from the main trunk using a combination of blunt dissection and sharp dissection. This is the median, the ulnar nerve in this case. So this is the intraneural dissection, which is now being performed using the robotic instruments. And this is the nerve cooptation, which is now being performed. You can see the good magnification, which is available with the use of the robot. There is a certain degree of learning curve. So once we are doing more procedures, the learning curve and the speed and the precision also improves gradually. And like in the first case, we usually put 2 to 3 sutures to orient the nerve fascicle and then proceed with the fibrin glue. And these are some of the results which we have achieved. So you can see in the first 2 cases, which are 8 months and 10 months post-operative, good elbow and shoulder function has been obtained. Both of them is M4. And then the third case, which is just 3 months post-op, the innervation has not yet occurred completely. The post-operative scars, as you can see, are mostly in the chest and the middle side of the arm, and these are very small as compared to the classical exploration scar. Also, some of the benefits when we compare the classical technique with the robotic include that the blood loss is significantly less because the field is almost completely cauterized. And this is the post-operative pain and recovery is much faster, and the patient can be discharged the very next day because of the lesser amount of dissection that we have done. And although their cost, we have to bear the cost of robotic surgery, but if we compare it with the number of days of hospital stay, then it may also come down. In one patient in which we had used the median nerve, we encountered this problem of pointing index, but this also spontaneously improved after 8 weeks. So to conclude, robotic microsurgical skills are easy to adopt for practicing microsurgeons, and robotic microsurgery has a promising role in the treatment of brachial plexus injuries because of their advantages. And possibly if more people are adopting this technique, then with the advent of newer robots, the entire procedure will become more cheaper in the coming few days. Thank you so much.
Thank you, Dr. Raja. That was a very nice talk. Dr. Bipin will talk about the role of surgery in CRPS.
Thank you, Chairperson and ISPNS for inviting me. So I am going to speak about a complex topic here, which is complex regional pain syndrome, and whether there is a role of surgery in this CRPS. So what is CRPS? So it is a chronic pain condition which arises after any traumatic event of the soft tissues. The definitive cause is still unknown. However, there can be the causes can be autonomic dysfunction, neurogenic inflammation, CNS neuroplasticity, but all these causes are still in dispute, and there has been proven cause of some multifactorial origin. So we don't know the cause of this. There have been criteria established for CRPS. So the most recent one is 2007 Budapest criteria, and there is a Wellman criteria, Cousins criteria. All these criteria tell us these 5 things. One is the patient has severe shooting pain. Second, he has a burning pain, allodynia, like he cannot stand below a fan, or very sensitive, the skin is very sensitive, edema, and the patient has vasomotor changes. However, not all patients present with edema and vasomotor changes. However, burning pain, shooting pain, and allodynia is very common. So this is a pathway which we must have seen when we were in first year. So what the nociceptive stimulus, the pain stimulus fibers are A delta fibers and the C fibers. Now, the C fibers are the chronic pain fibers, and the A delta fibers are the acute fibers. So we need to tackle these, and all the conditions and all the pain management people target these 2 fibers. So what has been the treatment of CRPS till date is, first is the NSAIDs, then steroids. Steroids is the only level 1 study, opioids, then anti-epileptics, gabapentin, amitriptyline, which most of us use, followed by therapy, TENS, and physical rehab to prevent stiffness. And stellate ganglion blocks have been proved very well in CRPS. However, most of them say that surgical intervention should not be done as it might aggravate the chronic regional pain syndrome. So what is our hypothesis? So our hypothesis is release and neurolysis of the affected peripheral nerve in the CRPS can help to alleviate the pain, and in turn this improves function. So how do you find this affected nerve is by a simple test which is called as a xylocaine block test, which is an age-old test, but we have not been following it. And the cause of the pain needs to be diagnosed and treated. So till date, since last 3 years, we have 7 cases which were diagnosed as post-traumatic CRPS according to the criteria above. All of them were average of 3 months injury. All were females. And the important thing here is the electrodiagnostic test and all the other diagnostic tests are mostly negative. And the patients, all these patients were treated with all the medical management given above. So this is a case 1, which I say that this is a complex regional pain syndrome 1. So there are 2 types of CRPS. There is type 1, which doesn't have any cause, and type 2, we specifically find a cause like a nerve injury and we treat it. So this is a 28-year female. So if there is a volume in it, she's saying that she has a lot of pain and she's unable to flex the elbow. This was after a fall, and she was suspected for a thumb injury for which she was immobilized. Then the swelling increased and she's unable to lift the elbow and shoulders. If you can see properly that the vasomotor changes have been developed.
The skin is red, black, and there is a lot of burning around, and she's telling that there is burning pain here. So we did an MRI to find what it is. So the MRI was done outside by an orthopedic surgeon, and they said that it is a C8T1 type of injury. However, clinically, it was not correlating at all. The EMG NCV was done, which was again saying that it was some C8 type of injury at the root level. However, the neurophysiologist also was not very sure. And the final line they have written that it is a CRPS can also restrict the movements like this. So what we did is, with my good friend, a radiologist who is a good musculoskeletal sonologist, he did the sonology of the nerves and found out that there is interfascicular edema in the median nerve, in the superficial branch of radial nerve, and in the ulnar nerve, cutaneous branch. So we injected 0.5 cc to 1 cc of xylocaine in the area where there was maximum tenals and maximum tenderness. And we found that there was some improvement in the movement, and patient had complete relief of pain. This was there for 2 hours. So this is also a diagnostic test which says that, okay, we can go ahead with the release of the nerves. Following this, we released the median nerve and the superficial branch of median nerve. There was a lot of tenosynovitis around the tendons because she was stiff for last 5 months. This was also excised, the tenosynovium. Then the ulnar nerve was also released, which was found compressed, and the cutaneous branch of ulnar nerve was also released from the volar side. Immediately post 1 week, the patient had significant relief in pain, and these are the results 1 month after surgery. Therapy was begun immediately. Patient was pain-free. There was no burning pain. There was no shooting pain, and the finger movement had been recovered. So this is another case which I am showing. This is now CRPS2. So in this case, we will find the cause of the nerve injury and will treat it accordingly. So this is a ganglion which is operated by an orthopedic surgeon, and he took an incision on the FCR sheath, and she was in plaster for a month, and after removal of the plaster, she presented to us in this type of this movement, lot of tremors and severe pain, and she was diagnosed as CRPS by multiple physicians. The tenals was positive along the scar. So you see here that there is a specific tenals here. The tenals is exactly on the scar. So we need to find the cause here. What is the cause of pain? She was posted for stellate ganglion block before referring to me. She had this burning pain, allodynia, EMG NCV again was normal. However, again, my friend sonologist, he told me that there is a suspected palmar cutaneous nerve injury. And we did this xylocaine block test, 0.5 cc along the scar. And this should only block the palmar cutaneous superficial branch, not the deep branch, like the median nerve should not be blocked. So only 0.5 cc of xylocaine is used. And the patient started writing, as you can see before. And this was again diagnostic that, so the cause is at the palmar cutaneous nerve area. So what we did is we released the palmar cutaneous nerve from the median nerve. The scar entrapment was released, and post 1 month release, the patient had good relief in symptoms. However, post 10 months, she was having good movements, but she had symptoms still. She was unable to write. Young girl, right-handed, unable to write. This was post 10 months of release. So finally, we divided the nerve, the palmar cutaneous nerve, and we buried it inside the PQ, pronator quadratus, and inside the bone. And post 1 month post surgery, she was able to write, and this was 1.5 years after the first surgery. So this is significant time the patient was in pain. The third case which I'll be discussing is which I call is as irritable nerve syndrome. Now this is a 45-year-old lady. She had a history of fall in the bathroom, entrapment of the forearm around 5 minutes. Little and ring finger loss of sensation and pain, and inability to flex the ring and little finger. Again, she had allodynia and burning pain. Analgesics, anti-inflammatory and nortriptyline were given to her. X-ray showed no fracture. So in this, there is no edema here. However, the patient has severe burning pain and shooting pain. and she's complaining that mainly the pain is along the ulnar side. Then she's also telling us that the pain is along the radial cutaneous nerve area. So again, we did a sonology and we found out that the median nerve appears to be, so the fascicles, there is edema between the fascicles. And the superficial branch of radial nerve also had significant edema. EMG NCV again was normal. And now we released the median nerve. The ulnar nerve also had edema. So we released the cutaneous branch and the ulnar nerve. And we also released the median nerve and the cutaneous branch of median nerve. In this, you can see that there is abnormal. So not all branches of they might sometimes arise from the ulnar side also. So this is a very variation in the palmar cutaneous branch of median nerve, and the superficial radial nerve was also released. So post 4 months, she was able to go back to her activity and had no pain or burning pain. So results, out of 7 cases, 4 were CRPS 2 that were treatable causes, 3 were CRPS 1, which were of which 2 was irritable nerve syndrome. And in all the patients, the VAS score reduced from 9 to 1 and stiffness significantly improved. So this is Dr. Francisco Del Pinal, who says that only you have to release carpal tunnel syndrome in all the cases of CRPS, and he has around 225 cases. However, I went further and released 3 nerves which had edema. So in summary, release and neurolysis of the affected nerve reduces pain, which indirectly improves the function. Ultrasound and xylocaine block tests are useful for diagnosis of the affected nerve, and most cases of cases diagnosed to have a cause of nerve injury can be treated. Thank you.
You, Dr. Bipin, will not be taking any questions. Dr. Satyakam, vagal nerve in central neuromodulation.
A very good afternoon to chairpersons. And at the very onset, I'd like to thank the organizing secretary and Dr. Anil Sharma, my colleague, for allowing me to be here in this wonderful gathering of minds. And warm regards from Amrita Hospitals, Faridabad. So unlike the previous talks, there are certain biases in my talk. Part of the bias is also attributable to Dr. Indira, who was my guide in NIMHANS, and I was very much introduced into central neuromodulation by her. My thesis was on rhizotomy and central cortical changes there. And so the other disclosures are that this talk would be again heavily biased for my passion for surgery for epilepsy, and also the technique that I would describe for VNS is based on Montreal Neurological Institute. This is a brief basically how we would go through the talk. The exciting part of vagal nerve stimulation is that it has numerous implications, and these are clinical implications which affect heart and inflammation, probably Alzheimer's and obesity, and therefore industry is very much excited. But again, my bias is towards epilepsy. I'll touch on all these other previous organs, but mostly focus on epilepsy and then future trends. So to begin with, there is a dateline which starts way back, almost 150 years back, when we started talking about vagal nerve stimulation. But it was in 1997 when FDA first gave approval for epilepsy management with a vagal nerve stimulator, and then later on for depression, drug-resistant depression, 2005. So briefly about the vagal nerve, the term vagus in Latin means wandering. And as we remember our anatomy books, is from Netters, you'll see it's a huge wandering nerve. You'd see it just wanders out from the brainstem, goes through the neck, through the thorax, then with so many different structures. But what we are concerned today is not about, in this talk especially, not about the peripheral innervations, but mostly about the afferent innervations that we have. And these start with the nucleus tractus solitarius, and from there the afferent fibers project to locus ceruleus, some parts of the cerebellum, going to the thalamus, intralaminar region, the thalamus, then innervating the hypothalamus, pituitary gland. Innervations have been found in basic science studies in amygdala, hippocampus, medial and orbitofrontal areas. And this significant thalamocortical projections which are involved in these innervations lead to central neuromodulation. So coming quickly to first the heart, which was extremely exciting for so many people because we thought, okay, we can reverse myocardial changes in heart failure because parasympathetic tone is often less in heart failure. So why not, like stimulate the vagal nerve? It was successful in animals, not successful as found by so many studies in humans. They are only in preclinical phase 2 trials. So we essentially stimulate the right cervical vagus, which innervates the sinoatrial node at very low amplitude current, and large afferent sensory fibers are usually innervated. Ischemia reperfusion injury, there was a lot of hope that, okay, we can do something here. Unfortunately, we don't have much data. Again, arrhythmia, it was thought it was a central neuromodulation, but Ling et al., they proved that it is actually myocarditis, which is suppressed, the arrhythmia because of myocarditis due to a peripheral acetylcholine release and hence inhibition of the inflammation markers. And so, but what excites us is this, the hypothalamic pituitary adrenal axis. So it has been proven now in guinea pigs and animal studies by Hoffman et al. That if you stimulate the central vagal nerve in the cervical region, in these animals, there is an increase in the levels of hormones in the blood, probably through hypothalamus, releasing CRH to pituitary, and then the adrenal giving rise to epinephrine or norepinephrine. And in their study, they found that actually, if you stimulate, the levels rise in blood, then you ligate this cephalic end of the vagus nerve, and you'll find that these levels do not rise. And this holds promise for asthma. What is actually approved is treatment-resistant depression, which 4,000 patients almost worldwide have vagal nerve stimulators implanted. There was a trial which was very nicely done, a sham arm and an active arm. It was found that, yes, there are subjective improvements. However, vagal nerve for epilepsy has been now established that it does help people in achieving a good quality of life. It is done worldwide. It is done for people who do not benefit from resective surgeries. But we must keep one thing in background, and that is that the incidence and the burden of drug-resistant epilepsy is significant, as was shown by this nice paper in 2000 in New England Journal of Medicine by Kwan and Brody, that almost 30 to 40% of patients have drug-resistant epilepsy. And the consequences of drug-resistant epilepsy are tremendous. They are not able to integrate into society. These are young people with benign lesions, and their mortality would be as high as 10 times sometimes. So we start thinking about how does the vagal nerve help in epilepsy? The answer is we don't know exactly how. But then again, coming back to the same picture, this is the pathway which is suspected to be involved. What the basic scientists have found that there are certain receptors of GABA1A which are found to be in higher concentration in the brain when the vagal nerve stimulator is applied. So essentially, GABA neurotransmitters are raised in the brain, glutamate goes down, serotonergic pathways are affected, and possibly query reticular activity system is also affected. So these are possible ways in which the vagal nerve stimulator works. And do we have any trials? Do we have animal studies? Yes, we have a lot. And the most important one was by Jacob Zabara et al., who did the study on 20 dogs, injected IV strychnine, and had a lot of seizures coming. And within a second, the seizures could be stopped by vagal nerve stimulator. But they had a serious flaw. They didn't use an EEG. They used EMG. And hence, there's a lot of criticism. But subsequently, we had more and more trials with monkeys, which were well-defined studies using sort of cortical lesions. And then again, vagal nerve stimulator was shown to be effective, but the results could not be duplicated. And therefore, in spite of these animal studies, the industry was not happy to support. So it's very interesting that from 1880s, we started stimulating the vagal nerve when Leonard Corning first found that you could stop a seizure by just pressing on the neck. And then it took almost more than 100 years to come to 1988 when we first implanted the vagal nerve stimulator in US in North Carolina. And that was by Dr. William Bell. An interesting part of it is it was Jacob Zarbara and a pacemaker scientist called Dr. Rees who left their original company, made a new company called Cyberonics, gave the implant to this neurosurgeon and the neurologist, and then they proved that, yes, it is seizure-free, a patient can be seizure-free. And once that was shown that patient could be seizure-free, you had a randomized control trial, which was done very nicely. It had good selection criteria. It had good exclusion criteria. It was multi-center, prospective, blinded. It had two arms, one which was for high stimulation vagal nerve stimulator and another for a low stimulation. And it was nicely carried out over multiple weeks, and people found that once the stimulator was started, after 12 weeks of baseline assessment, the rate at which seizures came down in patients was significant as compared to the low stimulation arm. So the high stimulation group did benefit, and more than 50% seizure control could be achieved. and side effect was just hoarseness. So basic technology still remains the same. There are two electrodes. One is a cathode, which is placed higher up cranially to provide the stimulus, and anode, which would hyperpolarize the nerve inferiorly so that you have less number of impulses going down to have lesser number of side effects. So how it acts, probably we have all discussed. So what are the basic surgical indications? Number one, which people have often said, and I would like to stress, it is a palliative treatment for drug-resistant epilepsy. It is not the gold standard, it's just palliation. And most of the indications are for age more than 12 years. However, there are more and more articles suggesting that pediatric generalized epilepsies do benefit from VNS. Basically, just on touching on the technique, this is again a picture from Montreal where we place two small incisions on the left side cervical along the skin crease, and the second incision in the infraclavicular region. This, for all neurosurgeons, it's a standard anterior cervical approach. We simply, and this is familiar for most of us, you dissect out the carotid sheath, you find the vagus nerve is large wandering nerve, no one can miss it. And once you see the nerve, you can put the electrode nicely, and it fits in quite snugly. This is a short video, and why I'm showing this is because you'll see that after having dissected the nerve, ideally we need just 2.5 centimeters of the nerve to be dissected, but we keep on dissecting inferiorly and try to achieve as much of resection, anatomical exposure of the nerve as possible. And why is that? That I'll show you in a minute. So here we're trying to put in the nerve, the implant there, and it becomes a bit clumsy initially, but because you need to pull it and strap it in, and then it falls in place. And the most important part of it is then attaching it to the to the platysma. So finally, it looks like this. So the pearls and pitfalls, why is it important to dissect inferiorly, is because that when the patient comes back for a redo or a battery change, which they will come to you after 1.5 years, probably 2 years, then you might find that lead is not working, the impedance is very high. In those cases, please do not remove the old lead. If you remove it, you'll damage the vagal nerve. So it is, if you place the loop inferiorly, you have enough nerve on top to place a new lead, fix it, come out. 3 centimeter strain relief loop is always mandatory so that there is not strain in the vagal nerve. Complications, minimal, hoarseness of voice. You can see it when the patient comes to clinic, when he's talking to you. These are the latest implants. These are beautiful. They can record your heart rate, probably preempt a seizure by looking at your baseline heart rate. Does it help the patient? It does, because the quality of life changes. Patients feel they have a control over the seizures. They can just swipe their arm over it. What is the future trend? This is all about vagal nerve stimulation, which is non-selective. We want to stimulate particular small fascicles of the nerve to reach the end organs. Can we do it? It's very difficult. We have tried, people are trying. There's something called fiber selective stimulation, where we try to make use of the different thresholds of the nerve thickness. Essentially, we don't know which vagal nerve on which side contains how many fascicles. There's a data which says 5 to 18 fascicles on each side, but we are not sure. So basically, if you ask me, we are still it's a research tool. We need to better understand the anatomy and physiology. We don't know how somatotopically the nerve is arranged in the fascicles. And then to conclude, this nerve definitely has central neuromotor opportunities. Opportunities are massive, but we still do not understand the anatomical connections, the somatotopic arrangement, and therefore we are not able to make use of it completely. Clinical uses are palliative. Vagal nerve stimulator, we as a team, when we offer VNS to a patient of epilepsy, we have admitted that we have failed in curing them, in finding a resection target. We have failed to localize the zone, and hence is palliative. And as VNS does have a lot of potential, the industry is very happy to support anyone probably because of obesity, Alzheimer's, migraine. They want to develop this field. And overall, in my opinion, I feel these are small but significant steps of integrating the central nervous system and trying to understand the central nervous system through a vagal nerve. Thank you. This is our team at Amrita Hospitals.
We are very sorry that we cannot take questions, but we have got our WhatsApp group, and that would be open for all the questions and answers. Please go ahead with it. Thank you.
Thank you, respected faculties, for chairing the session. Next, we have a plenary session. So I would like to invite Dr. M.S. Gopalakrishnan, Dr. Praveen Bharadwaj, Dr. Sunil Gaba, and Dr. Kanwaljit Garg to chair the session. Would also like to invite Dr. Sumit Sinha, to present regarding traumatic brachial plexus injury, a personal experience of 1,000 cases.
Hello. Yes, good afternoon, everyone. And thank you so much, ISPNS and the organizing committee, Dr. Anil, to give me an opportunity to share my whatsoever little experience that I have in this field. So talking about this adult plexus, now this is my learning, my experience about how I navigated through this over the last maybe 18 years or so in this practice. And the next few slides will be on this. And out of this, many of the slides must have been seen by you at various conferences. So my talk will be divided into what, when, and how, and it will go through this. So first of all, what to do when you see a case of a nerve injury, whether to operate or whether to conservatively treat it. So first of all, if it is an open injury, which are very, very less in number, what to do in clean open injuries, you have to explore immediately. If the wound is healthy, and clean incised sharp injury, end-to-end anastomosis at the same setting can be done. However, it's a surgical principle. If it's a contaminated injury, then to operate after 3 to 4 weeks and tag the nerve ends, and after that you can re-explore and do the necessary repairs after that. In close traction injuries, which are very common, which are more frequency, what you can do is you have to establish whether there is a root avulsion or not. And if it is, then it is not advisable to wait and waste the necessary time. Advisable is to do a neurotization or nerve transfer immediate. However, if it is a post-ganglionic injury, if it is not a root avulsion, then it is prudent to wait for some time, preferably less than 3 months, till 3 months, and follow the patient clinically and by EPS every 3 to 4 weeks. And if it is improving over this period of time and up to the level of functional restoration, then wait. However, if it is not improving with this conservative treatment, then you have to act and do whatever exploration is required. Now, when to do? There are pros and cons of both early and delayed surgeries. Early surgery, the advantage is early identification, clean surgical field. It identifies the normal fascicles, early rehab happens. However, the disadvantage is that you can miss the already ongoing natural renovation. And the delayed surgery, the advantages are that neuropraxic injuries that recover and tissue edema is resolved. The planes are well identified that delayed surgery. And however, with that weight, progressive intraneural fibrosis can happen, which can hamper your surgical results. BPI, we all know that. Now, this is for the residents who do not show a spontaneous recovery within 3 months, they should be explored. And why this time frame? Because if you delay it, then NMJ degenerates approximately 20 to 24 months after the injury. And hence, the best window is for 3 months. Indications for immediate and early repair are sharp open injuries, associated severe vascular injury, when there is a flail limb suggestive of avulsion or pseudomeningoceles are there on MR neurography. Indications for delayed exploration are then when the distal recovery is happening, but the proximal recovery is not happening. So you need to intervene. Now, how to do? What type of surgery? There are certain principles of nerve transfers which everyone should be aware about. Re-innervate the recipient and close to the target muscle is the number one. Nowadays, we call it various distal nerve transfers, hence the superior outcomes of these. Perform direct repairs whenever possible without a nerve graft, because 1/3 of the axons that you anastomose are lost at each anastomotic site. So you have to avoid as much as possible the number of the anastomosis in the nerve grafts. use similarly behaving neuromuscular units. We have seen amply, especially by Professor Indra Devi, about the importance of cortical plasticity, which is happening when you do a nerve transfer. And lastly, but not least, perform nerve transfer surgery as early as possible. And if the avulsion is there, do an earliest neurotization. A word about neurolysis. I know it's a debatable issue, but in my hands, I always give credence to this particular magic procedure whenever it is possible. If the neuroma is in continuity, I prefer to neuralize it, and has found to have very good outcomes with this technique. Now let's see about the treatment strategies that I have employed over the last years. This is neurotization. Everyone is aware about it. And indications are root avulsion and proximal injuries. And we have intraplexal donors and we have extraplexal donors. Intraplexal donors are preferred because of the obvious reason that they are more anatomical, they are more physiological to the brain. So it is better that you use them whenever they are available to you. And if they are not, then yes, there is no choice but to use the extraplexal donors. Now let's have a look about C5-6 injury. This is the holy grail. Now next 3 slides for the residents. What do we do? In the preganglionic injury, like I operated in live surgery session, triple transfer for shoulder abduction, external rotation, and for elbow flexion. This is a standard nerve transfer for an early injury, and late injuries also, of course. And early postganglionic, if you have a proximal stump, then you can utilize these stumps to obtain the necessary desired function. For C5, 6, 7, same algorithm. C5 to the lateral cord, upper trunk, C6 to the posterior cord, and C7 to the middle trunk of the posterior cord. And if it is a preganglionic lesion, then do a suprascapular to a spinal accessory to suprascapular, overlying SOMSAC, and you can choose to do an intercostal to axillary if it is available. So this is what for the C5, 6, 7, and for the lower plexus injury. For the late cases, you can do distal transfers for the nerve to brachialis to median or ulnar fascicle, or nerve to brachioradialis to the supinator, or supinator to the posterior interosseous nerve. For the global palsy, I mean, this is a very grim scenario. I mean, especially the hand function is a very, very problematic type of a thing and this is the algorithm for what you can employ for the global palsies. Secondary procedures, yes, I mean, they can be always offered they can always be offered, and this is what you can do. We have been hearing for the last 2 days about these procedures, and this is they are good in good hands. For my personal experience, I have this is the demographic profile of my patients, and majority of them fall from roadside accidents, and majority of them are in the young bread earner age group of the family. And I had majority of the panplexal injuries, and global palsies, they predominated in as expected, and total of 1,005 cases. And while I was at AIMS, this was a big number, but then when I moved on to corporate, slightly less because of obvious reasons. And the presentation of the injury, this is the most important factor while deciding about the success of your surgical procedure. This is what we lack in our Indian setup. The patients keep on moving around here and there, and they are being referred late. And this is what is reflected in the data here. Majority of patients, they are in the 3 to 6 months or 6 to 9 months. And we received patients as late as 15 to 18 months, which we chose to do distal transfers in selective cases only. So total patients operated, and we maintained a follow-up with OPD visits and telephonic surveys, and we lost the patients to follow-up about 20-21% of them. And this was the types of the surgeries. As I mentioned, neurolysis is always a part of my surgical armamentarium. And these are these type of the procedures. Sorry for being so fast. Time doesn't allow. And this is the rough outcome, grade more than grade 3 power of these patients. All sort of distal nerve transfers. This is what I employ in my practice. Is these are the transfers. And so the take-home message is that some treatment can be offered to these patients. These patients, also in global palsies, even as highlighted by Dr. Bhatia, even the weight of the limb, if the patient with your surgery says that it has improved, he's no longer feels the dragging sensation in his hand, it is somewhat beneficial to the patient. Early referral, of course, has better results, and the results of the surgery depends not only on the other factors, but most important is the time in which the surgical intervention has happened. Partial injuries, they have a magical outcome. I would say magical because this is with the advent of distal transfers. Now, in my training period over the years when I was a resident, there was a plexal reconstruction which happened more in practice, but then gradually transformed. And this is a paradigm shift in the treatment of brachial plexus surgery. Use of distal transfers have transformed the results of these gruesome pathologies. And this is, and in the last, I would like to mention that this is a multidisciplinary approach. Plastic surgeon, neurosurgeon, plastic surgeon, and this is what has to go hand in hand with for the better outcome. After all, we all work together for the betterment of the patient. Thank you so much.
You wait for 3 months. So currently, actually, with the advent of the neurography and every understanding of the new diagnostic modalities, if we are sure that there is a avulsion of the roots, then we can even proceed earlier also.
Yes. In my talk, I said, if you have proven beyond doubt that this is a avulsion rupture, there is no rationale to wait. Absolutely.
That is another thing.
Yes. Thanks.
So thank you, sir. Now we'll ask the next speaker, Dr. Ravi Kiran. He'll be talking to us about brachial plexus tumor management, his practical approach.
The brachial plexus are relatively rare and their presentation is generally vague. They generally present with an expanding mass, pain or paresthesias, and unless it is very large lesions and late presentation, neurologic deficits are rare. They arise either from the nerves or around the nerves. Basically, there are 3 types of tumors. One is benign peripheral nerve sheath tumors, benign peripheral non-nerve sheath tumors, and malignant tumors. Most common are benign peripheral nerve tumors. Evaluation, most common thing is the MRI of brachial plexus. And if there is a suspicion of any vascular elements in that, like vascular malformations, angiography is required. Based on the clinical scenarios and the history of previous illnesses, a metastatic workup also might be indicated if there is a suspicion of malignancy. Electrodiagnostics have a minimal role unless there is a signs of compromise in nerve function. Coming to the approach, the anterior supraclavicular approach, if the lesions are arising from root or trunks. Infraclavicular, if there is a lesion in cords or distal elements. In the gray zones, clavicular osteotomy might help. And the posterior approach is useful for intraforaminal lesions or the lower trunk lesions. Coming to a schwannoma, as most of them have discussed in the earlier presentations, interfascicular dissection to differentiate between the tumor and the involved fascicle is the most important principle. The fibrous capsule envelopes and separates the tumor from the nerve fascicles. Coming to the surgical exposure, neuromuscular structures proximal and distal to the mass have to be delineated. And it has to be dissected away from the adjacent structures from the involved nerve, loop both the ends of the tumors, interfascicular dissection, and nerve stimulation to identify the traversing fascicle functioning or non-functioning. Technique, open the capsule longitudinally, enucleate the lesion. Tumor is dissected away from the other fascicles. The capsule is trimmed away from the remaining fascicle. In this video, you can see how the tumor is being dissected from the surrounding fascicles. And looping the other adjacent structures
and nerve stimulation are very critical. Most of the times, neurofibromas are intimately involved in the tumor or the motor nerves, in contrary to the schwannomas, which are just abutting the nerves. Nerve grafting is required if the involved vesicle is positive for motor function stimulation. Malignant tumors as such require wide excision with soft tissue and radiation versus amputation in selected indications. My aim was to analyze the treatment outcomes of patients underwent brachial plexus tumor resection. All patients were evaluated clinically and radiologically. There were 6 patients in my series. One is schwannoma, the other is high flow AV malformation, 3 lipomas, and 1 lymphangioma. This is the first case. This young lady presented with a mass in the neck. She had occasional vague pain and tingling sensation in the arm, in the hand. So MRI showed a diagnosis of lymphangioma. It was traversing through the upper brachial plexus, roots and trunks. It was delineated and resected. It's a second case. A young girl presented with swelling in the neck since 2 years. She had increasing pain and numbness since few months. She was evaluated earlier by other surgeons, and USG guided biopsy showed a hemangioma. She underwent an MRI and contrast MRI, which showed a high flow vascular malformation. So the plan was a preoperative embolization followed by excision. So this is CT angiogram images. It's a MR angiography. So this DSA for the pre-op. This is a pre-embolization video showing a high flow AV malformation. You can see the arterial blush. This injection of the glue into the lesion. This post-embolization, we can see a coil in the vessel. So significant reduction in the blood circulation has been seen. The second image shows the image of the glue, which is radio opaque. After 24 to 48 hours, we have taken for intraop exploration and excision of the tumor. This supraclavicular brachial plexus exploration is right side of the neck. What we can see is C5 upper trunk in this, and the yellow arrow indicates the tumor. So we can the tumor was excised with neuromonitoring. The lesion was encircling all the trunks of the lesions very densely. In addition to that, multiple feeders from the subclavian system. The tumor was dissected. All the nerves were tagged and identified, and the tumor was excised in total. You can see the brachial plexus here intact. This is a tumor bed which was removed. You can see multiple ligatures and clips. It's a resected tumor. Another case is an infraplexus schwannoma affecting the medial cord. This is just after exploring the infraclavicular brachial plexus. You can see the tumor which is just abutting the lateral cord. On further dissection and delineation of the tumor, the structures were tagged, and it was found to be arising from the medial cord. So as I mentioned, fascicular dissection, and after removing this, it was running through a fascicle which was sensory one, and the motor fascicle we could somehow preserve it and stimulate it by showing the contraction of wrist. So complication, one patient had a temporary neuralgic pain for 3 to 6 months, was managed conservatively. Conclusion, brachial plexus tumor can be safely treated. Safe and effective results can be obtained if simple principles are followed. Thank you.
There be any questions for Ravi Kiran?
Next.
Ravi, interesting presentation. Do you do any tissue diagnosis before the surgery, or how do you ensure that this is a benign or malignant?
So based on the malignant as per clinical examination, the malignant tumors are more painful, rapid increase in size, and more neurological functions. But based on MRI and the clinical, if MRI is showing clear planes between the brachial plexus and the tumor, whereas malignant shows some encroachment into the vesicles.
So radiological diagnosis.
Radiological and clinical generally, because sometimes it needs high expertise to pinpointly going and removing that safely, biopsy and all.
Because it changed the management totally.
Yes.
Thank you.
The next speaker is Sanjay Sharma about injection nerve palsy.
Full screen. Full screen. Yeah. So thank you very much. At the outset, I'm very thankful to Dr. Anil Sharma for giving me this opportunity to talk about this problem of a post-injection palsy. And my talk is purely epidemiological, and we try to assess the magnitude of a problem at the Chhattisgarh region. So this study was conducted at Chhattisgarh for 2 consecutive years, 2001 and 2002, to estimate the incidence of post-injection palsy in the Chhattisgarh region below the 15 years of age. Till now, we do not have a true incidence of this post-injection palsy among the community. So this study was done. The data was collected during a acute flaccid paralysis surveillance to eradicate a poliomyelitis. So this was done in 2001 and 2002. The post-injection palsy was defined for a field worker as a asymmetrical monomelic involvement of the distribution of a nerve ipsilateral to the site of injection, and there was a temporal correlation with the injection. Of course, these cases are confirmed on the electrophysiological studies. So 2001, we had a 40 patient of post-injection palsy, and 2002, we have a 60 patient of a post-injection palsy. So in 2 years, we assessed 100 patients of post-injection palsy, and about 43% of patient of 43 patient, they are below the age of 2 years when the injection should be ideally given to the anterolateral aspect of thigh, but unfortunately, it has been injected into the gluteal region, resulting into the palsy. So in a small children, it's a predominantly a sciatic nerve involvement, 38 out of 40 cases in 2001 and 58 cases out of 60. That means we have only 2 cases of radial nerve palsy below age of the 15 years in each year. We performed nerve conduction studies, some motor nerve conduction studies. Peroneal is predominantly a division involved. Posterior tibial is involved only on 6 to 8% of patients. Radial nerve, we have very few cases of radial nerve palsy. The indication for giving this injection was very irrelevant. It was fever of 1 to 2 duration or a pain, and drug used are antibiotic, analgesic, and antipyretic. So we calculated the incidence of a post-injection palsy in 2001 and 2002. 2001, we detected 40 patients, and targeted population of that Chhattisgarh is 85 lakhs. So the incidence comes around 0.47 per lakh population. 2002, we had a 60 patient, and the incidence comes around 0.70 per lakh population. So the incidence of post-injection palsy as Chhattisgarh region for the year 2001 and 2002 was 0.47 to 0.70 per lakh of a population. So clinical features, I'm not going into a detail of clinical features and other things, but mostly it's a leg weakness and weakness of a dorsiflexor predominantly. Dysesthetic pain, which is out of proportionate, it's a very important sign. You can assess a tinal sign over the gluteal region. There may be a distal sensory loss, and sometimes you get the some wasting of a gluteal muscle. So these are the children: right foot drop, right foot drop, right foot drop, left foot drop below 2 years of age. These are the radial nerve palsy. The sciatic nerve is commonly affected in small children and frequently incomplete. The peroneal division is involved in the most of the cases. As you know, nerve is firmly fixed at the sciatic notch. The fascicle size are large and there is less connective tissue. NCV and EMG and MRI can be performed. So electrophysiology, if the compression of sciatic nerve may not produce significant abnormalities unless it's relatively severe. Usually there is a selective involvement of a peroneal and a sural sensory response, and there is normal saphenous sensory response. This you can see the nerve here in a piriformis fossa below a piriform muscle, and you can identify this now. And if the facilities are available, you can even go for neurography, which shows a S1 root, a formation of a sciatic nerve, and this hyperintense structure there is a dorsal root ganglion of S1, and this divides into the lateral division, which is a peroneal division, and a medial division, which is a tibial posterior tibial division. Management is conservative neurolysis, neurography, neuronerve graft, which has already been discussed. So coming to the prognosis of this post-injection palsy, coming back to year 2001, we had a 40 patient, and the residual deficit at the end of 2 months was present in 85%. But the prognosis of a sciatic nerve injury in the literature is not bad. In fact, the prognosis of sciatic neuropathy is generally favorable. 75% overall likelihood chances of a good recovery without treatment over 3 years. And if there is no foot drop, I don't think there is any indication for doing a surgical intervention in this group of patients. And this is a surgical series by Dr. Desai, and editorial written by Dr. Anil Sharma, editorial commentary. So they intervened in the 354 patient. 292 patients were with the IM injection. 53.7% make a good recovery. That's about 3, power about 3. There was no recovery noted in 46.3%, and worsening is noted in 2.5% of the cases. So this is what we need, more epidemiological data to praise a governmental agency, because this is not a small problem and it's unnecessarily happening into the country, especially below age of the 2 years. Thank you very much.
Thank you, sir. That was an eye opener. I think we should, our government should take some actions to bring this totally preventable disease down. Thank you, sir. Now I would like to call the next speaker, or the last speaker for this session, Dr. Weber. He will be speaking on neuromuscular ultrasonogram versus electrophysiology in nerve pathologies.
A very good afternoon to you all. A happy Makar Sankranti and a happy Pongal to all. I thank organizing committee and Dr. Anil and patient chairpersons for this talk. I have been given 12 minutes to talk about neuromuscular USG versus electrophysiology in nerve pathologies. And the target audience is neurosurgeons, all the surgeons. I hope you don't carry scalpels in your pocket. Really scared to give this talk. So with this, I start the talk. This is a brief of electrophysiology for all of you. Electrophysiology is nothing but converting a physiological function to something a human eyes can assess. Fine. A heart function converted to ECG is electrophysiology. Nerve muscle function converted to NCS EMG is electrophysiology, and so on. And this conversion takes with the help of some or the other machine. Okay. So with this basic premise, we start our talk. Regarding today's topic, we are talking about EMG, NCS, and USG, right? So in case of NCS and EMG, this machine is a nerve conduction machine, single machine, which can do both the investigations. And in case of nerve and muscle, this is converted to USG images. Why it is called electrophysiology in case of nerve muscle? Because we are analyzing waveforms. And why we are, while in USG, we are analyzing images. So what are NCS and EMG waveforms? NCS basically, as we all know, there are motor nerves and sensory nerves, which can be present simultaneously, fibers can be present simultaneously. when we call them mixed nerves. So in NCS waveforms, we record motor and sensory function. It's a superficial non-invasive test. And what do we record? We record compound muscle action potential and F waves, which comes in motor studies. And when we study the sensory things, they are called as sensory nerve action potentials. EMG, on the other hand, is performed in 4 states of muscle. One is we insert the muscle in relaxed states. Then we tell the patients and record something. Then we do in the minimally contracted state, and then finally in the fully contracted state. And we record something called as insertional activity and spontaneous activity in the relaxed state. Minimally contracted state, we study recruitment and MUPs. And finally, full contracted state, we study interference. So what are the abnormalities? In the CMAP, if there is increased latency, that is CMAP comes later than what is normal. Second, amplitude is reduced. That is, full compound total summation is not as tall as we possible. The tallness implies voltage, okay? And finally, the velocity of conduction is slow. In EMG, however, there are 4 different recordings. So in the insertional activity is increased or spontaneous activity. In the relaxed state also, you will find some activity. That is spontaneous activity. In relaxed state, there should be no activity in normal muscle. So what do we see? We see fibs, positive sharp waves, and fasciculations in the relaxed state. And when we tell them to contract, reduce recruitment. And this reduced recruitment is the most sensitive parameter for diagnosing the neuropathy. Okay. And finally, the interference, that is total contraction. When we see in the full contraction muscle, the interference is also reduced. So this is the basic, very basic introduction to NCS and EMG. This is how the waveform looks like. NCS waveform, the first one is compound muscle action potential. This is tallest and most robust one. You can see amplitude represents voltage. The distance of onset, that is called as latency. And the second one is snap. Although in this graph, it looks similar to you, but actually you can see there is microvolt. The second image is in microvolts. So snaps are very, very small. And compound muscle potentials are in action, are in this millivolts. So this is very tall. And last one is the F wave, which are called as late latency. The normal latency is around 100 milliseconds. Okay. And in the end, you can see those blue marked things are the F waves. And these are the abnormal waveforms. You can see the fasciculation, fibrillation, positive sharp waves. In the second case, you are seeing how does the motor unit potential looks. Second is for recruitment, and the third one is the lower one is the single MUP. And the last one we see here is where the recruitment is reduced. The top one is the normal, the second one is the reduced recruitment. And USG is obviously the scan you appreciate. It's just about the imaging. You can see the cross-sectional or you can track the whole roots. And here I would like to give a disclosure that I have not personally done the USG of the nerves, although many of the neurologists now are taking up the USG of nerves and muscles also. So coming to next, what does this USG versus electrophysiology means? So EP constitutes both EMG and NCS, and USG is the thing. So what is the basic difference between these two tests? The basic difference is overall USG gives you anatomical assessment, and electrophysiology gives you a functional assessment. And obviously there are overlaps. So we will just disregard the overlaps as for now. What are the drawbacks of each of these? Invasiveness is highest in EMG, where you insert the needle in the individual muscles. To less extent where you give in the NCS, where you give low potential currents. Sometimes patient is not able to tolerate even the NCS, and this is very painful. But most 90% of the time, patient tolerate this well. USG is obviously painless. Pre-test investigation is needed only in EMG. NCS is always a prerequisite test for EMG. You need CPK and some other tests for EMG. Anatomical function best in USG, functional info best in the NCS and EMG. All the tests are highly user dependent, technical dependence, and all the tests are extension of your history taking and clinical examination. Sensitivity for neuropathy is highest in nerve conduction study. What is the usefulness? What are the indications? Again, there are overlaps here. You cannot say that NCS is not at all useful in trauma. Can obviously localize the lesion here. But overall, USG, the trauma, leprosy, CTS, it gives very good result. Even in diabetic neuropathy, some new techniques like elastography are coming up. And wherever structural integrity is compromised, again, like cubital tunnel syndrome, neurofibroma, abscess, USG is best. In all these conditions, plus peripheral neuropathy, anterior disease, and all the other neuropathies, electrophysiology is best, which shows the functional integrity of the whole limbs. Now, just as the target audience is mainly surgeons, I will just give a brief word on carpal tunnel syndrome. My friend Dr. Abhijit will be covering this tomorrow, and there are 2 talks, I think, on carpal tunnel syndrome, where it will be covered in much more. This is a meta-analysis, which is the highest form of evidence. Sensitivity of electrophysiology, especially nerve conduction, is almost 90% here. And specificity is 77%. USG, it is reverse, 80% sensitivity, and specificity is higher, 90%. So why CTS? I have selected particularly CTS because, see, all the combinations are possible in CTS. You may get electrophysiology positive, USG positive, both. You can get electrophysiology positive, USG can be normal. You can get electrophysiology normal and USG abnormal. And you can get both negative. Then how you will diagnose? Still, you can go back literature and find out the gold standard for diagnosing carpal tunnel syndrome is clinical. Despite being everything negative, clinical features still remain the gold standard of diagnosis of the this thing. So here is the basic classification of neuropathies. All the neuropathies, electrophysiology diagnosis with 90% of sensitivity, except small fiber neuropathy, in which the NCS EMG will be completely normal. This is a small proportion of cases. Okay. So NCS sensitivity is almost more than 95%. All the tests, all the studies used nerve conduction studies as the gold standard against which these are compared. Other tests are compared. So now this is the classical standard book which we read as neurologists, and I hope you will also be reading, those of you are interested in electrophysiology, Preston Shapiro. How the book has changed from 3rd edition to 4th edition. 4th edition is the most recent edition of this book. See, the 4th edition, the whole chapter for clinical electrophysiological ultrasound correlation has been added in the electrophysiology book. So actually, electrophysiology is a form of EP test only. But this book also says that it is essential to emphasize that neuromuscular USG is complementary to EDX study and not a replacement. Okay, so the big question, should we consider EP studies, USG as a EP test or not? Well, I think you may. Just the scan versus waveform difference is there. So to me, this question seems actually a futile. Why to choose one? The best answer is in the combination of both. Mix curd and mix milk and then eat it. Use both and proceed with the patient on the patient-to-patient basis. If you are going for surgery, I think both should be performed before any type of invasive procedures. So I end with this with my puzzle. There's an email ID hidden here. So any of you interested in my talk or presentation, just mail to me. I will be more than pleased to mail you my presentation. Thank you.
Thank you, sir. Very nicely put. And you mentioned in the talk, but in the conclusion you didn't tell, and finally believe the clinical examination also.
Yeah, the topic was like that, but these both tests are extension of your good history and clinical examination.
Yes.
CTS, the diagnostic criteria still is
clinical.
GK is sitting here. We have been having many talks in the department. Like so many times, patient is classically carpal tunnel syndrome, but NCS, even the minimal comparative studies are totally normal. Sensory ulnar, you compare sensory and median and ulnar, they are also normal, but USG is also normal. You cannot do anything.
Yeah, but more the better. If we have all these investigations, more.
All three combinations.
Thank you, sir.
Thank you.
So with this, we end this session. And I think we are 2 hours late now. We have gone only 1 hour late. We are doing better. So we move on to the next session now. Thank you.
Thank you very much, sir. We would now like to proceed to our next session, adult brachial plexus injuries. I would like to invite our chairpersons, Dr. Ajay Nagraj, Dr. Sumit Sinha, Dr. Tatta Raj, and Dr. Raj Panas.
Hello. So without further delay, let's progress to the next session on adult flexor injuries. I call upon the first speaker, Dr. Amit Varade. Is he here now? Dr. Amit? Thank you. Is there? So till the excuse me, till the time he speaks, we can set up the next speaker there. I mean the talk of the next speaker on that laptop, no, isn't it? Yeah? Okay, we can alternate around, no, so that we can save time.
Very good afternoon, and I thank organizing committee for giving me this opportunity. I'll be talking on decision making about direct nerve repair or nerve graft. Whenever we talk about peripheral nerve, we should remember these two giants in the field of nerve surgery, Professor Seddon and Professor Sunderland. Professor Sunderland has contributed and described internal anatomy of the nerves, forming basic for group fascicular repairs. And later on, Professor Melesi has introduced microsurgery and peripheral nerve surgery. So in case of nerve repair and nerve reconstruction, direct end-to-end repair is always superior over delayed repair and nerve grafts. So like in this patient of 18-year-old boy, he had hit his hand on glass window and he represented on same day of injury. There was injury to median nerve and flexor tendons in zone 5 of the distal forearm. So we repaired the nerve primarily by using 8-0-ethylon under microscope, and tendons were also repaired. And 7-month follow-up, patient got very good result, and he had got a reasonably good thumb abduction and sensations also came back. So this direct nerve repair is good, but direct nerve repair is not possible in all the cases. Like when there is wound with gross contamination, such as in this patient, he was having open wound which is contaminated, and he was also having injury to median nerve. So here our primary aim is to cover the open wound with flap, and later on we can do nerve repair or nerve graft. Lot of times due to injury there is crushing of the nerves, and during repair we have to remove the crushed part till we can see normal nerve endings. So here we cannot repair it primarily. Lot of times patient present late, like in this patient, he was having injury to median nerve and FPL tendon. So median nerve was having neuroma that's why we have to resect the neuroma till we can see normal fascicular nerve. And after resecting, there was a gap, so we cannot repair it primarily. So there are other situations when there is life-threatening injuries of the patient, and sometimes in the periphery when appropriate setup is not available and surgeon is not available, in such cases direct nerve repair may not be possible. So if we see the classification of nerve repairs, primary is when we do repair in first week of injury, and secondary is any repair after first week. So whenever we talk about the nerve repair, we should remember these general principles. Maintain vascularity of the nerve while repairing. The nerve repair should always be tension free. and there should be proper rotational alignment. While repairing the nerve, cutback nerve, still it becomes normal in appearance. Under microscope, we should be able to see the fascicles, and surgeon should be familiar with the technique, and always it should be done under microscope. So technique wise, epinural repair, when we repair the epineurium with sutures, and it is while we repair it, there should not be any fascicular herniation. In perineural repair, repairing the individual fascicles and place suture through the perineurium. But in perineural repair, there is chances of trauma to the nerve in dissection and later on fibrosis due to the sutures placed. And group fascicular repair is indicated in large nerves with multiple fascicles and in nerves which do not have fascicular crossovers. So these are the techniques: epineurorrhaphy, perineuropathy, and epiperineuropathy. So as we discussed, direct nerve repair is always advisable over the nerve grafts. So there are sometimes situations which are in our hand, such as when we do nerve transfers, such as this patient nerve transfer we have done for brachial plexus patient. So this patient was young patient. He presented 3 months post upper brachial plexus injury. He was having grade 0 abduction of the shoulder and grade 0 flexion of the elbow. So this is medial exploration of the arm. Here we use one fascicle of the median nerve and ulnar nerve to neurotize with the fascicle with the branch of the bicep and brachialis. So here it is in our hand from where we are cutting the fascicle. We cut it distally so that primary repair is possible, and patient has got reasonably good outcome at 1 year and 2 month follow-up. So a lot of times there is gap at the nerve injury site, so we need to overcome the gap. This 23-year-old boy presented with laceration on medial aspect of the elbow due to sharp steel sheet cut injury, and on exploration his ulnar nerve was divided. So here there was a gap, but we achieved primary repair here. Like this, direct nerve repair was possible because we did anterior transposition of the nerve over the medial epicondyle. So another patient, this young boy presented after 3 weeks and he was having sharp injury to the distal forearm, and on exploration ulnar nerve, we found that ulnar nerve was divided. So we freshened the nerve ends and we have flexed the wrist joint and primary repair was possible. So here important thing is the flexion of the joint should not be more than 30 degrees. Otherwise, whenever he will extend it, the nerve will be stretched. And lot of times when we do reimplantation, in this lot of times we do bone shortening, so that we'll be able to repair the artery and nerve primarily. So during nerve repair in upper extremities, also we have to consider point of longitudinal excursion of the nerve and gliding of the nerves. Such as in upper limb, median nerve is having excursion of 7.4 mm at wrist and palm level and 4.3 mm due to elbow flexion. And ulnar nerve is having excursion of 9.8 mm at the elbow level. So whenever we are doing nerve grafting, consider the gap created at the nerve injury site plus add excursion required for gliding of the nerve. And lot of times we came across this situation and we have to think how to check intraoperative nerve tension, because we don't want to repair the nerve under tension. So flex the wrist less than 30 degrees, use 7-0-ethylon and repair the epineurium. And after the repair, there should not be epidural tearing and blanching of the vessels. And these are not fixed guidelines, but these are rough guidelines which guide us whether our nerve repair is under tension or not. So in case of secondary nerve repairs, it is far better to graft 2 healthy stumps than to join 2 fibrous scars under excessive tension. And however, there is no consensus or maximum gap that can be overcome without grafting. So a word about nerve graft. Harvested nerve graft shrinks in length approximately 20%, and additional length may be lost in final preparation. We cut the ends, we see the good fascicles. So harvested nerve graft should be 25% longer than the host nerve defect to compensate these changes, so that there should not be any excessive tension while repairing. So a nerve graft is cable grafts. When we repair when we take several segments of the cutaneous nerve, glue them together and repair them together. But in such cases, there is problem of vascularity. So to overcome this, we can do interfascicular nerve grafts. And sometimes we use split nerve grafts used in situations when graft is available as donor but cannot be used as a vascularized graft. We'll see this example. This young engineering boy presented with inability to move right thumb with absence of sensations in the thumb and index finger. He was having wasting of the thinner muscles, absence of sensation in the median nerve distribution. And on exploration, we found that he was having 4-month-old median nerve injury in the distal forearm level. So we have excised the neuroma, glioma, and there was a gap in the median nerve, approximately 4 centimeter. So we have harvested this sural nerve, divided into four pieces of 4 centimeter each, and repaired and did grafting between both the ends. And this is 1 year follow-up. He was nicely recovered thumb abduction and sensations in the median nerve distribution. So this was before surgery. He was also having stiffness before surgery, and this is the 1 year follow-up. So the take-home message is direct nerve repair gives superior results. Nerve repair should be done under microscope. In case of gap at injury site, if possible, try to overcome the gap by direct nerve repair. And in delayed cases, nerve grafting should be done. Thank you very much.
Thank you, Dr. Amit. We shall take questions later on. The next speaker is Dr. Sunil Gaba to talk on surgical exposure in adult plexal injury.
So, good evening, friends and chairpersons. Thanks to Shaminder to adjust my talk in the last moment to change the talk, because earlier I was given the topic of adult brachial plexus injury, and I thought a lot of people has been talking about that. And I will be talking about exploration, which is important for the younger people, and I hope I will try to give message to senior people as well. So as we all know that this is the anatomy of the brachial plexus, which we should be having in our mind all the time when we are exploring the brachial plexus, because here, if we see, it arises from 5 to T1 between the scalene anticus and medius, and go laterally, then divide trunks and then cords. Trunks lies mostly supraclavicular, particularly upper trunk, and middle and inferior trunk just under the clavicle. So what incision usually we give? We give curvilinear incision starting from the posterior border of the sternocleidomastoid and 1 centimeter above the clavicle. And then if we have to explore the infraclavicular portion, then we can extend it to the deltopectoral groove and go downward. So the position is really very important. Whenever we do, usually we go with the supine position. A folded sheet is placed beneath the scapula. The neck is extended gently and turned to the opposite side. So here, important thing is we have to keep the neck in extension, and elbow should be flexed and kept over the chest. So this is the common incision which usually we give. Yes, we can go with the simple horizontal incision, but if we give that, then there is a difficulty to explore the spinal axis nerve sometime. So we give this C-shape incision, which is, I have explained earlier also. So we give infiltration. Infiltration goes deep to the second layer of the fat. We usually give it infiltrate deeply as well. Give the incision, and this incision, after giving this incision, we raise this flap in the subplatysmal manner. So here we have to understand there is a 3 fat layers which come when we go to the brachial plexus. First is just beneath the skin, between the skin and the platysma. So first layer we have elevated with this subplatysmal flap, and after raising it, we can see there's a second layer of the fat, and on the medial side there is a external jugular vein. So then we dissect in this, we dissect the second layer of the fat. This we raised medially, and we tried to save the cervical plexus here. So if you can see there, we have saved the cervical plexus here. And This is the second layer when we raised. After that, we can see the inferior belly of omohyoid, which is running just close to the clavicle. So this is a very important landmark. Whenever we are exploring the brachial plexus, if we see the inferior belly of omohyoid, it means we have reached to the brachial plexus. That's the most important landmark. So we dissect out the inferior belly of omohyoid, retract it, and then you can see there is a third layer of fat. So now this third layer of fat, we usually don't raise it as a flap. We dissect it out through, and we find the brachial plexus lying just within it, just below it. So before dissecting this third layer of fat, usually we roll our finger in that area and we can palpate cord-like structures, so which ensure that yes, we are in the right area. After that, we dissect it out. In this patient, you can see there is a scarred cord-like structures. It is just above the omohyoid. So in this picture, you can see omohyoid is just lying close to the clavicle, and there's a scarred structure. And on the medial aspect of the incision, you can see there is a vertical one nerve is going down. This is the phrenic nerve, which is running on the anterior surface of the scalenus anticus. So we dissect it out and preserve it and save it. And then we dissect with our brachial plexus. So you can see as we go laterally in the incision, we can see the anterior division and the posterior division, the suprascapular nerve. This is the Erb's point. And we go to medially in the yellow loop, you can see that's the phrenic nerve. And scalenus anticus is just beneath it. So after this, if we have to explore the root, we have to cut the scalenus anticus. So cutting the scalenus anticus is important, but when we cut the scalenus anticus, we have to take care of the phrenic nerve. So here you can see in the yellow loop, there's a phrenic nerve, which we have just taken care, and we are cutting the scalenus anticus. Once you cut the scalenus anticus, you will reach the roots. So this is the picture. Here you can see all the roots, all the trunks has been identified and explored and isolated in the loop. So if you can see the C7, we can easily see. Unless we cut the scalenus anticus, it is difficult to see the C7 root in the supraclavicular incision. So this is the way how we explore the brachial plexus. So just to understand it, we give this incision, C-shaped incision, raise the flap in sublatissimal manner. I go to the second layer of the fat, dissect it out, preserve the cervical plexus, just look for the inferior belly of omohyoid, dissect it. You will see the third layer of the fat. Just go with that and just dissect it out. You will find your brachial plexus, and then you preserve the phrenic nerve and dissect out the scalenus anticus to reach to the root. So this is all about the exploration. So once we explore it, we may find a lot of situation there. So what kind of situation we can have? We can have a rupture of the root, and we can have a partial injury, or we can have avulsion. So in different scenario, we may have different options, which has been discussed earlier. So whenever we are proceeding to exploration, it is very important that we should be knowing how to explore the donor nerve as well, because what are the donor nerves that are available? So these things are also very important. So this has been talked since morning so many times. So these are the donor nerves that are available. And this is the standard protocol which everyone is following. So I will be showing few examples where we can change our plan on table. Like in this patient, I found C5 intact, and there is injury mainly to the C6. So I did C5 to SSN and the posterior division, and at the same time I did the Oberlin. So you can see the good result if you plan, because earlier we planned we'll do the triple nerve transfer, but in this patient, when we find the proximal root intact, we used it as a donor nerve. So you have to change according to the availability of the nerves. And here now we can see the spinal extensor to suprascapular. Here I usually do one modification, because when we do the anterior approach, spinal extensor nerve is usually lying very deep. So whenever I do this, I always use a gel form. I place it in the cavity, and which brings the spinal extensor nerve up. So it makes easier to anasmose this nerve to the suprascapular nerve. So I make small patties of the gel form, and then just put it in the deep in the cavity, and which makes the nerve, brings the nerve up. So by doing this, we can always have and it acts as a background for me also. So when we talk about the how to dissect the axillary nerve and how to look for the axillary nerve, so here the trick is always it is found under the teres major. So just retract the teres major in the upper quadricular space, you will find the nerve. So you have to retract the teres major. Few people cut it also. So this is a case of triple nerve transfer. So you get fantastic results in particularly younger patients. So I'm showing all the patients with good results. So if patient is young, definitely they will be having good results. And as I said, spinal axis suprascapular, I do this modification. It's really helpful for me. I hardly does posterior approach. And usually we harvest the intercostal nerve also. So trick here is whenever we are harvesting the intercostal nerve, we go as medial as we can go, but we avoid to take the most medial most part because it is mostly sensory. So as we dissect it out literally, we see that most of the branches going to the muscle. So we try to take those part. And here the trick is we give directly incision on the periosteum, retract the periosteum, and then dissect through the periosteum to prevent the injury to the pleura, because this nerve runs in the inferior border of the rib within the periosteum. So this is the ICN to MCN. So this is a few important exploration tips which I have given. So take home messages. We have to have a good understanding of the anatomy. Identification of inferior belly of omoid is a key landmark because it directs us to reach to the brachial plexus directly. Orientation of phrenic nerve and brachial plexus is very important. Phrenic nerves run vertically while brachial plexus runs anterolaterally. And for complete exposure of the nerve roots, we need to dissect the scanus anticus. Thank you. Thank you very much. Yes, sir.
If you injured pseudomeningocele or subclavian vein below, how do you manage it and how?
Subclavian vein below.
Yeah.
Till now, I have not injured, and that's the important thing because that's why it can happen. That's why I said once you dissect the inferior belly of omoid, after that you roll your finger over the brachial plexus, you feel like hard cord-like structure. Meningocele, yes, and the vein is never hard. So these are the things which you always keep in mind, and you need a good hemostasis.
What do you do? How to?
I have never done. I have no idea. We can ask Dr. Sumit. He can give a
So,
better answer.
regarding pseudomeningocele, I mean, I personally don't have any problem as far as the rupture of the pseudomeningocele during the surgery is concerned, because many times you don't come to know of it.
Yeah.
Number one, and even if you rupture it, it's hardly a problem of CSF leak. I've never seen that in my entire career. Right?
Yeah.
Anyone here may throw some light if he has seen. Yes, sir.
Yeah.
You want to say something?
I had one experience, sir. In the post-op period, in the evening, patient started having CSF leak. So we just had the lumbar drain put and then it sealed off.
We have encountered 2 cases of pseudomeningocele rupture when we had done it within 1 week. There was clavicle fracture which had to be operated, and so we had gone in early.
Acute is a different scenario. We're talking about late.
What we did, I'm just coming to. Put gel foam, take some fat from neck or from tummy, pack it with fat, take 2 or 3 sutures with surrounding muscles, and usually it stops. I mean, in both the cases that I had operated, it had stopped.
Yeah, yes, sir. Thank you. Thank you, Dr. Singh. So we move on to the next speaker, Dr. Durga. They'll be talking on trapezius transfer for shoulder abduction.
Good evening, chairperson, seniors, and my dear friends. Today, I'll speak on trapezius transfer for shoulder abduction in adult brachial plexus injury. The movements of the shoulder joint with a glenohumeral joint stability forms the very basis for providing a functional and purposeful range of movements across the elbow, wrist, and fingers. So as the shoulder joint, it has a very complex function with the movements and the stability. So I'm highlighting few of the joints like acromion is used in various, trapezius transfer. So these are the important joints, and the ligaments also, which are connecting the bones. The few acromion associated ligaments are also there, and the muscles of the rotator cuff and deltoid, trapezius, LD, and pec major. So here we can see various important ligaments which are attaching the clavicle and the acromion and the coracoid process. So, and with the clavicle and the rotator muscles along with the pec major, deltoid, LD muscles, which are important for the stability and the movements of the shoulder joints. So for the shoulder reconstruction, the primary repair and the nerve transfer is a gold standard. But in the shoulder joint reconstruction, there is an important role for the secondary surgery because the results are not adequate. Secondary surgery done in patients with the nerve repair is unsuccessful, or there is an inadequate recovery, or in cases of late PPI. So when we compare with the orthodesis, or some are using a free functional muscle, trapezius transfer has a vital role. And it has promised to restore the shoulder movements and has stood with the time since 1927 with the Saha's technique and various modifications. This has a role. So here I'm sharing my experience with the modified technique, protocol, and outcome in 20 patients, in which I use a three-fold of facial lata graft, and which is attached to the trapezius musculotendinous unit, and it is transferred to the deltoid muscle. So these patients are with the various pattern of injuries, with the reinnervation, partial recovery, and with the late BPI. So this is done after 2 years after the nerve repair or after the injury. And the important point is patient should have a good passive shoulder function. In my protocol, I start with the shoulder movements and the trapezius strengthening exercise since a day of injury. So for the operative technique, few key point steps are, I used to give a U-shaped incision over the lateral border of the clavicle, lateral end of the clavicle acromion, and the lateral spine of scapula, and the curved incision over the deltoid. So I raised a skin flap, which and leaving behind some tissue over the acromion and over the distal attachment of the trapezius muscle. And this flap should be dissected as proximal as possible. Then we raised give an incision up to the periosteum, including a periosteum over the acromion and the distal insertion of the trapezius muscle. And this trapezius muscle is mobilized as proximal as possible, taking care not to injure the neurovascular bundle. And it is separated from the skin and the underlying tissue so that it has a good mobility and good excursion for the insertion. And then the TFL is taken and it is placed in a three-fold stitch with the suture. And this is attached to the distal attachment of the trapezius muscle. And we can see a good mobility of this whole unit. And then this is sutured with the over the deltoid muscle, not as a single point of fixation, but as a mass effect. Mass suturing is done from the anterior, posterior, and the distal limit. And the shoulder is kept in the 130 degree of abduction. Here is a short, very short video giving an incision, and the incision is deepened and raised. Then after that, we raised a skin flap. We are leaving behind few small amount of the tissue and the fascia over the distal insertion of the trapezius muscle. And this flap should be mobilized and raised as proximal as possible. Whole extend from posterior lateral to the anterior. On anterior side, take care not to injure the spinal accessory nerve. Then after that, give an incision over the insertion of the trapezius muscle along deep to the periosteum. And take care not to injure the origin of the deltoid muscle. Then this is raised very delicately. It's a very flimsy, insertion. And it is raised along with the tissue which is over this distal insertion. And similarly, this is dissected very carefully and in the whole extent. Then we give a incision over the curved incision over the deltoid. And these flaps should be raised so that this can be inserted over the deltoid muscle. We can see the excursion at the movement of the muscle, which is mobilized. Then after that, we placed a tensor fascia lata graft over this muscle and sutured, and we can see the extent of the muscle and the tensor fascia lata. Then we raise the arm and we immobilize the joint. In this point, it is very important to not to detach the origin of the deltoid muscle. And the post-op protocol is the upper limb is immobilized with the shoulder in 130-degree abduction for 6 weeks. Then splint is decreased to 100 degrees for 2 weeks, then 90 degrees for 2 weeks, and then slowly adduction and abduction exercises to be started with the intermittent day splint, and the night splint is to be continued for 6 months. Then later the muscle strengthening exercises to be started. Result mean 116 degree of improvement of the abduction, and the improvement of dashboard was 38. These are the few cases. This preoperative shoulder abduction is here. Then after the trapezius transfer, 2 months, the splint is there for 90 to 100 degree. And slowly the patient was doing an abduction exercise from the 90 to 100 to as much as possible with the active and the assisted exercises. Then this is the 4th month when we remove the splint to start with the abduction and the adduction. Here we can see that there is a lack of adduction. Below 90 degrees is not possible. And this is 8-month post-op, where the full range is not present and some amount of adduction lack of 30 degrees also there. And this is 2 years post-op with a full range of movements. This is pre-op and this is post-op. Here we can see the contour of the deltoid. It is almost, there is no bulkiness, it is almost atrophic, and this movement is wholly due to a trapezius transfer. This is the patient with a restricted shoulder abduction, and the trapezius transfers were done after 2 years of post-op. Patient has a good amount of movement. This patient was 5/6/7 injury, where shoulder spinal accessory with the SSN was done, and the Oberlin was done. And he has a shoulder abduction of 30 degree. After that, we did a trapezius transfer, and this is 1 year, 6-month post-op. Similarly, this patient with the C5/6/7 injury without any shoulder and the elbow movements. Here the spinal accessory to the suprascapular and the Oberlin was done, and the shoulder abduction of 30 to 35 degree was there. So after that, we did a trapezius transfer. This is the 3-month post-op, where abduction is about 110 degree, but there is an adduction lag of 90 degrees. Then this is a 2 years post-op, where the patient has a full range of almost full, about 160 degree of abduction. This patient similarly had a previous surgeries, and patient presented with a shoulder abduction of 90 degree, where the trapezius transfer was done, and he has almost 160, 170 degree of the abduction. This patient presented to us with the late presentation with only shoulder abduction of 30 to 40 degrees, where similarly the abduction trapezius transfer was done. This is 3 months post-op, where he was allowed to do the only abduction beyond 90 degrees. Then this is 4 months with a good amount of abduction, but he has some muscle strengthening was not there. Then 9 months, his abduction was okay, but adduction lag of 30 degrees. So we are not worried about the adduction lag, that can be taken care. And this is 2 years. So here we can see the muscle over the neck. There is a bulk of the trapezius we can see here. Here we can see the deltoid contour, and in the neck we can see the transfer trapezius muscle bulk. So the other technique disadvantages according to me of the osteotomy and disruption of ligaments and muscles, and morbidity due to a bone healing, and maybe some site there may be osteoporosis, so there may be a failure, and loosening of the screws are there. With my technique, it is simple and feasible. Bony framework ligaments are maintained, and no osteotomy related complication. And it is a transfer of a whole musculotendinous unit along with the graft, not a single point fixation. And this has an excellent result in upper brachial plexus injury, but other also results are satisfactory. Thank you so much.
So we'll have question at the, later on. Now I invite the next speaker, Dr. Devajyoti Queen. You're already there.
Good afternoon, everyone. Thank you for this opportunity. I'll try to keep it short and controversial, going by the theme of our meeting. Almost everything in this title is controversial because interfascicular neurolysis, many swear against it. Chronic, we are not sure what is chronic and neuropathic pain, whether it's 6 months or 1 year. And when it comes to non-compressive, it's not grossly non-compressive, but then again at the interfascicular level, there is compression of the fascicles. So we'll start off with the first case. It is a 26-year-old gentleman who came with history of foot drop and also pain on the lateral aspect of the foot, because of which he was not able to walk. There was a through and through knife injury through the left thigh. We were expecting because the other functions and sensations were intact. We were expecting partial sciatic nerve injury. So we explored the sciatic nerve in a prone position in the lower thigh, and we found adhesions on the lateral aspect of the sciatic nerve. So we went ahead with interfascicular neurolysis. On the right, we can see the microscopic image where we found one fascicle to be damaged. And if we see closer, there were there were what they call as hourglass or collar-shaped constrictions of the fascicles. One here, and there were 2 or 3 on the other one. So we took a sural nerve graft and repaired the fascicle which was found damaged, and released the contractions interfascicularly under microscope, and the pain was gone immediately, on the very next day. And we have followed up this patient for around 8 months now. He doesn't complain of pain or paresthesia. But the foot drop has still not repaired. It was around 1.5 years from the injury when he had come. So he needs secondary procedures for the foot drop. Thereafter, we had another patient with upper sciatic nerve penetrating injury for which we had done neurolysis, and she said there was 80 to 90% relief of symptoms. So that brought us to the third patient who came with history of venous malformation in the posterior aspect of thigh. He was a 24-year-old male who hadn't slept properly, according to him, for last 8 years. He had undergone 4 to 5 surgeries for venous malformation, and there was only a particular position on a reclining chair where he could sit and sleep. That's how he has been sleeping for the last 8 years, and he couldn't walk properly. He complained of constant flowing kind of pain throughout the limb from upper thigh to tip of the toes. So we did a imaging, and we found there were residual phleboliths along the posterior aspect, and there were inflammation along the long segment of sciatic nerve. Here we can see the phleboliths being removed first, and this is the entire segment of sciatic nerve, almost more than 15, which was found to be fibrosed. So initially we did epineural resection, but that was not enough. The fibrosis was quite severe. So under microscope, we did interfascicular dissection, taking care not to cut the interfascicular connections also, so that we do no harm. But eventually, this is after 11 months, he is able to walk and he is able to squat. His pain during the initial 6 months, according to him, was 70% lesser. But now at 11 months, he says that it has almost come back to his previous stage, like maybe 10% lesser. He is able to sleep in a lying down position, but as soon as the other leg touches his previous leg, he feels the same shock kind of pain. And there has been neuropraxia, as in foot drop, not completely, but partial, which is recovering slowly. So, going by a few of the publications, is the old one, 1980, where they said none of the patients recovered after operation and all developed severe or sometimes persistent paresthesia. And in our conclusion, the interfascicular neurolysis of, in this case, ulnar nerve should be abundant. This was quite a strong statement. Here they had described epineural fibrosis, that is the epineurium becoming thickened, perineural fibrosis, and then there's fibrosis of the connective tissue in between. So they had done interfascicular release, but if we have a closer look at the nerve don't really look healthy. And when we go by the duration here, chronic cases were taken, but from 4 months to 21 months were included in this. Coming to another paper of where carpal tunnels, where neurolysis in interfascicular neurolysis in carpal tunnel were meta-analyzed, and they found the same. And they said there's more harm than benefit because of the persistent paresthesia. And other papers related to sciatic nerve say that the paresthesia comes back because of the fibrosis coming back. So here is another patient where after we had removed all the plates and he complained of the Tinel sign was positive right on the median nerve with pain radiating to the radial aspect of the index finger. So we did interfascicular neurolysis, and there was severe fibrosis at one point, which we can see here. So after interfascicular neurolysis for this, for the last 6 months, he is pain-free and doesn't complain of any pain. So, which brings us to a few questions, as in, is there a limited amount, length of nerve which we can neuralize safely? Because there is the vascular component supplying the nerve, and there is the fibrosis component when the rehealing is happening. And what is the best time to do it? Because many a times when you release the compression over the fascicle, if it is early, the healing is better and regeneration happens. And if it's a late one, it doesn't. But the pain usually settles. So there's another paper by Julius Tertius in 2008, where she said that advanced microsurgical procedures like interfascicular neurolysis and use of vascularized nerve grafts and vascularized fascia should be kept in mind in complex and previously failed cases. And there she said that the results are best when it's done within 5 months and when the length of the graft or the nerve is less than 5 centimeters, for obvious reasons. So, in this era of super microsurgery, I think we need to revisit this interfascicular neurolysis, because now under 10 to 20x magnification, we are quite sure that we will not cut any fascicle, or for that reason, even the interfascicular connections. But what about, so it has an exploratory role, and under the microscope, if we find the nerves to be not healthy, we can always cut those particular fascicles and graft only the fascicles which are not looking healthy. But we still don't have an answer as such of the refibrosis, as in once we keep the once the neurolysis is done, the pain goes. But it comes back maybe 6 to 7 months later. So whether free tissue wrap, free fascia, or free subcutaneous tissue wrap providing healthy vascular tissue around the nerve will solve this persistent problem. I'll leave you at this. This is our team in Amrita, Faridabad.
So very nice, Devajyoti, very nice paper. I mean, as we have decided, we'll have the questions at the end of the session. And I call upon next speaker, Dr. Nichal Naik, for his talk on nerve surgery in birth brachial plexus palsy, beginning of long journey.
Good evening, Chairperson, seniors and friends. I'm here as a part of team CVPC from Ahmedabad. Now, first of all, the child will be born at obstetrician's place. He will be calling pediatrician, and then a lot of persons will be coming into picture. You cannot just keep on shooting the child which is newborn from one place to other. So what we decided is to form a comprehensive brachial plexus clinic in Ahmedabad in 2012. So far, we have 954 cases enrolled, and 63, that is only 6.6%, have come up for nerve surgery, of which 13 have been operated in last year. So of the 15 cases operated before that, 22 cases have required some or the other case of secondary surgery, secondary reconstructive surgery. And luckily, most of these patients have been Narakas 3 and 4. Our protocol is just like routine. If there's no biceps at 3 to 6 months, go in and operate for nerve surgery. Otherwise, wait till 9 months. Check for cookie taste. If child passes the cookie taste, no surgery. If fails the cookie taste and shoulder is poor, go for plexus reconstruction or distal nerve transfer. If there is good shoulder, then some amount of shoulder rebalancing and nerve surgery. In Narakas 3 and 4, I think it's quite straightforward. At 3 months, if there is no recovery, if there is Horner's, there is no biceps, you go in and operate. Now, after this, the secondary surgeries come into picture. Usually, shoulder rebalancing has to be done after 1.5 years to 2 years of age. That's the earliest that you can do. Many times we may have to do it at the time of surgery, where you can do subscap release or just passive stretching and giving spica. To check that, you need to have MRI classification. Peter Waters have given a very good classification of shoulder congruency. If there is congruous glenohumeral joint, usually you get away with soft tissue surgery. But if there is non-congruous glenohumeral joint or there is dislocation, then you have to go ahead with either humeral osteotomy or scapular osteotomy. In infants, we get shoulder ultrasound done to check, because before operating, you check for external rotation. If that is not good, you may have to do subscap release, scapular stretching, and spica. And in adults, we go ahead with, bigger children, we go ahead with MRI. Check for the humeral head that is behind the scapular line, and check for dislocation or sublocation if it is there. For elbow FFT, newer concept is that brachialis is more of a causative agent for elbow flexion deformity rather than the biceps. Obviously, triceps weakness adds to it. And the surgery for this has to be done at 5 years of age. Our approach is, if it is less than 20 degree FFD, give a push elbow splint and wait. If it is more than 20 degrees, and if the triceps is weak, then go for brachialis to triceps transfer. If the triceps is strong, release the brachialis, attach it again with biceps, stretch it. You may require anterior elbow capsulotomy at times. And this is the result that you get after that. If the elbow extension is weak, it should primarily be treated while you are doing the first surgery. Don't forget to give good cables to C7. But in other cases, you may have to do brachialis to triceps, which may lead to some amount of elbow flexion loss initially, but it recovers with time. Or you may have to do a lower trapezius to triceps transfer. Free gracilis is another option for triceps reanimation, but it has not given very good results in most of the hands. Forearm issues that you face will be supination deformity or pronation deformity. It can lead to, beggar's hand or unshakable hand. You cannot shake hands with it. You cannot do tabletop work activities with that. 65% of patients who have distal paralysis have one or the other problem, either supination or pronation deformity. We prefer to treat it after 7 years of age. Can be done before that with osteotomies if the deformity is severe. Our approach for this is, if it is passively correctable, then check for biceps. If there is strong triceps. If there is strong triceps, biceps rerouting is required. If the triceps is weak, then brachioradialis has to be rerouted from forearm. If it is passively correctable but terminally stiff, the same procedure with anterior interosseous membrane release. But if it is fixed deformity, check for radial head location. If it is well located, pronation osteotomy works very well. Give it in over-corrected position. If it is dislocated, pronation osteotomy with biceps to ulna transposition. For hand deformities, you have to assess thoroughly all the muscles. Individual muscle charting has to be done. Luckily, majority cases are Narakas 1, C5-6, and hand is unaffected in that. Evaluate for tendon transfers, bony fusions, if there are no adequate tendons available, and none of this works, then go for free functional muscle transfer. Common indications for surgery: lack of wrist movement in one way or either way, flail wrist, thumb opposition, medial, most of the times ulnar deviation, lateral or medial deviation, finger flexion, extension, and intrinsic functions. This is the sequence which we would like to follow in reanimation. Most commonly, we do for Narakas 3 and 4 cases. Usually they end up with wrist and first CMC arthrodesis. Chondrodesis is preferred in pediatric cases as it will not hamper the growth, and we prefer to do it after 7 to 9 years of age. And this is an adult case, obviously. Chiseling of dorsal radius and removing all the cartilage with proper fusion of all the bones. Chiseled radius is used as a bone graft. Reverse it, fix it into carpus, and put a plate over it. Cover soft tissue properly over the plate, otherwise your tendons will get attrited. And FCU to ADC transfer was done in this case. At the same time, first CMC arthrodesis and web space which gets contracted because of lack of physiotherapy. A Z-plasty works well for that. Centralization of wrist, I think Ganga Hospital has given us a good article for that. If there's severe ulnar or radial deviation, tendon transfer, either flexor to extensor or extensor to extensor tendon transfer can be done. And this is one case where we reconstructed everything from single root. Probably intercostal nerves were not used because we had done it at beginning of our practice. But the good thing is to see the same patient dancing in a group with reasonable good coordinated movements. This is second case, C567 nerve injury. This child also required shoulder rebalancing because external rotation was weak. There was excessive pronation, supination osteotomy was done, and the child has very good function. And this third case where C5 to T1 roots were involved and tendon transfer was also done. So to sum it up, the nerve surgery forms a platform for reconstruction of near normal upper limb with subsequent surgeries, and role of physiotherapists should not be underestimated. It's required for at least 7 to 8 years. Thank you.
Yeah. Thank you very much, sir. Very nice paper. And one comment for all the presenters, like we had Dr. Amit, Sunil, Dr. Durga, Nishal, and Devajit. Please submit all those articles to our society journal, which is Journal of Peripheral Nerve Surgery. So, and for other delegates as well. Rest of all, this paper is open for the comments for all of the presenters of this session.
Sure.
So if there is no comment, then we can move to the next session. Thank you very much. Thank you very much, everyone.
Thank you very much, sir. We would now like to proceed to our next session. This is a video session of how I do it. I would like to invite the chairpersons for the session, Dr. S.N. Madaria, Dr. Amol Raheria, Dr. Dakesh Saha. Please take the dais, sir. I would now like to invite our first speaker, Dr. Deepak Agarwal. Sir will be showing a video about facial-hypoglossal anastomosis.
So good afternoon to everyone, and it's been a very lively session since morning. We are getting to learn a lot of new things. I think that we can incorporate in our practice. So I will quickly go through facial hypoglossal anastomosis. We as neurosurgeons see a lot of facial palsy. I think most of which we are creating ourselves, iatrogenic injuries, and following most commonly acoustic neuroma surgeries. So these patients are usually, when they come back with grade 4, grade 5 facial palsy, most of them are wanting something done, but are not wanting another surgery. So it takes some time convincing them. And I'll quickly show you the video of the facial hypoglossal anastomosis as we do it. This is the positioning of the patient, supine. So this is a right-sided facial palsy we are treating. And this is the marking. We make two vertical lines anterior to the tragus and posterior, and the mastoid is forming the inferior portion. So actually the facial nerve is there between the parotid gland and the mastoid tip. the biggest problem is how deep do you go? You need a little bit of experience. It lies approximately 2 to 2.5 centimeters from the surface of the skin. So it is that deep. And if you, I'll just, so if you look at when we reached 2 centimeters deep, you can see the facial nerve and you can see the various divisions in this, as we are seeing here. So this, then you trace this distally, proximally. And here, if to orient you, this is the mastoid tip, this is the parotid out here, this is superior, this is inferior. So we have just marking out the branches and cutting it, the facial nerve, as close to the stylomastoid foramen as possible. Once we cut that, we'll get the facial nerve free. And obviously, to free it, you'll need to cut the cervical branch to get it available. And this is the facial nerve which has been prepared. The next step is to make the incision submandibular, which we make around 1 to 2 centimeters below the mandible. And after making the skin incision, we try and trace the 2 landmarks are the posterior belly of the digastric, because the hypoglossal nerves lies posterior to the posterior belly of digastric. And the second is the carotid bifurcation, because it lies slightly higher than the carotid bifurcation. So here you can see I'm just exploring in the submandibular phase. This is again superior, this is inferior, this is lateral, this is medial. So I hope you are all oriented here. And as you go down, you can see this pearly white nerve. Obviously, we should have a nerve stimulator to make sure with a needle on the tongue. So it becomes very nicely visible. What is described in the books is that the ansa cervicalis you should identify, go up and cut it, although it may not be necessary, as we see in our case. And we keep dissecting it as distally as possible, because we'll need a long length of the graft. So we are dissecting it out as distally or medially if you want. And there have been some controversy whether you should do a end to side, end to end, or a split graft. I usually do a split graft. The problem is in splitting. I think sometimes you cannot get the fascicles out, because it's a very tightly intertwined hypoglossal nerve. And so we are trying to open up, but it's very difficult because the fascicles cannot be separated. But you have to be patient. You have to do it, continue working on it. It will take 15-20 minutes, half an hour. So if you keep doing it, you'll find some fascicles, and keep working on them till you can identify a fascicle which is stimulable. I would rather keep a thinner fascicle anastomose to the facial nerve and keep the thicker one available for the tongue. And then we release it going all the way back towards the facial nerve. And all these structures, we have to preserve the facial vein and the arteries, whichever are there. So here I'm trying to get it out and tracing the hypoglossal nerve more proximally. And we're just putting a loop over it. So once we have done that, and we have exposed the whole fascicle as proximal as possible, it becomes relatively easy to do the anastomosis. And the bottom line is you have to be patient. Here we have got it here, and you have to try other techniques, because if you're not able to get it, I sometimes use the knife to open it up, and sometimes it becomes visible after doing all these knife, scissor, whatever you want. You have to separate the fascicle, otherwise there will be issues. And try and get as much length as possible, because obviously that's the standard teaching, that it should be a tensionless anastomosis. So we have got a decent length now, and this is the length you can see we have de-zoomed to get the picture here. And we have the facial nerve you can lying here. So we get that facial nerve there. So it's reasonable. The diameter is reasonably good if you look at the facial nerve. And this, by the way, this patient had injury around 3-4 years. I mean, that time it took for the patient to say, okay, I'm ready for another surgery. Usually the timeline for surgery, ideally they say should be done within 6 months to 1 year. However, practically you don't get patients who are ready for surgery at this time. And this is the immediate, you can see that immediate result. There is slight deviation of the tongue which recovered after a month or so. We don't have long-term post-op, but we have for other patients. And if you see the largest series in the literature, what they say is that 90% plus, if you do it within a year or so, will have such a good function in grade 1 or grade 2 or grade 3 function of facial nerve. So we have done I think 5 or 6 cases only till now. So, but this is a very good technique in the armamentarium. Thank you so much.
Thank you, sir, for the wonderful talk. We'll proceed with the next presentation by my colleague, Dr. Dattaraj. He'll be presenting on rhizotomy procedure.
Mike? So idea of this presentation is another is the teamwork, that you should know how to do a procedure. And another thing is how to simplify it. You need a simple instruments, and you can convert complex problem into a simple solutions. So the idea is like microscissor rhizotomy. When you see, like we have discussed whole day, like how these patients are under tremendous pain and they need some help. So if you know solution, which generally you do for the other procedures, and you can provide them a good solution with less economical things, why not? So idea here of this presentation is there is certain treatment which is needed and you should know how to do it. So this is the dorsal root entry zone, as you can see here, and this is our area. This is dorsal horn, where you need to do a lesioning. So these are the few components that you should know it. There is a posterolateral sulcus and dorsal rootlet. Like this is in the normal patient. When you go for the root entry zone injury, when the roots are avulsed, you can't see anything there. But in that case, you have to go proximal and distal to that area and identify the normal rootlet, which will guide you into the posterolateral sulcus. And what you have to do is just like a small lesioning there, so that patient is pain-free. This is normal anatomy. You can see that this is the responsible area where you need to do a lesioning. These are the various pain procedure fibers, and I will not go into the detail like how this mechanism of pain work, but one of the important factor when you go for the patient will get relief, these are the if it is intermittent, sharp stabbing and segmental pain, they respond better compared to the chronic burning pain. And why to do it? Generally, these are the extended indication. What we are talking here is intractable brachial plexus avulsion injuries, but there are other lesions, other diagnostic modalities where we can provide those same solutions. Sindha was the first one who described it way back in 1972. Then there were subsequent modifications by the Nashold and then Levy with the radiofrequency ablations. What we presented is a simple solution with the microscissor, without any ablation. So as you can see into this image, these are Rex laminas, and what is described in the literature that lamina 2 is one of the most important things where you have to cut it, go in depth and have a, good relief if you cut it there. Some of the article like Takai has went till the lamina 4. So, but what generally we do till lamina 3 or 4. This is the way that this diagrammatic representation, how we cut the that posterolateral sulcus for around 2 to 3 millimeters. When we use the scissor, one of the important things that we mark on the scissor is around 3 millimeter mark, so that when you guide into that sulcus, that it gives you a depth perception that you don't have to cross that area. One of the important thing again to identify here, just medial and anterior to your that posterolateral sulcus is lateral corticospinal tract. So if you don't maintain the trajectory, so what is the trajectory? You have to maintain around 35 degree plus minus 10. I mean, approximately we say it's around 45-degree trajectory to the midline. And this is the area where you have to direct. If you go too medially, you will have a proprioception deficits. If you go too anteriorly, patient will have the motor deficits. So one of the important thing, like stay 45 degree into that posterolateral sulcus and go for 3 millimeter max. These are diagrammatic picture. You can see this is posterolateral sulcus on the right side. This is wall. Everything has opened up as a book, and you can see this is the mark on the scissor, which is around 3 meter. We are not going into depth. We have treated around 56 patients, and we have around 80 to 85% good relief into the symptoms. And out of that, around 6 patients required have a recurrence, and 4 patients require resurgery. So, I mean, good outcome. And when we think about the complications, hardly around it was less than 9% compared to the various series they have presented. Like when compared to the ablation and going into deeper, these people have around 50% to around 70% complications. So restricting yourself with micro scissor for 3 millimeter, we had better results. These are the expectations by the patients, the good pain relief, good quality of life, better sleep, and economically productive life. And as I said earlier, what can go wrong? Motor weakness if you go too laterally, paresthesias, dysesthesia if you go too medially, and loss of proprioception as well. If you go too medially, you can have bladder incontinence and autonomic dysfunction. So be careful. It's not completely safe surgery if you don't follow the tips and tricks. Various other options we have discussed, including neuromodulation to selective dorsal rhizotomy, but this is very good approach in, and can be replicable. This is the video done by my colleague, Dr. Ramesh. Dr. Deepak Agrawal has given this procedure, like we started doing way back, and a whole of our team do it. Rajesh, Dr. Hitesh is here, Kawaljit, Amol. So we all do that procedure. It's that applicable. We had a patient who has 2 years back injury, right side, completely flail limb. And this is a pseudomeningocele suggestive of brachial plexus avulsion injury. Approach is very, I mean, for a neurosurgeon, it's very simple. Like we go ahead with the midline exposure. Here, as we are approaching on the only unilateral side, we do the hemilaminectomy. We do periosteal dissection of the muscle only on the same side. Not you don't have to take complete lamina off. You can use the bone CUSA, or even you can use the routine things to cut that hemilamina, expose the dura. Then you can have a dural opening. You open the dura on that side. One of the important things that I said, like go 2 level up than the level of the injury to have a myelotomy. So, and another important point, you have to identify normal rootlet above and the caudal area of the injury. Once you identify that, as you can see, this is small rootlets. We are going under it, and then we dissect those posterolateral sulcus, and we start doing a myelotomy there. Dissection into that sulcus with a scissor. It's a micro scissor. Only when there is a serious bleeding, we will go ahead with the coagulation. Otherwise, it's not needed. It's, I think, few seconds video remaining. You can see that this is the mark on the scissor, and it's a continuous lesioning at that time. And with that mark also guide us into that. And then dura is closed, you put the glue, and then patient is pain-free. So 80 to 90% of patients are pain-free. It's a good result. So carry home message is like, it's very underutilized procedure for refractory brain syndromes. We are doing it quite better way nowadays, and we propose that it should be done very nicely and can be done in any institute. It doesn't require very good or significant gadgets. It's one of the best indication, brachial plexus avulsion injuries, and it can be done for other lesions as well. So it's the best suited for like India resource limited settings. Thank you. And this is for neurosurgeon and spine surgeons. We have our 12th annual spine workshop in August. You all are welcome for that. Thank you.
Thank you. After a very good video, I am calling Dr. Raja Tiwari talking on the nerve injury, nerve grafting.
A very good evening, chairpersons and audience. My today's talk is a basic operative technique for nerve grafting. So as you all may know, the nerve grafts are usually required for acute or chronic injuries where the nerve will have a neuroma in continuity in chronic cases or a defect in the primary cases. And after microsurgical exploration, we find either there is a total defect or there is a partial defect. Now, my case was a 30-year-old male who suffered electrical burns of the forearm. And during the course of his recovery, he suffered loss of the tendons, the median nerve, and major part of his thumb. So the plan was to cover this scarred area with a westernized flap cover and simultaneously do a nerve grafting for the defect. So mostly for we use a sural nerve grafts, and we use small incisions for taking smaller nerve grafts. But if we are doing a bigger nerve defect, then we mostly try to do a long incision. So after getting the nerve grafts, I usually also take the sural communicating nerve so as to get 3 fascicles for reconstruction of up to 15 centimeters of a median nerve defect. And as you may see, we also have to reverse the nerve grafts in order to prevent sprouting from the cut ends of the nerve. So the first step, once the proximal nerve stump is there, is bread loafing of the neuroma in continuity. And as you can see, we continuously irrigated and painted with ink so as to make the fascicles which are bulging out more conspicuous. Also, the assistant has to simultaneously put counter pressure from the stick which is placed down inferior to the nerve, and this eases in the cutting of the nerve. Now you can see the nerve fascicles which are healthy are very nicely seen, and any bulging nerve fascicles may be trimmed at this stage. Similarly, the distal stump of the nerve is explored and it is bread loaf to get good fascicles. And at this stage, we also try to explore the nerve and find its topography. So in this part, the lateral part would be the motor, and the medial and the anterior will be the sensory. And if we are doing a group fascicular repair, especially in cases where we need both motor and sensory function to be regained, we mark the site and then choose 1 fascicle for the motor and 2 which are larger ones for the sensory recovery. So in this case, we take the posterior suture first because it will be difficult to turn the nerve around. And the first suture fixes 2 fascicles together to the point which I have chosen to be the posterior most point. And once this is done, the nerve fascicles are aligned. We usually use a 9 or 10 suture and then stitch these 2 fascicles in place. We do not cauterize any bleeding which may occur from the distal stump because that will damage the fascicles also. Once the posterior suture is placed, then we use 2 additional sutures to reorient the rest of the fascicles. And we try to do an epiperineural repair when we are doing a group fascicular repair. So it aids in better orientation of these fascicles so that there is no cross reinnervation of sensory into motor fascicles and so on. An assistant usually irrigates the space so that we can have a better view and a better orientation for these nerve fascicles. Finally, the topmost or the anteriormost nerve fascicle is similarly repaired anteriorly with 2 sutures. And once the repair is complete, we may use additional fibrin glue to secure them in place. This is the final suture. And you can see once all the nerve fascicles have been repaired in place, the oozing from the nerve stumps also stops Now we focus our attention onto the proximal part, and one of the nerve fascicle which we have used for the motor, we mark it with ink and similarly keep it into place. And we also keep a look on the topography of the proximal median nerve. And the motor fascicle has to be repaired first, so it is oriented and fixed with the motor fascicles proximally. Again, we use the orienting stitch first and do a group fascicular repair. The first two sutures are placed on the circumference. Then we take up the next fascicle and suture it into place again also. And in cases where I'm doing a reconstruction for both motor and sensory fascicles, I tend to take a perineural suture between the two follicles and suture it with the perineurium on the medial side. So this prevents any, again, the cross innervation taking place between the axons of the two sides. So the axons are not misdirected. And if there is some bulging of the fascicle at this point, then we can always trim the extra amount of fascicles which is now projecting. Now the topmost sensory fascicle is kept and it is again sutured. Sometimes there can be discrepancy of the fascicles in the recipient and a donor side, and we should aim to utilize most of the fascicles that we have grafted. And the last suture is used to take care of any dead space or any buckling which may be occurring. Now, in cases where there is a proximal nerve involvement, we tend to need multiple donor grafts. And in these cases, I make use of a splint and weld technique in which multiple fascicles are put together using fibrin glue, and then their ends are trimmed to expose the fascicles. And now, in this case where there was a partial nerve injury, only 2 fascicles were required. So now we can easily proceed with doing a epineurial repair. You can see now we are not entering into the fascicles, we are only repairing the epineurium. After placing the anterior sutures, we move on to the posterior side. And I use a horizontal mattress suture in this place, an epineurial suture, to orient and simultaneously invert the epineurium also to prevent any buckling which may occur. Now you can see the suture has very well coopted both the fascicles to the distal stump of the nerve. Then we use a similar suture to do epineurial repair of the proximal end. And lastly, we use fibrin glue to secure the nerves in place. This glue usually seals in around 30 seconds. So after which we can take off the background. And after removing the background, we use the residual fibrin glue to eliminate the dead spaces so that we may not require to use any drains to cover the space. And this is the patient after completion of the surgery with the free flap in situ. Thank you so much for your patience being.
Nice illustration, Dr. Raja Tiwari.
Thank you.
Can you take questions later on? Okay.
Thank you.
May I invite Dr. Sumit Sinha for his present. May I invite Dr. Kuntal Kantidas for his presentation on intercostal musculointestinal transfer.
Dr. Kuntal Kandidas is presenting on an undercutting of rib in intercostal musculoskeletal nerve transfer.
Good evening, everyone. First of all, I'd like to thank the organizers for this opportunity. So I shall be talking about a common procedure that peripheral nerve surgeons do, that is intercostal to musculocutaneous transfer, but with a small technical modification, which I find useful in certain cases. As you all know, this is one of the favored options in pen brachial plexus injury, and it can neurotize the elbow as well as the shoulder, depending on what is our need. But one of the difficulties is its harvesting, and secondly, limited length of the donor nerve, and it can be a major roadblock. This is the standard technique that we do. We generally harvest 3, 4, 5 intercostal nerve. We make it into one, and the musculocutaneous nerve is divided as proximally as possible, and then they are co-opted in an adapted shoulder position. Now, there are certain problems, as you see. In order to gain length in the donor nerve, these are the two things that are normally done. Either the dissection is done too proximally, where the serratus digitations may be damaged, leading to fibrosis, or we have to dissect much distally, where the number of motor axons can be less. So the possible solutions in situations like this are rib retraction to bring out the hidden part of the intercostal nerve, simultaneous nerve counter traction with a loop, distal dissection, proximal dissection, as I said, and adducting the arm at the time of coaptation. But despite all this, we can sometimes have problems. So here I'm going to show you a video where the length of the donor was increased by a subtle modification in the standard technique that we utilize. This was a pan brachial plexus injury, and intercostal was utilized to neurotize musculocutaneous nerve. The dissection typically begins at the lower border of the rib, and we search for the intercostal nerve. I'm going to show harvesting of one nerve only for the sake of time. We can see that the intercostal nerve has been visualized. And once it is visualized, the second step is to confirm that it is a motor branch. Then it is taken into a loop. And utilizing traction counter traction, it is distally dissected. And as I said, in order to gain length, we have to go as distally as possible. Smaller branches which are going to the intercostal muscles may have to be divided for rerouting. But as I said, if we go very distally, we may lose the motor axons. As you can see here, some of the branches which are going into the intercostal muscle are being divided. And the nerve is subsequently freed from underneath underlying structures. And as you come proximally, this is the standard way. We generally hook up the rib, and then we resect the nerve. Here, all the 3 intercostal nerves have been divided distally, and they have been rerouted towards the axilla, as you see. But we felt that the length was insufficient. So next, what we did was we tried to create some space, additional space, by dividing, incising the fat over there. At the risk of future fibrosis. Then the incision was continued into the arm. We use a continuous incision. And just beneath the biceps brachii, the musculocutaneous nerve was found. It was similarly dissected by taking into a loop. And then it was dissected as proximally as possible. The entire MCN is utilized for this purpose. And as you see, still the length was not sufficient, and then anastomosis would have been under tension. So we did a small technical manipulation here. What we did was we undercut that portion of the rib. This can be done with a drill as well. It was done with a upcut. As neurosurgeons, this is common processes that we do. So what it does is, as we take out the lower third of the rib like this, additional length of the intercostal nerve can be mobilized because it lies deep beneath the rib. And this additional removal of bone can also shorten the path to the axilla. As you will see, this additional maneuver has given us a couple of centimeters of additional length, particularly the lowermost intercostal nerve. These 3 nerves are then made into one by utilizing glue, the welding technique. And the musculocutaneous nerve, which was dissected earlier, is divided as proximal as possible. As I said, these three intercostal nerves were made into one, joined into one, so that the sizes were matching. And when this new nerve is recreated, it is then brought close to the MCN with the arm in an adducted position. And coaptation is done with a combination of suture and glue. I generally do not take a lot of sutures, maybe 2 to 3. And the rest of the anastomosis is done with the help of glue. And of course, the arm is in adducted position and remains like that in the postoperative period. So this is how the anastomosis is done. And as the glue settles in, we can take out the background. So this is the final coaptation. So we have done this technique in a few patients. And as you see here, what this additional bone removal undercutting does is it mobilizes the nerve from underneath and it can shift the anastomosis closer to the target, which is always preferable. It gives additional length. There is less disruption of the serratus. The coaptation can be tensionless, and anastomosis, as I said, gets shifted to the target by a couple of centimeters, which is always desirable. Of course, it can come with some extra pain, potential pleural injury, and callus formation at the rib resection side, but we apply generous bone wax over there, and we haven't seen any complication arising thereof. And this technique has been published in British Journal of Neurosurgery. Thank you.
Excellent presentation, Dr. Kantar. We'll take the questions at the end of the session. Thank you. So now we invite Professor Sumit Sinha to deliver his talk to the video on carpal tunnel.
Hello. Okay, so this is I would say that this elementary video is the bread and butter of a peripheral nerve surgeon, because you will be seeing the cases for sure in some part of the career. And this is such a small operative exercise, but even if it is a small, can cause real problems with the patient if not done correctly. So certain basic steps if you follow, which I learned, of course, from my mentor and teacher, Professor Mehta, who has been here, which are absolutely crucial for the successful outcome of this surgery. So I will take you along for directly for the operative video. So before I start, this is the line that all of you have to understand, and give credence to, and it is especially important for this surgery. This is called as Kaplan's cardinal line. So this is drawn from the base of the thumb and the index finger space, and it goes parallel to the proximal palmar crease, and then it rests the medial end of this line rests on the hamate bone, which is the medialmost border of the transverse carpal ligament or the carpal tunnel. So one is this Kaplan's line. Another line is drawn perpendicular to this Kaplan's line, which runs from the ulnar border of the ring finger and then drops straight away on this Kaplan's line. And why this line, this intersection of these two lines is important is because the recurrent motor branch of the median nerve, it emerges from the carpal tunnel exactly at this point, or slightly radial to this point. So your cut on the carpal tunnel should not reach on this, because if you do that, then you would be probably damaging the recurrent motor branch of the median nerve with debilitating palsy of the thenar muscles in the post-op with the patient. So remember these surface marking drawings before you embark on the surgery. The incision is typically, it follows the two incisions are there, which are being described in the literature. Either one of them can be given. Either you follow the crease, the thenar crease, in a curve, slightly medial to that, slightly on the ulnar side of that. Don't be too much radial. Why so? Because if you are radial in your incision, then you will be probably ending up with damaging the superficial motor branch of the median nerve, which is very, very important. Because if you damage this branch, then your patient will be relieved of pain, but will complain of debilitating hypoesthesia on the thenar eminence. So these two take-home points are there. Preserve the motor branch, preserve the sensory branch by planning your incision. And your incision should be not on the radial side, but slightly on the ulnar side of the thenar crease. So having said that, incision, no use of cautery, sharp dissection, and then after you dissect the superficial fat, you come across the palmar aponeurosis. And cutting this palmar aponeurosis, you see the shining transverse ligaments of the transverse carpal ligament here. And then when you make a small nick over this, insert your number 1 dissector, and then cut with a sharp knife, number 11 knife, over this dissector. Take it as much proximal as possible. Another thing which I should mention here is, do not extend your incision into the proximal palmar crease or the distal palmar crease, because if you extend your skin incision to that, there are chances that you might end up again damaging the sensory branch of that median nerve. Also, and also, if you extend your straight incision into these creases, then the scar heals very badly. So if you have to take this incision into proximally, then what you have to do, you may end up with a zigzag incision at this place. So insert your number 1 dissector below the ligament, cut over this dissector very carefully, and take care to extend this dissector as proximal and as distal as possible to ensure complete opening of the ligament. And this is the end. When you insert your number 1, it goes in freely. You feel that there's a lot of space there. Now, the same thing done distally. Distally, more distally. Still, you see that number 1 is still not free. There is still a tightness over there. So you have to go as distal as possible. The deep palmar arch is 1 centimeter distal to the Kaplan's line. So you have to take care of that. Still, this is not free distally. I'm again inserting. There is a sense of constriction there. So it needs to be divided more. Not only this, you have to take care of the entire canal. Some people say that you have to dissect out the median nerve all around. Some additions there on the lateral and the medial aspect of the median nerve inside the canal. It has all been freed except for 1 point distally, which I will just now free it. And you see that as soon as it is cut, a lot of space has been created, and this is the end of the surgery. Now, this last step is the most important step in the cubital, in this carpal tunnel surgery, because if you don't do this, your patient will invariably come to you again for recurrence. The last step, which is very important in closing, when you suture that, take care, don't involve the ligament again in your sutures. Because if you do that, your surgery will be futile and it will be a reapproximation of the carpal ligament. Thank you so much.
Thank you, sir. Very nice presentation. And I call Dr. Rajesh Meena to show his video to make transfers.
Thank you, chairpersons, respected faculties, and my dear colleague. Today topic of my video presentation is SOMSEC procedure in brachial plexus palsy. It's more kind of an educational video. So as you all know, SOMSEC procedure is an intraplexal nerve transfer in which the donor nerve is now to the long head of the triceps and the recipient is the anterior branch of the axillary nerve, and we do it by the posterior approach, and it is used to restore function of the deltoid muscle, and it enables shoulder abduction and external rotation. So historically, Lurje was the first to describe this technique, in which he used triceps fascicle of the radial nerve to transfer to the axillary nerve. And Somsek described it by posterior approach in 7 patients. And this paper was published in 2003. The advantages of this approach is that no nerve graft is needed, and triceps motor activity is synergistic to the shoulder abduction and an external rotation, and it facilitates post-operative re-education of the deltoid. And it is proximal to the neuromuscular junction of the deltoid muscle, and it is expendable as the loss of the long head of the triceps muscles leaves a negligible deficit of function. And it is a pure motor donor nerve, and it has many axons and good size match. Why long head of the triceps is used? Because among the 3 head of the triceps, long head of the triceps plays the least important role in elbow extension. So its function can be compensated by the other 2 heads of the triceps or a teres major muscles. Regarding the axillary nerve, Zio et al. Divided into 3 parts, L1, which is above the subscapularis muscle, and on the subscapularis muscle and below the subscapularis muscle. Below the subscapularis muscle, it divides into 2 parts, lateral and the medial division. So the lateral or the anterior division supplies most of the deltoid muscle, that is anterior and medial, which is useful for the shoulder function and abduction. And the posterior or the medial part supplies it gives a cutaneous branch, and it supplies teres minor muscle. So anatomically, there are 2 spaces which we have to look out at the quadrangular space and the triangular space. So this is a video of the Somsek procedure. So this is a 20-year-old male, which is a history of road traffic accident and sustained left partial brachial plexus injury. Left shoulder abduction is 5 to 10 degree, and with elbow flexion is 4/5. And we plan left side brachial plexus injury. We position the patient in supine with our tray. This is an incision. We mark the acromion and we mark the lower border of the teres major muscle. And we give a longitudinal incision between the long and the lateral head of the triceps. So the dissection involves 2 parts, superficial dissection and the deep dissection. Superficial dissection, we have to trace the lateral cutaneous nerve of arm, and that will guide the posterior division, and it can be confirmed by gentle traction, which dimples the skin. Deep dissection, we have to develop a plane between the long and the lateral head of the triceps muscles by gentle finger dissection. So this is the orientation, cranial caudal, teres major muscle. These are the circumflex vessels, which we are dissecting out. And by gentle dissection, we will loop the circumflex vessels. Now we will dissect the axillary nerve branches. So we get 1 branch. So we do not know whether it is an anterior branch or the posterior branch. So the teres major muscle has been retracted by the suture, so I don't have to cut it. Further exploration, we are able to mobilize another branch. Now the whole of the axillary nerve is cleared out. And now we trace which is the posterior branch. So we further dissect to trace this is the posterior branch, and it will be going to the cutaneous nerve. And so we are definitely sure that this is the posterior branch. So this is the overview. This is now we go in the triangular space to mobilize the triceps and its branches to the long head of the triceps. And it was nerve stimulation was used to confirm further mobilization will now we have identified which is the anterior branch and the posterior branch. So we have cutting the anterior branch of the axillary nerve. We put a LIGA clip before cutting because it's very depth and there may be some troublesome bleeding, so it can be prevented. Now after that, we are freshening the nerve ends. So there is a good match between the donor and the recipient. Now we are doing the coaptation of the nerves using nylon 10 sutures. And fibrin glue is applied to augment the anastomosis. Thank you.
Nice presentation, Dr. Meena. Now I invite Dr. Suyesh Singh for his presentation on peripheral nerve schwannoma. Dr. Digvijay Singh Thakur for his presentation double Oberlin nerve transfer.
Good evening, respected faculty and respected chairpersons. I am Dr. Digvijay Singh Thakur. I am working as the AP in IGMC Shimla. I'll be presenting a video on double Oberlin nerve transfer. My mentors are Professor B. Indra Devi ma'am and Dr. P.S. Bhandari sir. The instruments that we use in our institute, a arm table, a Stimpod NMX nerve stimulator, a surgical loop 5X, operating microscope, TISL and Ethylon 90 suture. Indications for double Oberlin nerve transfer when there is lack of elbow flexion in a patient of brachial plexus injury, and the prerequisite before performing this procedure, there should be intact hand and wrist function. Now some important tips. First of all, the first nerve to be identified in this procedure is median nerve, and it is more superficial and it is lateral to the basallic vein. Ulnar nerve is deeper. It is usually medial to the basallic vein. And next nerve to be identified is the musculocutaneous nerve, which is on the medial surface of the biceps. Now, this is the relevant anatomy and exposure before proceeding for epineuritis. First of all, most medially we'll encounter the ulnar nerve, and after that, basallic vein. Lateral to it will be the median nerve. Lateral to it on the medial surface of biceps will be the musculocutaneous nerve, then the nerve to biceps and the nerve to brachialis. And before proceeding for epineuritis, the topography in the median nerve is such that the sensory fascicles are located in a lateral position and the motor fascicles are located in a medial position. The ulnar nerve topography is such that the flexor carpi ulnaris fascicles, they usually lie in the posterolateral aspect. Now we have a team, myself, which comprises of myself, Dr. Biplav, Dr. Akshay, plastic surgeon, Dr. Bhavya Thakur, and neuroanesthetist, Dr. Kunal Kumar Sharma. The patient had history of RSA 8 months back with elbow flexion 0/5, EMG showing no signs of renervation, and MRI showing C5, C6 avulsion with pseudomeningocele, and surgery planned was double Oberlin nerve transfer. As you can see in this video, the right elbow flexion of this patient is 0/5, and the left elbow flexion is MRC 5/5. And the prerequisite for this procedure, bilateral intact hand and wrist function is present. As you can see, there is also marked atrophy of the right biceps muscle when we compare to the left side. Now the position the patient lies supine with the arm abducted at 90 degrees on the table extension. The table extension should be wide enough so that you can rest your hand also on this while performing nerve anastomosis. And now the incision. The incision is on the medial border of the biceps from the axilla to 3 centimeter proximal to the antecubital fossa. After dissection and placement of self-retaining retractors, the first nerve that we encounter is the medial antebrachial cutaneous nerve. And as the dissection proceeds deeper, the median nerve is the first nerve to be identified, and second is the ulnar nerve, which is more deeper. Next nerve to be identified on the medial border of biceps is the musculocutaneous nerve, nerve to biceps. And we can also see this leash of vessels at the mid-humerus level. Usually at this level, nerve to biceps bifurcates. Now we do the tuck test for confirmation of lateral antebrachial cutaneous nerve, and we also identify the nerve to brachialis. So this is the relevant anatomy again. The ulnar nerve lies most medially, the median nerve, the nerve to brachialis, the nerve to biceps, and musculocutaneous nerve on the medial border of the biceps. After that, we proceed on electrical stimulation, and there was no response to stimulation on stimulating nerve to biceps and nerve to brachialis. After that, we proceed to epineurotomy and fascicle dissection of the ulnar nerve. Gentle dissection is done, and after that, ulnar nerve stimulation is done to identify the fascicles that supply the flexor carpi ulnaris and cut. They usually lie in the posterolateral aspect, and the fascicles that are supplying the intrinsic hand muscles are identified and spared. Next, we proceed on to the epineurotomy and fascicle dissection of the median nerve. Again, we use stimulation, and the fascicles supplying flexor digitorum superficialis are to be identified and cut. Next, the recipient's nerve to brachialis and biceps are to be cut as proximally as possible, and the donors, median nerve and ulnar nerve fascicle, are to be cut as distally as possible. After this, we take operating microscope, use a background, and use 9-0 suture to do anastomosis between the ulnar nerve fascicle and the nerve to biceps. And second anastomosis is done between the median nerve fascicle and the nerve to brachialis. Hand is well rested on the table to reduce tremor. After that, we use TISL to reinforce the anastomosis. And after that, wound closure is done in standard fashion. Postoperative care. The arm is immobilized in a shoulder sling for 3 weeks. Alternate day dressing is done. Suture removal at 14th day, and physiotherapy is done. Thank you.
Thank you for the nice talk, Dr. Digvijay. Any questions for any of the speakers, if anyone wants to comment or ask? I think if there are none, then we can close the session, and we have to proceed with the inaugural function followed by the GB meeting as well. Thank you.
Thank you very much, sir. We will now have the official inauguration.
A very good evening. Now, I would like to welcome the dignitaries on dais for the inaugural function. I would like to call upon our chief guest, Dr. Alok Agrawal, sir, Dean, AIIMS Raipur. Dr. Indira Devi, ma'am, President, Indian Society of Peripheral Nerve Surgery. Dr. Deepak Agrawal, sir, Secretary, Indian Society of Peripheral Nerve Surgery. Dr. Ajay Nagraj, sir, President, Chhattisgarh Association of Neuroscientists. Dr. Sanjay Sharma, sir, Vice President, Chhattisgarh Association of Neuroscientists. Dr. Anil Kumar Sharma, sir, Organizing Secretary, Indian Society of Peripheral Nerve Surgery Conference 2024.
Hello. Check. Check. Hello. Check. Hello. Check. Hello. Check. 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 Hello. Check. Hello.
Now, I would like to call all the dignitaries for the lamp lighting and Saraswati Vandana. So, ma'am, please come forward for the lamp lighting.
Thank you very much for this wonderful Saraswati Vandana. Now, I would like to call upon Dr. Anil Kumar Sharma, sir, Organizing Secretary, Ispnscon 2024, to address the gathering.
A very good evening and greetings. On behalf of organizing team, I welcome all the dignitaries on the dais. Our honorable chief guest, Dr. Alok Chand Agrawal, Dean, AIMS, Professor B. Indra Devi, my teacher and my mentor, and President of Indian Society of Peripheral Nerve Surgery, Dr. Deepak Agrawal, Secretary of Indian Society of Peripheral Nerve Surgery, Dr. Ajay Nagraj, President of Chhattisgarh Association of Neuroscientists, and Dr. Sanjay Sharma, Vice President of Chhattisgarh Association of Neuroscientists, and Dr. Samin Shah, Co-Organizing Secretary. So at the outset, I welcome all the participant and distinguished faculties and dignitaries to the Indian Society of Peripheral Nerve Surgery Conference 2024. You all have come all across the country and spare time to enjoy this academic feast related to peripheral nerve surgeries. I must, from core of my heart, I must thank all of you. We are grateful and we are thankful to Indian Society of Peripheral Nerve Surgery, Secretary Dr. Deepak Agrawal and President Dr. B. Indra Devi, and all executive members to giving and trusting us and giving this opportunity to organize this academic festival. So as far as peripheral nerve surgeries are concerned, so I would not say it's easy, but certainly it's less difficult as if we compare from other discipline of neurosurgery like cerebrovascular, skull base, complex skull base. So certainly it's less difficult, but I would not say it's easy. When I started the department, so there, as it was started from scratch, so there was no resources, there was no instrument, nothing was available at that time. So I borrowed some instrument, spinal instrument from orthopedic department, Dr. Alok sir, he agrees to share instrument with us, and that's how we could start spinal surgery. And spine surgery and peripheral nerve surgery were the only surgeries that I could do at that time for initial few months till we got equipment and other related infrastructure. So I would say because for peripheral nerve surgery, most of the time we need micro instrument and magnification device. That loop also works quite well most of the time. And I'm happy that we started long back, and many neurosurgeons who worked here as faculty, and now they have started this practice in their own setup. Some of us are here with us today, Dr. Vaibhav and Dr. Prasant, I can see. So I won't take much time. As already sessions are delayed, and it's long exhausting session from morning 8 a.m. to till it's already almost 7 now. So thank you all of you. And I'd like to thank all the sponsors also for this academic event. Now I would like to invite all the dignitaries for releasing of conference souvenir.
Now, I would like to call upon Dr. Deepak Agrawal, sir, Secretary, Indian Society of Peripheral Nerve Surgery, to address the gathering.
Dignitaries on the stage, Professor Agarwal, Dean, AIMS Raipur. We have Dr. Nagraj, President, Chhattisgarh Association of Neurosurgeons, a neuroscientist, and Dr. Sanjay Sharma, Vice President. Along with that, we have our own Madam, Dr. Indra Devi, as the President of Ispns, and Dr. Anil and Shaminder. And I would like to reflect on the progress we have made over the last few years as a society to reach this stage where, from negligible numbers, we have now almost a 400 member society from diverse specializations. And I think we have a long journey to go. And it is a true reflection of what interdisciplinary work can lead to in terms of learning from each other's specialities and using these learnings to improve your own specialty. So I'm really thankful for this academic feast, which was organized at a very short notice. And I think more than what I gave a lecture, it is the whole learning I came across. And I think that is the feeling which is shared by all of us. So I thank you again for this, for sitting here for so long and going through all the proceedings. Thank you so much.
Thank you so much, sir. I would request Dr. Indra Devi, ma'am, President, Indian Society of Peripheral Nerve Surgery, to please address the gathering.
Good evening and welcome. We are anyway halfway through the conference. We'll be completing it tomorrow. I thank each and every one of you for having taken time, trouble, and patience to come here and spend 3 days with us and share your experience and listen to us and also to share some memories. And the last 2 years as president has been quite encouraging and enjoyable. And we did a lot of things together with the EC members and with the able support of Dr. Deepak Agarwal, the president-elect, Dr. Hari, and the very extremely hardworking and devoted treasurer, Dr. Dr. Rajiv Sharma, who is unable to attend here for because of low backache. We all did a lot of things together, and then we were on a membership drive, and we could get plenty of members added to. And I thank all my junior colleagues and ex-residents and the current residents who had who could be persuaded to become members. And because the strength of a society is in its numbers. Together we can do a lot. And if it is just a society in name, for namesake, and then there are not enough inputs nor encouragement, that society cannot grow, nor can it contribute, nor can it sustain itself. So I would once again thank all of you, and thank you very much.
Thank you so much, ma'am. Now, I call upon Dr. Sanjay Sharma, Vice President, Chhattisgarh Association of Neuroscientists, to please address the gathering.
I welcome you all, and there is nothing more to add from my side. The only thing, learning is a lifelong process, and we have long been neglected this problem, which starts from a pediatric age, like a brachial plexus injury. Then we come across a post-injection palsy, and then the road traffic accident, leaving many disabled because of brachial plexus injury. I think we need a very close cooperation between a pediatrician, orthopedician, plastic surgeon, and neurosurgeon, and we shall move together to achieve this goal and alleviate the problems of mankind. Thank you.
Thank you so much, sir. I request Dr. Ajay Nagraj, sir, President, Chhattisgarh Association of Neuroscientists, to please address the gathering.
Respected dignitaries on the dais, respected delegates who have come from all over India, plastic surgeons and neurosurgeons, I welcome you on behalf of Chhattisgarh Association of Neuroscientists. It is a body which consists of neurologists, neurosurgeon, neuroanesthetist, and neuroradiologist. I am thankful to Dr. Anil, who has organized such a nice conference here under the guidance of Dr. Agarwal. And we have really learned so much from this conference. I am quite sure that my other colleagues in the Chhattisgarh have learned, which is this branch has been relatively negligent in this area. So now I'm quite sure that many young neurosurgeons and plastic surgeons will take up this branch and advance in this specialty. Thank you so much.
Thank you so much, sir. I request our chief guest, Dr. Alok Agrawal, sir, Dean, AIMS Raipur, to say a few words. Please, sir.
Respected President, Madam Dr. B. Indra Devi, Secretary, Professor Deepak Agrawal sir, Organizing Chairman, Dr. Anil Sharma, and Organizing Secretary, Dr. Shamendra, the senior most neurosurgeon of the city, and the President of CAN, Dr. Ajay Nagraj, and the senior most neurophysician in the city, and now the Vice President of CAN, Professor Dr. Sanjay Sharma sir. It is indeed a pleasure of being amongst you people who have taken the Herculean task of making people functional following a neurological illness or injury. As a convener for the Chhattisgarh and Bihar state from National Academy of Medical Sciences, I want to inform all of the neurosurgeons and neurophysicians that National Academy of Medical Sciences has changed its rules. So any person below 45 years of age, and if he has done MCH, he can become an associate fellow directly. And our state now has got 3 fellows. Our director, Professor Dr. Ajay Singh, myself, and Dr. Nigam, who is a dermatologist, very senior dermatologist of the city from the medical colleges. So this is a golden chance. National Academy has also changed the rules for becoming members. The MAMS degree comes for all MDMS people who have completed 5 years. And the fresh ones, they can also become associate members. So this is a chance for all of you to come into the national body and participate. Neurosurgery, a very specialized branch. We start our MBBS career by finding how to diagnose clinically a nerve injury. Maybe in post-graduation, we know how to confirm our diagnosis and what are the surgeries available. But then during MCH and the course of plastic surgery, MCH and neurosurgery, both are available in AIIMS Raipur with so many students working. The actual surgeries and the senior faculty who also knows the follow-ups. So it is really good. And Madam Indra, I am thankful and grateful to you that you thought AIIMS Raipur to be worthy for holding such a big conference where there are 318 members, maybe more than the state membership of many of the chapters. In the hall, there are many senior doctors sitting. Dr. Kishore Jha, Dr. Madharia, and many more who have made a very well name in the city. And I welcome you all also to this conference. Anil, I am proud of you. Thank you.
Thank you so much, sir. I would request our dignitaries to please felicitate our chief guest, Dr. Alok Agrawal, sir. I would like to call upon Dr. Deepak Agrawal, sir, for the announcement of Lifetime Achievement Award.
हाँ नहीं करो अरे तुम for this year ISPN Lifetime Achievement Award we have 2024 is being given to Professor V.S. Mehta. Professor Mehta received his education from SMS Jaipur College Jaipur and MCH from AIMS. He continued to become faculty at AIMS, where he subsequently became the head and chief neurosciences center at AIMS. He is a pioneer in the surgery for brachial plexus injuries in India and has always encouraged this specialty. He has received multiple awards, as you can see from the list, which finally culminated in him getting the Padma Shri in 2005 from the Government of India. I call upon Professor Mehta to please come on the stage and award him the multifaceted, multi-talented Padma Shri Professor Dr. V.S. Mehta, the ISPNS 2024 Lifetime Achievement Award. I would request Madam Dr. Indra Devi and Dean Professor Agrawal to kindly felicitate Professor V.S. Mehta.
Sir, I would request Padma Shri Dr. V.S. Mehta, sir, to please say a few words.
Well, thank you very much. Please sit down. Please sit down. Thank you, everyone on the dais, Dr. Indra Devi, Dr. Ajay Agarwal, Dr. Deepak Agarwal, Dr. Anil. It's really an honor to receive this Lifetime Achievement Award from the specialty which I think the brachial plexus injuries, which initially I started as early as in 1982. And it started like when Dr. Mazid Sami was visiting us in 1982, he operated on a brachial plexus injury and he just opened and closed it. And then next day after the conference, the Dr. Banerjee, who is my teacher, he just told me that, Dr. Mehta, why don't you start operating on brachial plexus injuries? So I started looking for the cases, and with great difficulty in 2 years, I was able to operate on 3 cases. In next 5 years, we were able to operate 25 cases. And then it started like that every year we were operating about 180 to 200 cases in a year at All India Institute. And then it started that, well, how can I continue operate on 180 cases a year? So we tried to persuade the junior faculty to start this. And then there was a boy called as Manish Sharma, who was then MCH student and joined as a faculty. And that was his, in fact, thesis topic also. So he took an interest and he was doing, but he soon left the AIMS. And then Dr. Sumit was there. And so he took a keen interest, and then he continued to do this brachial plexus injuries. And as you know, then it started spreading all over the country. And I still feel, as everybody is saying, that still a lot of neurosurgeon, plastic surgeons are not interested because the results comes very late. But I can assure you that if you choose cases correctly and do surgery properly, every case will improve, whether it is partial or complete. But it's only those cases which are not good, which are not done in time or not done properly. But as the conference goes on, as the education goes on, this will certainly improve and everybody will have good result, no question about it. So more and more people should take interest in it. And I think it's, as everybody had said, it's a very demanding specialty. And I hope that everyone takes interest and more this people start doing this specialty. Thank you very much.
Thank you so much, sir, for your blessings. I would like to call upon Dr. Shamin Sahu, sir, Organizing Secretary, for the final vote of thanks.
Good evening to all of you and happy Makar Sankranti. Now we have come to end of an exhaustive academic session today. I would like to thanks from the organizing secretary and organizing committee to our director sir, Dr. Ajay Rai sir, our dean sir, Dr. Alok Chandra Agrawal sir, our teachers, seniors, mentors, residents, our sponsors, local Chhattisgarh Association of Neuroscientists members, our event organizers, GetSet event organizers, and our staff, nursing officers, who has helped us to organize this event and this session today. Now I will request everyone to rise for the national anthem.
नायक जयति भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड़ उत्कल बंगा हिमाचल यमुना गंगा उत्कल जलधि तरंगा शुभ नामे जागे तब शुभ आशीष मांगे गाहे तब जय गाथा जय गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
Thank you very much for this national anthem. Now we will have a group photo. I will request all of you to come to the stage for the group photo. After group photo, I would like to request the Ispns members to stay back for the GV meeting, and rest of all us will join for the gala dinner at 8 o'clock at Piccadilly. Please